रेड होनी चाहिए ग्रीन? Good morning, delegates. Now we are going to start second day of our scientific session. First, I would call Dr. Shabi Sharma for paper presentation.
For oral paper presentation, I would like to invite Dr. Chavi Sharma, who will be presenting on the topic Clinical Spectrum and the Predictors of Early Mortality in Patients with Paraquat Intoxication.
A very good morning to one and all present here. I'm here to present a presentation on the topic Clinical Spectrum and the Predictors of Early Mortality in Patients with Paraquat Intoxication. Introduction. Paraquat is a dimethyl bipyridinium dichloride compound. It is a widely used herbicide and a suicidal agent in developing Asian countries. Estimated annual incidence of paraquat intoxication is about 2,000 per year, with a mortality rate of 60 to 70%. Minimal lethal dose is 30 mg per kg, with no specific antidote. Primary cause of mortality in patients with paraquat intoxication is respiratory failure due to the oxidative insult to the alveolar epithelium and the resulting fibrosis or ARDS. Severity, the paraquat intoxication can be mild or with presenting as oral irritation and GI upset, moderate with ARF, and severe, which involves acute hepatitis followed by pneumonitis or pulmonary fibrosis and death within 2 to 3 days. This is the mechanism of action of paraquat with generation of superoxide anions, which leads to formation of more toxic reactive oxygen species like hydrogen peroxide and hydroxyl radicals, and the oxidation of cellular NADPH and disruption of important NADPH requiring biochemical processes. Material and methods, study design, both retrospective and prospective. Study setting, Department of Medicine, Guru Gobind Singh Medical College and Hospital, Faridkot. Study period of 2 years and 6 months. Sample size of 18 patients with only 1 survivor. Inclusion criteria, patient presenting with acute paraquat intoxication. Exclusion criteria, patient with a history of serious chronic diseases like heart, liver, kidney, and lung. Patients of paraquat intoxication combined with other drug poisoning. Results, the most common presenting symptom was breathlessness in such patients, followed by jaundice and decreased urine output. Oral ulcers and paraquat tongue was seen in about 50% of the patients. Involved in the study were male. Biochemical investigations. This is indicative of LFTs and RFTs. A mean of all of these is indicated. Deranged LFTs were noted in 66.65% of the patients. Chest X-ray suggestive of parenchymal infiltrates in 44.4% of the patients, with consolidation in 27.7% of the patients, and normal X-ray in just 6%. ABG revealed metabolic acidosis and respiratory acidosis. Respiratory involvement was are indicated as follows, with the respiratory failure occurring in 66. The results suggest that there is no as such single marker of early mortality except the dose of paraquat ingested. SOFA score can be used as marker of early mortality as it includes the variables from respiratory and hepatorenal involvement as well. It is indicated that in patients with early mortality, SOFA score was higher as compared to the patients with late mortality. Also, eGFR can also be used as the marker for early mortality. Conclusion, our data demonstrates that both SOFA and eGFR, which are based on the extent of multiple organ failure, can help in predicting early mortality in paraquat poisoning. Nevertheless, the retrospective nature of the study, the small patient sample, and the short follow-up time limits the certainty of our conclusions. Thank you.
Test for blood level estimation in of paraquat is available or not available?
So just the ABG reports of the patients was collected and data was and hence summarized, which revealed metabolic acidosis and respiratory acidosis. Reports are not available.
Paraquatemia is a good predictor for paraquat outcome.
Hello. Any data regarding the amount of paraquat ingested in different patients?
Sir?
Data regarding the volume amount of paraquat ingested in different patients and its relation to mortality and morbidity.
So it was noted in the study that the more the amount of dose ingested, the more is the mortality in the patients. And hence the conclusion that minimal lethal dose is 30 ml kg in these patients.
It's not 30 ml, 30 milligram.
30 ml.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, ma'am. For the next oral paper presentation, I am going to invite Ame Makhija, who is going to speak on the topic role of serum ferritin in dengue and its correlation with disease severity.
Good morning to one and all present here. Today I am Dr. Amam Makhija is here to present my paper of role of serum ferritin in dengue and its correlation with disease severity. Dengue fever is an important cause of febrile illness in the tropical and subtropical areas, and approximately 1 billion cases of dengue fever are reported according to WHO. It is a mosquito-borne viral disease and transmitted by Aedes mosquito, mainly Aedes aegypti. The dengue serotypes detected in India is mostly dengue 1 and dengue 2. Ferritin. Ferritin is an acute phase reactant and expressed by cells of reticoendothelial cell system in response to infection or inflammation. Hyperferritinemia was found to be associated with severity of dengue fever in terms of increased PEG cell volume and decreased platelet in adult patients. It is also associated with immune activation and coagulation disturbances. Aims and objectives: to study the serum ferritin level in dengue fever and to study the correlation between serum ferritin level and severity of dengue fever. Materials and method: study area. The study was conducted among 50 dengue patients, mean age of 35 plus minus 10 years in MMISR Mulana from the October 2020 to July 21. Inclusion criteria: patient was confirmed NS1 positive or IgM antibody positive with age 35 plus minus 10 years. Exclusion criteria: all the exclusion like unknown cause of fever, pregnancy, liver dysfunction, blood coagulopathy, mixed infections, patient on heparin, aspirin, cardiac patients, thyroid dysfunction, kidney dysfunction, patient with qualitative and quantitative platelet disorders. Data statistically analyzed by IBM SPS static software. The charts the significance between serum ferritin level and platelets. The patient out of the total 50 patients, the hyperferritinemia with thrombocytopenia was seen in 17 patients, with no thrombocytopenia in 11, and there are patients with no hyperferritinemia but thrombocytopenia is 16, and with no thrombocytopenia is 6. Significance between serum ferritin level and PCV: hyperferritinemia with increased PCV is seen in 16 patients, hyperferritinemia with normal PCV in 12, and no hyperferritinemia with increased PCV in 14 patients, and no hyperferritinemia in normal PCV in 8 patients. P-value is less than 0.1 and statistically signified. Significance between serum ferritin level and platelets. In current study included 50 dengue patients with confirmed NS1 positive or positive IgM antibodies. Out of the 50 patients, 28 patients showed high serum ferritin level with mean of 1350, and whereas 22 had normal mean serum ferritin level with mean of 120 to 50, that is within normal range. There was significant increase in PCV observed in 16 patients who also developed hyperferritinemia, and 34%, that is 17 patients out of 50 showed thrombocytopenia with increased ferritin level. According to my discussion, overall it is said that 28 patients had high serum ferritin levels significantly associated with thrombocytopenia in 17 patients and raised PCV in 16 patients, which is statistically signified, and mean serum ferritin was found significantly higher in patients with dengue. Dengue fever is a dynamic febrile illness that can range from a mild self-limiting form to other end of the spectrum, with ranges from plasma leakage, shock syndrome, and hemorrhagic fever, multi-organ dysfunction syndrome. The findings are consistent with increased level of ferritin associated with severe disease and a pro-inflammatory cytokine profile. Ferritin is an acute phase reactant, and a significant amount is produced by monocytes, macrophages, and hepatic cells. It has been shown that synthesis of ferritin can be induced by cytokines and iron. In the earlier cohort studies from Aruba, increased concentration of ferritin were significantly associated with a confirmed diagnosis and viremia. The association of thrombocytopenia with dengue infection has been approved with significance, a total of 34% in thrombocytopenia. This is accordance with a study done by M. Anuradha that showed thrombocytopenia in 89% of the patients. Hematocrit monitoring is used to evaluate the degree of plasma leakage and to determine the therapeutic intervention is detected. The patient can be used IV fluids as per the hematocrit level. The increase in hematocrit in dengue is due to hemoconcentration attributed to plasma leakage induced by cytokine-mediated increase in vascular permeability and damage to vascular endothelium. The results of current study correlate with the study done by Joshi, showed 55% of cases with hematocrit more than 40%. The conclusion, it is concluded that a higher prevalence of hyperferritinemia was found in dengue patients along with thrombocytopenia and raised PCV. Thus, hyperferritinemia is associated with thrombocytopenia and elevated PCV, and such patients may require a careful monitoring. A raised serum ferritin level was found significantly associated with disease severity. The serum ferritin evaluated in dengue could possibly end clinical judgment and prompt early resuscitation, which in turn could be useful in avoiding undue complications. Thank you.
Hello. Which confirmatory tests were used to diagnose dengue?
Sir, the gold standard is virus isolation. It can be done in the high-end lab. We use the dengue antibody detection, dengue ELISA we can use, and virus isolation is the gold standard.
Which you used in your study?
Sir, NS1 and IgM.
Rapid car test?
Sir, I have rapid cast test. Yes.
It's not the confirmatory test.
Yes, sir.
Dr. Makiza, what made you to think to do a study for ferritin levels in dengue fever, since we all know the high ferritin levels are in all inflammatory conditions, the ferritin level will be high anyway. So how you can correlate that it is because of dengue fever?
Sir, in the studies done by Joshi, in that it shows that in certain fever other than dengue, hyperferritinemia is not severely risked. But in few studies, it has been shown that serum ferritin increase is associated with dengue in most of the cases.
Okay.
So,
Thank you.
Have you studied the relationship of serum ferritin level with the complications?
Sir, complications, yes, sir. There is increase in the patient with higher ferritin level, with more than like the normal range. We have in my study, I have taken 30 to 300, and in the patients which have increased more than 1,000, the severity is there. The that mortality is more in patients with high ferritin level.
Because it has been compared with PCV and platelet count. Comparison has been done.
Yes, sir.
Of serum ferritin level with PCV and
Serum ferritin level with PCV
level.
and hematocrit level and platelet level also.
With the clinical outcome.
Clinical outcome, sir, studies has been done, and clinically patient has the poor prognosis.
Thank you.
Thank you. Thank you.
Thank you, sir.
For the next oral presentation, I would like to invite Dr. Devinder Pal Singh, who will be presenting on the topic hyperbilirubinemia, a diagnostic tool for acute appendicitis and its complication. You will be provided with 10 minutes. A bell will be ringing at 5 minutes, after which is followed by 8 minutes.
Good morning, everyone. I, Dr. Devinder Pal Singh, presenting the case paper presentation of a hyperbilirubinemia, a diagnostic tool for the acute appendicitis and its complications. The acute appendicitis is the most common general surgical emergency, and early intervention improves the outcome. The most of the patients are presenting with the Murphy triads, which includes abdominal pain, nausea, vomiting. The diagnosis of the acute appendicitis in clinical practice is done by blood investigation like CBC, CRP, and the ultrasound, CT scan. The various scoring system like modified Alvarado score, the Tzanki score, RISPA score is used in the literature. Uh, the various pathologies like fecolith, parasite infection, and the uh, and the and the infections causes a luminal obstruction which promotes the gram-negative bacterial multiplication and the continuous mucus secretion, which leads to the luminal obstruction, which further leads to the lymphatic and the venous drainage affected. It leads to the appendicular perforation or gangrene. The pathophysiology of the hyperbilirubinemia in the appendicitis is best understood by bacterial transmigration and the cytokines released by the bacteria, which leads to the endotoxemia and the bacteremia, which interfere the biliary excretion, which causes the hyperbilirubinemia. Aims and objective of the study is to evaluate the role of the hyperbilirubinemia as a potential marker for the diagnosis of the acute appendicitis and to evaluate its role in complication. Material and methods. The study involves a prospective study involving the 50 consenting case over the period of the 3 years, including the patients of the 15-year or above. The patient having liver disease and immunocompromised are excluded from the study. Result. The hyperbilirubinemia is found in 42 patients, which is roughly 84% of the patient, whereas 8 patients are having the normal bilirubin. The mean total serum bilirubin is 2.6. The mean bilirubin with the acute appendicitis was 1.6 milligram per deciliter, whereas in the patient having the gangrenous or appendicular perforation, the mean serum bilirubin was 1.9. The specificity of the study was 83% in percentage of the patient having the hyperbilirubinemia in acute appendicitis and the gangrenous and the appendicular perforation, whereas the specificity of the study is 84%. The positive prediction value is 85%. Discussion. Hyperbilirubinemia is found in 84% of the patient with appendicitis in our study, whereas Strada ETL study has found it is 38% of the patient having the hyperbilirubinemia. The mean total serum bilirubin was 2.6, which was consistent with the study conducted by the Salim Khan, where the average level of the serum bilirubin was found to be 2.38. The mean bilirubin in our study diagnosed with the gangrenous and the appendicular perforation was 1.6 milligram per deciliter, which was higher than the acute appendicitis mean bilirubin found in the SAND study, which was 1.6. The sensitivity and the specificity in our study having patients having the acute appendicitis and appendicular perforation is 83% and 84%, whereas the positive and the negative prediction value are 85 and 12.5% respectively. The sensitivity and the specificity found in the study by SAND et al. Is 76 and 86%. Conclusion. The level of total serum bilirubin is having high significance in aiding the diagnosis of acute appendicitis. Higher total serum bilirubin is having a positive prediction value for the diagnosis of the gangrenous and appendicular perforation.
Thank you. See, these studies have been done in the past also. Any acute emergency, abdominal emergency, having portal sepsis will have high bilirubin.
Yes, sir.
So in that matter, you see, sometimes you see even acute appendicitis, for that matter, any other emergency, I mean, it becomes very difficult. appendicitis at times becomes even difficult to diagnose, even with the investigations.
हाँ जी.
Sometimes it is more of a clinical diagnosis than with investigations.
Yes, sir.
So I'm just to see bilirubin, whether how much is associated with the acute appendicitis. Because studies have been done in the past also, where they still say because of portal sepsis there's an increase in the bilirubin level. But that probably will happen with most of the emergencies in the abdomen.
Sir, the patient having the liver disease and immunocompromised are already excluded out.
No, I'm not saying they are already excluded.
हाँ जी, sir.
I'm saying portal sepsis because of the acute infection, you see. That's why your bilirubin is high.
हाँ जी. But sir, the study is conducted in only elective cases, not on emergency cases.
I think probably we need more studies, you see, to make it more sort of a documentary or evidence-based, something like that.
Thank you.
Thank you, sir. Now I'm going to invite Dr. Baljinder Kumar, who will be presenting on the topic prevalence of asymptomatic ischemic heart disease among type 2 diabetes mellitus patients, a hospital-based observational study. 5 minutes will be given for the presentation and 5 minutes for questionnaire.
Good morning to all. I am Dr. Baljinder Kumar, Junior Resident, Guru Gobind Singh Medical College, Faridkot. My paper presentation was prevalence of asymptomatic ischemic heart disease among the type 2 diabetic mellitus patient, hospital-based observation study. Introduction: cardiovascular disease contribute to mortality in 70 to 80% of diabetes patients. Patients suffering from diabetes have 4 times greater risk of coronary artery disease when compared to non-diabetics. Diabetic patients may not exhibit the classical symptom of angina because of the prevalence of the neuropathy in the thoracic nerve fibers, and this is referred to as a silent asthenia. This study aimed at studying the prevalence and clinical factor associated with the silent myocardial ischemia as diagnosed by the TMT among type 2 diabetics who had no previous history or symptom of cardiovascular diseases. Methodology: the hospital-based descriptive study was conducted at the GGS College of Hospital and Faridkot, Punjab. Inclusion criteria: Punjab with patient with type 2 diabetic mellitus as per the ADA criteria, age 35 to 65 years of the any sex with any duration of the diabetes mellitus without clinical evidence of ischemic heart disease were enrolled for the study. Exclusion criteria: subject who were known to have ischemic heart disease, valvular heart disease, cardiomyopathy, congenital heart disease, pericardial diseases. Patient who had contraindication to undergo exercise treadmill test were excluded. A total number of 180 asymptomatic type 2 diabetes mellitus patients without clinical evidence of ischemic heart disease attending outpatient and inpatient department were enrolled. Data collection procedure: all the subject underwent detailed history with emphasis on history of risk factor like hypertension, family history of IHD, dyslipidemia, lifestyle, duration of type 2 diabetes mellitus. Personal history of substance abuse was taken along with through the clinical examination with BMI BP monitoring. Lab investigation include CBC, FBS, HbA1c, RFT, lipid profile, ECG were done. All the subject underwent treadmill testing performed in the RMS TMT Mark II as per the standard Bruce protocols. ECG was recorded before, during and after the exercise on the treadmill. The workload was increased by increasing speed or by grade, and the ischemic STT response was defined as flat or downsloping depression in the ST segment more than 0.1 millivolt below the baseline and lasting longer than 0.08 seconds. Negative exercise test in which target heart rate was not achieved, that is 80% of maximum predicted heart rate for the age and sex, was considered non-diagnostic. Result: mean age of study of subject was 50 plus 8.97 years, and 63% were male and 36% were females. Exercise TMT was positive in the 43 out of 180 subjects. Uh, this shows that total number of subject were 180 and positive finding were found in 43 subjects only. Proportion of exercise treadmill test positive was significantly higher in the subject age more than 60 year as compared to the age less than 40 years, uh, or 41 to 50 year, 51 to 60 years. Uh, and the percentages are similar, and 5.71 and 12.73 and 28.81% respectively. It was statistically significant with the p-value less than 0.001. Association with the age, as already said in the previous slide, with the exercise age less than 40 years age, showing two subject only positive for the treadmill test. 41 to 57 subject were positive, and 51 to 60, 17 subject were positive, and more than 60 there are 17%, 17 subject were positive, and p values 0.001, less than 0.001. Proportion of positive exercise treadmill test was significantly higher in the with the BMI that is more than 30, or as compared to 25 to 29.9 overweight, and 18.5 to 24.9, that is in normal range. Association of body mass index with the similarly in the previous slide, like BMI 18.5 to 24.9, showing only in four subject positive for the treadmill test, and similarly showing that in the overweight patients 25 to 29.9, showing 37 subject were positive for the treadmill test. Proportion of the exercise treadmill test was significantly higher in 11 to 15 years as compared to less than 15 year of the duration, and 6 to 10 years of the durations. Association of, similarly, the slide shows that the association of duration of the diabetes and the subject positive for the exercise treadmill test in the 6 to 10 year of the duration, 18 subject were positive, and in on 11 to 15 year of the duration, 13 subject were positive for the treadmill test, and p value is less than 0.001. Proportion of the exercise treadmill test for significantly higher in subject with a family history of IHD, or as compared to those without family history of IHD. The slide showing that in India, family history was positive, and showing as 19 subjects were positive for the treadmill test. As this HB1C in a positive exercise treadmill test was 10, which was significantly higher as compared to the negative exercise treadmill test, showing the lower level of HB1C. Similarly, slides. Proportion of exercise treadmill test was significantly higher in the dyslipidemia patient, and hypertension patient, and the alcohol used. Distribution of the exercise treadmill test
Please hurry up. Your time is up. Already you are exceeding the time. Then there will be no question answer sessions. Please. It is request to all the presenters that please stick to the time. It is 5 to 6 minutes for presentation and 4 to 5 minutes for judges' question answers. If you exceed the times, there will be no question answers. So what is the use of presentation? Please.
Conclusions. Determine silent myocardial ischemia is a diabetic patient is important due to the high morbidity and mortality of IHD in the diabetes patient. The study of consisted two aspects to assess the prevalence of silent myocardial ischemia in the asymptomatic patient with the diabetes mellitus, and assessment of the clinical predictors of silent myocardial ischemia in these patients. Duration of diabetes mellitus, dyslipidemia, glycosylate HB, BMI, hypertension, family history of diabetes mellitus are strong clinical predictor of silent myocardial ischemia. Longer the duration of the diabetes mellitus, greater the risk of silent myocardial ischemia. Dyslipidemia was found to be more in the diabetes who had greater prevalence of the silent myocardial ischemia on TMT. HbA1c levels were found to be more in the diabetics who have had greater prevalence in silent myocardial ischemia on the TMT. Based on this, we have recommended routine screening asymptomatic diabetic patient with a non-invasive testing, which was exercise treadmill test. The screening of the early myocardial ischemia help in preventing the worsening of the cardiac disease, especially in the high-risk groups who had family history of cardiovascular deaths. Thank you.
I think it is proved beyond doubt that diabetes per se, you see, all those patients with diabetes, they do have asymptomatic ischemic heart disease.
Yes, sir.
If we investigate them, you see. So probably again, suggestion is that all diabetics periodically, maybe once in a year, you see, if the duration is short, or if the duration of diabetes is long, you see, probably maybe in every 6 months they should go for their complete cardiac checkup, you see, even if they are asymptomatic. That's probably the message or the lesson from whatever we have studied so far. The other thing is, you see, as far as the duration, probably the controlling of diabetes. If it is uncontrolled, probably you have more chances of having asymptomatic control.
And
Especially in cases where there is other risk factor like dyslipidemia and smokers, family history, other risk factors of getting coronary artery disease. In those cases, TMT is more advisable.
Any data regarding the level of hyperglycemia in your study?
sir, not mentioned.
Thank you.
Thank you, sir. For the next presentation, I would like to invite uh, Dr. Hargun Singh, who will be presenting on the topic acute kidney injury in dengue fever. You will be provided 5 minutes for the presentation and 5 minutes for questionnaire.
Good morning. Dengue fever is amongst the most cardinal arthropod-borne infection among humans. 50 million positive infections occur each year, out of which 500,000 patients of dengue develop hemorrhagic fever. Dengue fever outbreaks have outstretched more or less 120 nations. Numerous patients are affected in India as well. Acute kidney injury is so far well-studied dengue complication. Renal abnormalities, though not common, are AKI, proteinuria, glomerulonephritis, hemolytic uremic syndrome, which is considered complication of the disease. Furthermore, when given an insight, there is only few cases reported and also few literature. There are many timely epidemics of dengue infection and limited database of these, including renal systemic effects. The study was planned to estimate the prevalence of acute kidney injury in dengue fever. A study was done in Department of General Medicine of Hospital Ambala, where NS1 and IgM was performed, and 120 patients were shortlisted. Patients fulfilling the inclusion criteria were enrolled based on the convenient sampling. Patient with clinical suspicion of dengue fever underwent NS1 and IgM studies and included in the study. Individuals with known diabetic nephropathy, hypertensive nephropathy, chronic kidney disease, infectious diseases like malaria, enteric fever were excluded. Those who were eligible were briefed about the nature of the study and enrolled in. A thorough general physical examination was conducted, and all these findings were noted on a pre-designed and preset performer. Some of the common features noted, fever being the symptom in 100% of the patients. Other symptoms include, second most common being myalgias, vomiting, headache, cough, rash, dyspnea, joint pains, and multiple others. Investigations done were CBC, PT-INR, SGOT-PT, serum electrolytes, urea, creat, and on the basis of Aiken criteria, that is, if the serum creat was more than 0.3 milligram deciliter or more 0.3 milligram deciliter rise or more than 50% rise from the baseline in less than 48 hours, or a persistent low urine output of 0.5 ml per kg per hour for more than 6 hours were labeled as AKI. These evaluations were done, and variables like age, sex, severity of dengue were also noted. Data was obtained and tabulated, and p-value was less than 0.05%. Results, during the study period, total 135 adults were presented with dengue, out of which 120 were selected, depending on the inclusion criteria. Out of which it was found out that during the analysis, majority of the patients were male, 57%, and 42% females who were suffering from dengue, and the age group was 31 to 50 years, and following less than 30 years, it was 30%. Mean age was 42 years with a deviation of 16.28%, and median age was 42 years. When considered, fever was present in 100% of the patients. General condition, petechial hemorrhages, rashes were noted. Majority of the patients, 79% show normal X-ray with pleural effusion in 14% and ARDSN in 8.3% and ground glass appearance in 1.7%. The diagnosis of AKI with dengue was observed with 27.5% of the patient. Out of this 27.5%, 83% of the patients were discharged and got better. Mortality was 16.7% of the patients. When AKI is associated with 6, the applied statistics show that total 33 AKI associated patients, 9 were females, whereas 24 were males. Similarly, AKI associated with age, showing the majority of age group lie between 30 to 50 years of age. The incidence of dengue is equal in males and females. However, in present study, males, 69 male, 57.5% were more than 51 females, 42.5%, with male to female ratio of 1.35% to 1.35 to 1. Laboratory parameters also included, and it was found out that less than 20,000 platelet was in 14% patients, and in the range of 20,000 to 49,000, it was 47% patients. So to conclude, dengue affects people of all ages. Our study suggests that dengue fever was widely prevalent amongst the young age. A retrospective study to review the changing epidemiology between 2002 to 2008 also reported similar results, and similar studies were conducted in AIMS, which extracted the similar results. The creatinine levels at admission range between 0.1 to as high as 9.69. Serum creatinine levels of 1.27 with standard deviation of 1.29 was noted. And however, based on AKI criteria, 33 out of 120 patients developed AKI. Hence, the prevalence of AKI in dengue is 27.5%. Thank you.
How many patients of acute renal injury were hemodynamically unstable at presentation or during stay, hospital stay?
Out of
because one of the main cause that is visible, that is hemodynamical instability.
Yes, sir. Out of 120 patients, it was found out around 30 patients were hemodynamically unstable, and it was more commonly seen that the AKI occurrence was more common with hemodynamically unstable patients.
It has been mentioned.
I'm happy that since morning this is the second lecture on dengue sort of fever. So that means you can very well imagine the importance of dengue fever in our area and this. I mean, it is around the corner even now. You see, starting from the month of August till probably November, December, you see, we have a lot of patients coming with the dengue fever. Yes. So I think people should be more aware of all the complications and the problems that coming with dengue fever. Yes. Thank you very much.
Yes.
But if you make your presentation in dotted presentation as salient features, that gives a lot of weightage to your presentation. Yes. So that's my suggestion for your future, because you'll be presenting a lot of, I think in future. So just keep it in mind. Thank you.
Thank you.
Thank you, sir. For the next oral paper presentation, I would like to invite Dr. Harleen Kaur Gill, who will be presenting on the topic Spectrum of Fungal Isolates from various clinical specimens. 5 minutes will be given for the presentation and 5 minutes for the questionnaire.
Good morning, everyone. My topic for presentation is spectrum of fungal isolates from various clinical specimens. Fungal isolates are not notifiable infections like viral, bacterial, or parasitic diseases. Hence, these are not given much attention. They can be mild and only superficial or cutaneous or may cause life-threatening systemic illnesses. In the earlier years, yeasts are the most common causative agents of invasive mycosis. But nowadays, molds, especially the Aspergillus species, have become frequent in certain groups of patients suffering from cancer or prolonged neutropenia and in patients with solid organ transplantation. Aspergillus, which is transmitted through inhalation, is present in the environment ubiquitously. In all pulmonary syndromes, Aspergillus fumigatus is the most common species, but Aspergillus flavus is also causing various forms of allergic rhinosinusitis, postoperative aspergillosis, and fungal keratitis. Candiduria. The presence of Candida species in urine is caused by various predisposing factors such as long stays at hospital, urinary indwelling catheters, immunosuppressive therapy in immunocompromised patients, abnormality in urinary tract, renal transplantation, broad spectrum antibacterial therapy, and hemodialysis. Mucormycosis or zygomycosis is a serious fungal disease caused by a group of molds called mucormycetes, which includes Rhizopus species. Rhizopus oryzae is responsible for 60% cases of mucormycosis in humans. Mucor species, Rhizomucor species, Syncephalastrum species, and Apophysomyces species. The present study is carried out for finding out the spectrum of fungal isolates from various clinical specimens in our hospital. Material and methods. The study was conducted at Department of Microbiology, Guru Gobind Singh Medical College and Hospital, Faridkot for a period of 6 months. Various clinical specimens received in the lab were plugged hair samples, nail clippings, skin and scalp scrapings, swabs, tissues, pus, sterile body fluids, sputum, and corneal scrapings. Total 610 samples were received in the lab, which were processed by direct microscopy and culture. The samples were analyzed by using 40% KOH for nail specimens and 10% KOH for other samples. For the CSF specimens, India ink preparation and wet mount was done. To identify the yeast infection, gram staining was done. For the fungal culture, all the samples were inoculated on 2 different sets of SDA culture media. One set of SDA or Sabouraud's dextrose agar without antibiotics, and the second set of SDA with antibiotics, which are chloramphenicol and cycloheximide. The culture tubes were incubated at 25 degrees Celsius and 37 degrees Celsius for 4 weeks. These were examined daily for the first week and twice a week for subsequent period. So this image shows the KOH preparation, which is showing broad aseptate hyphae under high power. This image shows KOH preparation showing hyaline septate hyphae under high power. This is SDA showing white, creamy yeast-like colonies. SDA showing SDA without cycloheximide showing colonies of mucor species. Lactophenol cotton blue preparation, also known as LCB, showing ribbon-like hyphae with nodal rhizoids of Rhizopus species. LCB showing septate hyphae with conidiophores or vesicles and conidia covering the vesicle under high power. Observations and results. So this figure shows that out of 610 patients which were enrolled in the study, maximum patients were in the age group of 21 to 40 years, followed by the age group of 41 to 60 years. This shows that in the study that the predominance of the patients was of males 61% than the females, that is 39%. This shows that most of the common specimen which was received was CSF, followed by urine, buccal mucosa, nasal mucosa, and others. This shows that the maximum samples were received from medicine ward, followed by the ENT ward. The results or the outcome of the clinical specimens. This figure shows that 109 patients were found to be positive out of total 610 patients. This shows that the maximum fungal isolation is found in the urinary samples, followed by tissue, buccal mucosa, and others. The various fungal isolates isolated were the maximum toll was taken by yeast-like organisms, non-albicans, Candida and Candida albicans, followed by Aspergillus species like flavus, fumigators, and then Rhizopus, mucor, and Trichophyton. This table shows that direct microscopy was positive in 92, clinical specimens and culture was positive in 86. So the conclusion is that KOH examination and fungal culture are good diagnostic methods for the detection of fungal infection. Early detection of fungus by microscopic examination can be used as an important screening test for presumptive diagnosis of fungal infection. It can help clinician in stoppage of antibiotic therapy and in initiating empirical antifungal therapy earlier, which will help in the better clinical outcome in such category of patients. In the present study, non-albicans candida infections, especially in UTI cases, are increasing globally, which is a cause of concern in our country. Thank you.
Thank you.
Thanks.
For the next oral paper presentation, I would like to invite Dr. Harmandeep Kaur Gill, who will be presenting on the topic Antimicrobial Susceptibility Pattern of Escherichia coli Isolates among Various Clinical Samples.
Good morning, everyone. My topic for oral presentation is antimicrobial susceptibility pattern of Escherichia coli isolates among various clinical samples. Introduction. E. coli is gram-negative rod-shaped bacterium that typically resides in the lower intestinal tract of humans. E. coli is one of the most frequent causes of urinary tract infections and is among the most important pathogens causing bloodstream infections, otitis media, wound infections, neonatal meningitis, and nosocomial pneumonia. Antimicrobial resistance is one of the main cause of failure in the treatment of infectious diseases, resulting in increased morbidity, mortality, and cost of healthcare services. Materials and method. For this study, a total of 500 specimens like urine, blood, pus, stool, sputum, and different body fluids received in clinical microbiology laboratory were processed and inoculated on culture plates and were incubated at 37 degrees Celsius for 18 to 24 hours. After identification, E. coli was processed for antibiotic susceptibility testing on Muller-Hinton agar using Kirby-Bure disk diffusion method. E. coli ATCC25922 was used as a reference strain. Results. A total of 500 clinical specimens were taken of different age groups and processed in clinical laboratory for isolation and identification of E. coli. Out of 500 specimens, 180 were found to be culture positive, of which 88 were E. coli isolates. 54% E. coli isolates were obtained from the female patient, while 45% were obtained from male. Isolation of E. coli was highest in urine, that is 80%, followed by pus and other samples. E. coli were 100% resistant to ampicillin, followed by ceftriaxone and ciprofloxacin, whereas least resistance was observed in imipenem and piperacillin tazobactam. This is a pie chart that shows out of total 500 samples, 182 were culture positive, while 318 were sterile. And another diagram shows the distribution of various organisms among the culture positive samples. So out of 182 positive samples, 88 were E. coli positive. So these are the diagram that shows the results of antibiotic susceptibility pattern of E. coli among various clinical samples. E. coli isolates were found to be resistant to ampicillin, and resistance was about 100%, followed by ceftriaxone and ciprofloxacin, and 100% susceptibility was found towards the colistin, and followed by imipenem and piperacillin tazobactam. Whereas in urine samples, susceptibility was found towards the colistin, followed by nitrofurantoin, and imipenem and piperacillin tazobactam. Conclusion. Among the various clinical specimens processed, antimicrobial susceptibility pattern was noted only among E. coli isolates. E. coli isolates exhibited high resistance to ampicillin, cefotaxime, and ceftriaxone. However, amikacin, piperacillin tazobactam, imipenem, nitrofurantoin, and colistin were found to be effective antibiotics against E. coli isolates. Discussion. Routine surveillance of antimicrobial susceptibility patterns should be conducted so that the rational antibiotic policy could be adopted and reviewed at regular intervals. This could serve as a guide to the clinicians for empirical and definitive therapy while treating the patients. This would help to reduce morbidity and mortality associated with multi-drug resistant organisms. Implementation of good infection control practices can play a major role in prevention of infection and spread of multi-drug resistant pathogens. Thank you.
Actually, by misuse or overuse of antibiotics, probably we are having so much resistant the commonly used antibiotics, and that's why we have to use high-end antibiotics these days to overcome all these infections, particularly E. coli. Probably again the message is we should not we should use antibiotics judicially rather than overuse or extensive use of antibiotics.
Yes, sir.
That leads to the resistance what we are facing today.
Pardon me, sir?
That is why we are facing the resistance to the commonly used antibiotics because of overuse or misuse or this excessive use of antibiotics.
Yes, sir.
Is there any you have studied regarding difference in sensitivity in pus culture and urine culture?
No, sir.
You have studied as a whole.
As a whole, E. coli from all the samples.
It would have been better because urine culture usually we see nitrofurantoin is the commonest and cheapest antibiotics to be susceptible. But in this case, it is showing some cases are showing resistance even to nitrofurantoin. Those cases may be because of inclusion of pus.
Thank you.
Thank you.
Thank you, ma'am. For the next presentation, I would like to invite Dr. Indu Gupta, who would be presenting on the topic Clinical and Laboratory Evaluation of Patients Presenting with Fever with Thrombocytopenia in a Tertiary Care Hospital of North India. 5 minutes will be given for the presentation and 5 minutes for the questionnaire.
A very good morning to all of you. I am going to present my paper on the topic Clinical and Lab Evaluation of the Patients Presenting with Fever with Thrombocytopenia in a Tertiary Care Hospital of North India. Fever has been recognized as a common manifestation of disease since ancient times, as recorded by the ancient scholars like Hippocrates. Thrombocytopenia is defined as platelet count less than normal range, usually below 1,50,000 per microliter. Cases are considered mild if counts are between 70,000 and 1,50,000 and severe if less than 20,000. Diseases like dengue, malaria, typhoid, leptospirosis, miliary TB, HIV, septicemia, these all are associated with abnormal platelet counts. Objectives of the study are to determine possible infective etiology of fever with thrombocytopenia, to correlate clinical features, laboratory studies, and infective etiology. Material and methods used were, the study was conducted on 50 patients who were admitted in the medical wards of GGS MCH Faridkot, Punjab in the period between July to September 2021. Patients with a history of fever and found to have thrombocytopenia were considered. Careful history was recorded with general physical examination and detailed systemic examination was done. Temperature was measured orally by the clinical thermometer. So the main objectives of the current study were to determine possible infective etiology of fever with thrombocytopenia, to correlate clinical features, laboratory studies, and infective etiology. Materials and methods used were, the study was conducted on 50 patients who were admitted in the medical wards of GGS MCH Faridkot, Punjab in the period between July to September 2021. Patients with a history of fever and found to have thrombocytopenia were studied. Careful history was recorded with general physical examination and detailed systemic examination. Temperature was recorded orally by a clinical thermometer. This was followed by routine investigations, which included CBC, total leukocyte count, renal function test, LFTs, PTINR, urine routine, ECG, ultrasonography, chest X-ray were done wherever indicated. Blood cultures, urine cultures, bone marrow examination, viral markers, malarial parasites by rapid CAR test and PBF, dengue antibody test by IgM ELISA, typhoid test and other relevant investigations were also done. Inclusion criteria was 50 patients, both males and females, aged above 15 years, admitted with fever and found to have thrombocytopenia were included. And in exclusion criteria, there were patients who were less than 15 years of age and who had only fever but no thrombocytopenia, or other way around, that is thrombocytopenia with no fever were excluded. So the results were, it was found that in the percentages that the diagnosis of the fever with thrombocytopenia, patients came out to be malaria positive in 36% of the cases, and they had viral fever in 34% cases, dengue in 24% cases, and enteric fever in 2% cases. Hepatitis included in the 2% of the cases. And in others, it were the 2% cases. So clinical presentations of the patients were fever in the 100% of the cases, pain abdomen in 8%, gastroenteritis and shock in 4%, altered sensorium in 2%, rash and bleeding manifestations in the 4%. And the distribution of cases in relation to severity of thrombocytopenia was that malaria causes the severe thrombocytopenia. That was in 11 cases, there was less than 50,000 platelet counts. And in viral fever, 7 cases were having the less than 50,000 counts. In dengue, there were the 4 patients. And in hepatitis and enteric fever did not cause any severe thrombocytopenia. So fever is known as pyrexia from the Greek word pyretus, meaning fire. It is a medical sign that describes increase in internal body temperature to the level above normal. It is considered as one of the body's immune system to attain neutralization of the perceived threat inside the body. A fever rarely comes without other signs and symptoms. Many a times it is associated with low platelet count, and normal platelet count, as we know, it is 150,000 to 4 lakhs per cubic millimeter. Thrombocytopenia results from decreased production, increased sequestration, and or increased destruction. So in conclusion, thrombocytopenia was the commonest lab finding in many fever cases. It is better to do platelet count in all fever cases wherever they have the bleeding manifestations or not. It is not always necessary that fever with thrombocytopenia is dengue or malaria. It can be viral illness in which recovery starts within 4 to 5 days with improvement in the platelet count. Thrombocytopenia due to infectious diseases shows seasonal variation commonly seen in the rainy and the winter season. Treatment of the causative agent will lead to the improvement in the platelet counts. Thank you so much.
Thank you, Dr. Indu. It is nice that we have documented something which is probably we already knew it beforehand, but we never ever we thought most of the viral infections they will cause low platelet count. You see,
yes, sir.
The low platelet count again all the time doesn't mean that it's the dengue fever only. I mean, even from your slide, you see malaria probably was more sort of causing low platelet count than most of the other fevers.
Yes, sir.
So I think, again, because we all knew it that most of the virus, since you see the availability of the tests so easily nowadays, so
yes,
we have come to know more and more about the low platelet count. You see, I mean, it was there already in the past also, but we never had the facility to do the test. So I think, again, you see, one should be very careful. Low platelet count doesn't mean dengue fever. But one has to investigate thoroughly to make sure that what is really wrong with the patient.
Yes, sir. Sure, sir.
Thank you.
Thank you so much.
Dr. Indu, it was
yes,
a nice presentation. Now, there is just one thing which I want you to please follow up. You had shown the platelet counts, and you have shown fever, and you have shown malaria and viral fever. Now, if you can further subcategorize, what was the platelets which you saw in malaria? What was the platelets you saw in viral? So that will give an impression, like how much do we expect that it might be a viral fever and how much do we expect if it is a malarial fever.
Yes, sir.
So what happens with this, you will open a window for more research in this topic. So at least this can be a pilot study and others can also carry on, or you can carry on with this study so that we have a good data and it can correlate.
Yes, sir.
So that will be helpful.
Yes, sir.
How did you diagnose viral fever? How did you diagnose viral fever?
Sir, viral fevers are diagnosed by the viral markers, hepatitis B, C. As we know, hepatitis C.
No, because hepatitis you have said separately.
Thrombocytopenia,
So
yes, sir.
that's not included in viral fever. Even dengue is also viral. So,
Dengue hemorrhage.
so how did you diagnose that category viral fever?
Sir, like other causes like yellow fever and West Nile
No,
fever.
that's what I'm asking you. How did you diagnose viral fever? That is a diagnosis of exclusion, or it's a positive diagnosis?
No, no, sir, diagnosis of exclusion only.
So again, I think it's a gray area.
And other part is, how do you know this is decrease in platelets if you don't follow up that platelet count has improved?
Yes, sir.
See, it can be. So have you followed up those patients that this 50,000 has improved to 1
Yes,
lakh
sir,
50,000?
sure. They were in the wards only, so we discharged them with the following platelet counts are improved. Then only we discharge them if their fever subsided. With the fever subsidation, there is a increase in the platelet count also.
So that you should also document here that this was the baseline platelets, this was decrease in platelets, and this was recovered platelets. Only then you can authenticate this type of study. Otherwise, you can have, low platelets in so many cases and you diagnose the patient as viral fever. Patient's baseline is 90,000. Now it is 90,000. We will label it as thrombocytopenia. Thank you.
Just on the lighter side, you see, it says, how do you diagnose viral fever? When you don't know anything, you just say it is a viral fever.
Yes, thank you.
Thank you, ma'am. For the next presentation, I would like to invite Dr. Manish Kumar, who will be presenting on the topic penile fracture, a study of outcome.
Good morning, everyone. I am presenting my presentation on penile fracture, a study of outcome. It is introduction. Penile fracture is defined as rupture of tunica albuginea. It can involve both corpora cavernosum and it may also involve corpora spongiosum, urethra. The various causes of penile fracture is over-enthusiastic masturbation, falling or rolling out of erect penis, took down. This is a technique which is followed in Middle East countries for bending or rolling of the penis to increase the size. Anatomy. Arterial supply is through the internal pudendal artery. Venous drainage is through the deep dorsal vein. Lymphatics drain into superficial, deep inguinal lymph nodes. Sign and symptom, sudden loss of erection with severe pain, popping or cracking sound, eggplant deformity, dysuria, hematuria, penile chymosis with swelling. Diagnosis, appropriate history and clinical examination is enough for diagnosis. Early intervention with degloving incision gives a good outcome. The defect is repaired by vicryl or other absorbable suture, preferably 3-0 round body. Post-operatively, patient is managed by analgesic and antibiotics. Materials and method. It was a retrospective study. All the cases of the penile fracture over last 5 years presenting in our unit were taken in this study. Patients were contacted telephonically and examined in our hospital OPD. These are the images, and case 1 was 30-year-old male with defect of 1 into 1 centimeter. Case 2 was 32-year-old male with defect of 2 into 1.5 centimeter. Case 3 was 31-year-old male, defect of 2 into 1 centimeter. Case 4 was a 60-year-old male, 2 into 1 centimeter defect. Fifth case was 29-year-old male with defect of 1 into 1 centimeter. Sixth case was a 19-year-old boy with 1 into 0.5 centimeter defect, and the last case was a 30-year-old male with 2 into 1.5 centimeter defect. The result and discussion, two cases were not able to have erectile function on the day post-op day 10, but on day 30, all were able to have normal erectile function. The mean age of the patients were 33. The mean time of presentation was 14 hours, and the mean time from presentation to the surgery was 2.5 hours. The erectile function of all the patients were achieved on the day 30. Conservative conservative management increases the morbidity. 24 to 48 hour delays does not affect the outcome of the surgery. Early surgical intervention reduces the complication, and repair is done by absorbable suture. Conclusion, penile fracture is a rare surgical emergency that challenges both patient both mentally and socially. Embarrassment associated with the condition delays the treatment. Appropriate clinical examination is definitive for diagnosis. Early surgical intervention gives a better outcome. Thank you.
Any complication of painful erection or curvature in the penis on erection? Have you studied?
Sorry, sir?
Painful erection?
Sir, painful. I couldn't understand, sir.
Painful erection?
Sir, it is priapism.
Yeah. No. Priapism is something different. Complications of this penile rupture, fracture, are usually painful erection and.
No, sir. It was normal on day 30. Day 30.
Erection was normal.
On day 30. Post-operative day 30.
Right.
Only 7 patients in 5 years.
Yes, sir.
Study sample is very small to...
Sir, it is a very rare condition, sir.
Condition is rare?
Yes, sir.
Yes, definitely.
And patient do not report as urgently as possible. And if there is a small defect that is limited above the tunica albuginea, that resolve spontaneously. When it involves the tunica albuginea, then it needs a surgical intervention, sir.
Okay, thank you.
Thank you, sir. For the next presentation, I would like to invite Dr. Nishant Sharma, who will be presenting on the topic prevalence and determinants of anemia in patients with rheumatoid arthritis and its correlation with serum hepcidin levels.
Good morning, everyone. I'm Dr. Nishant Sharma, and I've been working as a PG resident in the Department of Medicine at Dr. RML Hospital. My thesis was conducted under Dr. Pulin Kumar Gupta, Professor, Department of Medicine. And the thesis topic was prevalence and determinants of anemia in patients with rheumatoid arthritis and its correlation with the serum hepcidin levels. So as we all know that rheumatoid arthritis is a chronic systemic autoinflammatory disease with many articular and a lot of extra-articular manifestations. And the previous studies have already established that almost 40% of the patients of the RA develop extra-articular manifestations at the onset or even during the course of the disease. Now, anemia being the most common extra-articular manifestation of rheumatoid arthritis is often underdiagnosed or often undertreated. The cause of anemia can be multifactorial. It can be due to the nutritional deficiencies, can be due to the chronic inflammatory state, or even the side effects of the drugs. Now, till now, the gold standard investigation to differentiate between the two major entities, that is the iron deficiency and the anemia of chronic disease, has been bone marrow biopsy, which is an invasive procedure. So therefore, due to the lack of any surrogate biomarkers, we have conducted this study. So ours was a cross-sectional observation study where we recruited 101 patients with RA as per the ACR EULAR criteria 20 to 10, satisfying our inclusion and the exclusion criteria and the patients who had given consent. So the parameters that we included were a detailed history and examination, a complete blood cell count, RBC indices, iron studies, serum ferritin, serum erythropoietin levels, soluble transferrin receptor levels, and serum hepcidin. The data was entered in MS Excel sheet, and the analysis was done using SPSS version 21. So to define anemia, we use the definition as per the WHO, that is less than 12 gram per deciliter for females and less than 13 gram per deciliter for males. Further, for the type of anemia, it was classified as per the following definitions, and this has been previously used in the earlier studies. So for pure iron deficiency anemia, a CRP level of less than 5 milligram per liter, a percentage transfer saturation of less than 20, and seroferritin of less than 30 nanogram per ml was used. And for pure anemia of chronic disease, a CRP level of more than 5 with a percentage transfer saturation of more than or equal to 20% and serum ferritin of more than 100. And any values that came in between were classified as the mixed type of anemia. So coming towards the observation of our studies, the prevalence among the 101 cases was found to be 53. That is 52.4% of the patients were found to be anemic, out of which both the pure iron deficiency and the pure anemia of chronic disease was found to be 9.4% of the patients. But the majority of the cases were classified under mixed picture. That is, they had both the iron deficiency plus anemia of chronic disease, while no cases had any megaloblastic or dimorphic anemia picture. Coming towards the determinants of anemia, the disease activity as measured by the Simplified Disease Activity Index was found to be higher in anemic cases with significance of P less than 0.041. With the highest values that were found in the anemia of chronic diseases, intermediate values in the mixed picture, and the lowest values were found in the iron deficiency anemia. A significant correlation was also found between the rheumatoid factor and the anti-CCP as compared to the prevalence and the severity of anemia. Also with the acute phase reactants, that is the ESR and CRP. Now coming towards the 4 major determinants that we evaluated for this study, the serum erythropoietin levels were found to be higher in anemic cases as compared to the non-anemic cases, although they could not correlate significantly with the type of anemia. Also, the levels that were found in our cases in all the rheumatoid arthritis patient was subnormal as compared to the normal ranges or the values of the erythropoietin that is seen in the normal population. Secondly, serum ferritin levels were found to be highest in the cases with anemia of chronic disease, moderate in the mixed anemia, while the lowest were found to be in iron deficiency anemia, although significant correlation was not found with respect to the prevalence or the severity of anemia in seroferritin also. Third, the soluble transferrin receptors, they were found to be significantly higher in the anemic cases, with p-value being 0.08, with levels being highest in the cases with iron deficiency anemia, intermediate in mixed anemia, and lowest in cases with anemia of chronic disease. While the most important biomarker that we have evaluated as it has been upheld in the previous studies to be a upcoming surrogate biomarker, we could not find any significant correlation to the prevalence or the severity or even the type of anemia with serum hepcidin levels. So crunching our data, anemia being a common finding often at the onset or during the course of disease may significantly hamper the quality of life in RA patients. Also, the nutritional deficiencies are often masked by the inflammatory process in almost all the chronic diseases, especially the disease that I've considered in this, that is rheumatoid arthritis, thus making it difficult to differentiate between the types of anemia, leading to ineffective or even overtreatment in some cases. So among the studied parameters, serum ferritin reliably differentiated between the anemia of chronic disease versus the IDA group, and also between the mixed anemia versus IDA group. Secondly, the soluble transferrin receptors, they were also able to differentiate between the anemia of chronic disease and IDA, and AOCD versus mixed anemia. While serum erythropoietin levels and hepcidin levels, they were not able to do so. So concluding my study, anemia is very common, but underdiagnosed in patients with rheumatoid arthritis. CBC cannot reliably differentiate between the types of anemia. Serum ferritin levels and soluble transferrin receptor levels, they can be used to differentiate the same and hence determine an effective treatment for the patients. Now, serum erythropoietin levels show paradoxically lower levels than the normal values suggestive of a blunted response in the patients having anemia in RA cases. Now, this can be used for a therapeutic option in patients who are already refractory to the other treatments. And serum hepcidin levels, though, cannot be used as a surrogate marker for the same as concluded with our study. Thank you, sir.
Yes, I think anemia is very common in rheumatoid arthritis.
Yes, sir.
Because of the disease per se, plus the amount of anti-inflammatory, and the other drugs we are using regularly, that contribute to anemia.
Yes.
So even with this, what do you recommend for the treatment then?
So for the treatment per se, actually anemia is usually quite undertreated in the patients with RA. We tend to give them the DMARDs and the other agents. And the thing is, even after the treatment, even if the CRP levels and the disease activity is controlled as per the physician's point of view, the patient would still complain of other symptoms, the symptoms that can be attributed to the anemia. So the simplified disease activity index that includes the patient-related factors, it will still be high in the patients, and the patient might get over-treated for the same. So that may lead to the cumulative side effects from the drugs. That's why we need to evaluate for anemia and whether the treatment parameters that we can use to improve the quality of life of the patient. So that was the reason for the study, sir.
No. I'm asking you, since they respond poorly to the iron supplement, you see, that's what I'm asking you, see, how are you going to?
So for the supplementation levels?
Yeah.
So in case that we are having a pure iron deficiency anemia that is usually found in a lot of patients in the Indian population, we can simply supplement the iron deficiency with even IV or oral medications. So that's the most commonly found anemia as per the previous studies, although in our study it was mixed type of anemia. In case it is a mixed type or an anemia of chronic disease that is due to the disease activity, the most important thing is to decrease the disease activity that can be done with DMARDs, mostly DMARDs, and initially low dose steroid can be helpful in that. Later on, the steroids has to be tapered off, considering the side effects of the drugs. And if the disease activity is still high, or the anemia levels, or the patient is not improving with the current treatment, then we can think about changing the patients towards the biological agents, the TNF-alpha blockers and the IL-6 inhibitors. Sir.
Because all the anemias with the chronic disease are very difficult to treat, you see.
Usually, sir.
Normally don't respond very easily to the treatment.
Of course.
If we take a cutoff of serum ferritin,
yes, sir.
I think a lot of your anemias will be classified as anemia of chronic disorder. Because
Sir,
I think even in the mixed anemia,
yes, sir.
The ferritins were pretty high.
Yes, sir.
So a lot
So
of patients, ferritin. So I feel that if we talk of ferritin only, then a lot of patients will be classified as anemia of chronic disorder.
For sure, sir. Sir, in the previous studies, actually, ratio of the serum ferritin to the soluble transferrin receptors has been taken into account to compare for the other biomarkers. A log ferritin to the transferrin receptor ratio of more than 2, it correlates better to the anemia of chronic disease, and a ratio of less than 1 correlates better to the iron deficiency anemia. So even in cases that we are using serum ferritin as our main biomarker to classify the patients under the different types of anemia, log value would be better.
Thank you, sir. For the next presentation, I would like to invite Dr. Paramjeet Singh, who will be presenting on the topic to study the association between microalbuminuria and hospital outcome in patients of sepsis in tertiary critical care hospital.
Good morning, everyone. I am here to present a study done on the association between the microalbuminuria and hospital outcomes in patients of sepsis admitted in the critical care unit of tertiary care hospital. Sepsis is a systemic deleterious host response to infection leading to severe sepsis and septic shock. The two widely adapted systems to predict mortality are the acute physiologic and chronic health evaluation, Apache 2, and the simplified acute physiologic score. Though useful to evaluate the outcome, these tools are of limited use in day-to-day practice, sensitive, inexpensive and dynamic prognostic markers which generate rapid and reliable results are therefore desirable in the ICU setting. A severe and sustained inflammatory reaction induces rapid changes in the endothelium resulting in the loss of barrier integrity leading to systemic capillary leakage. In the kidney, this manifests as altered glomerular permeability, causes increased renal albumin excretion in the urine, called microalbuminuria, defined as the 30 milligram per day of albumin excretion in the urine occurs rapidly after the acute inflammatory insult such as sepsis. Microalbuminuria is a sensitive predictor of outcome in critical ill patients early after ICU admission in severe clinical situations. Aims and objectives are early therapeutic intervention can be life-saving in patients with sepsis and enable us to do that. We need to specific objective of these studies to study the various clinical and laboratory parameters in sepsis patient, to document the mean Apache 2 score and the level of albuminuria in patients of various sepsis patients, to find out the association between the microalbuminuria and hospital outcomes in critical ill patients. Study area was critical care ICU. Study population was adult patients of both gender, age more than 18 years and less than 16 years, presented with sepsis to ICU with stay of more than 24 hours. Sample size of 50 adult. Sample design was simple random selection. Study design is a hospital-based short-term prospective study. Parameters to be studied: history taking, clinical examination, laboratory examination. Study tools were clinical examination, blood examination, WBC count, serum creatinine level, and ABG. Urine examination, routine and microscopic examination, culture and sensitivity. And albumin creatinine ratio. Study technique is 50 adult patients were selected whose ICU stay period is more than 24 hours. Thorough history, clinical and routine laboratory parameters were obtained of them, and their Apache scores were calculated within the first 24 hours of their ICU admission. A spot urine sample was collected and sent for the urinary microalbumin was measured by the autoanalyzer, and urinary creatinine was the autoanalyzer modified kinetic Zephyr reactions. Microalbuminuria was defined as the albumin creatinine ratio values between 32 to 90 milligram per gram. Value of more than 300 milligram per gram is considered as a clinical proteinuria, and less than 30 milligram is normal for the healthy population. These patients were followed up on the 3rd, 7th, and 40th days in the ICU to assess treatment and outcomes in the terms of mortality and length of ICU stay. Inclusion criteria was adults patients of any age, sepsis, a proven or suspected microbial etiology, plus 2 or the more of the following: core temperatures more than 38 or less than 36 degrees Celsius, heart rate is more than 90 beats per minute, respiratory rate is more than 20, WC count is more than 12,000 or less than 4,000, duration of ICU stay is more than 24 hours. Exclusion criteria was age more than 60 years, duration of ICU less than 24 hours, patient with anuria or microscopic hematuria, history of pre-existing chronic kidney disease, menstruating or pregnant woman, patient with significant proteinuria due to renal or post-renal causes, or patient of diabetes and hypertension with established microalbuminuria. These are the results. This is a table showing distribution of patient according to age group. In this, in present study of out of 50 patients, a maximum number of patients fell in the 41 to 50 years age, around 40%, and a minimum number of patients were under the 30 years of age. First table shows the distribution of patients based on the outcomes. In present, out 50 patients with sepsis, with sepsis 32 were survivors and 18 were no survivors. Second one table shows the correlation between urine ACR and Apache-2 in sepsis patient. In the present study, urine ACR and Apache-2 of 50 sepsis patients shows a good correlation between them, which was also statistically significant. So summary is the presence of microalbuminuria occurs very early in the onset of inflammatory response. Microalbuminuria is a better indicator than the Apache-2 and SOFA scoring. In predicting vasopressor requirement and mortality, urine for ACR was done on admission within 24 hours for admission, and Apache-2 score was calculated. Total of 50 patients was included in this study. The mean age of the patient was 42.0 with standard deviation of 8.87. Out of 50 patients, 14 patients were females and 36 were male. Mortality in this study was 36%. 18 died out of 50 patients, and mortality was more among male patient than the female patient. Apache-2 score ranged from 9 to 23, and mean Apache score were, survivors were 12.53, and among non-survivors was 17.06. Non-survivor has a higher Apache-2 score compared to survivors one, and p-value was statistically significant with p of less than 0.001. Mean USCR among survivors was 103 milligram per gram, and among non-survivors was 171. ACR measured within 24 hours of admission was found to be good as a Apache-2 in predicting mortality in sepsis patient. So conclusion is presence of significant microalbuminuria 24 hours of admission correlate well with the mortality as compared to Apache-2 score. Survival rate in patients with severe sepsis can be improved by early institution of intensive therapy. Microalbuminuria is an expensive, rapid diagnostic as well as prognostic tool. Hence, present study conducted a microalbuminuria can be used as dynamic marker of sepsis.
Just 1 minute. Just 1 minute. Did you follow up these patients regarding microalbuminuria?
Yes, sir.
And did you do the quantitative assessment of all these patients?
Yes, sir.
So what was the follow-up results?
So 18 were non-survivors. Out of 15 patients, 36 were survivors, and they die within less than a week.
And survivors, what was the follow-up of microalbuminuria?
Sir, that I didn't do, sir.
Okay.
Thank you, sir. For the next presentation, I would like to invite Dr. Shivam Swarnkar, who would be presenting on the topic clinical etiological profile of acute and chronic liver failure. 5 minutes will be giving for the presentation and 5 minutes for the questionnaire.
Good morning, everyone. Myself, Dr. Shivam, PG third year student in the Department of Medicine in the RML Hospital. I did my study under the guidance of Dr. Ulka Kamble, professor in the Department of Medicine. The topic for today's study is clinical etiological profile of acute and chronic liver failure. Introduction: acute on chronic liver failure defined by an acute deterioration in the liver function in the patient with established chronic liver disease, and the APSL defined ACLF as the acute hepatic insult manifesting as a jaundice, that is serum bill more than 5, and the coagulopathy, that is a INR more than 1.5, complicated within 4 weeks by ascites and or encephalopathy in the patient with previously diagnosed or undiagnosed CLD or cirrhosis that is associated with the high 28 days mortality rate. Etiologies are alcohol-related injury, drug-induced hepatitis A, B, C, D, E, and the liver-related surgeries, and the extrahepatic causes are bacterial infection and the other major surgeries. Objectives of study: to study clinical and the etiological profile of acute and chronic liver failure. Methods of the study: 83 patients included as per APSL criteria, and the exclusion criteria was age less than 18 years and the patient with hepatocellular carcinoma. All 83 patients subjected for the detailed history and the clinical examination routine investigations like CBC, KFT, LFT, urine investigation. In the special investigation is ascitic fluid analysis, blood culture, serum procalcitonin, ascitic fluid culture, all done, and the patient followed up in the during hospital stay, and the outcome was assessed. And the for prediction of the mortality, we use two score, Apache 2 and the Cliff Sopa score. The result of the studies: age of the study population ranged from the 22 years to 68 years. Among 83 patients, 84.5% were males and the 15.5% were female. Our study showed the 95.2% patient had melena, and the 91.7% has altered sensorium, that in the form of hepatic encephalopathy, and the 8.3% of the patient has grade 1 hepatic encaph, and the 19% patient has grade 2 hepatic encaph, and the 26.2% patient has grade 3 encaph, and the 46.4% patient has hepatic encaph grade 4, and the 84.5% patient has visible jaundice, and 79.8% patient has abdominal distension in the form of acute onset ascites, and the 42.9% patient has decreased urine output in the form of AKI or HRS, and the 31% patient has fever, and the 26.6% patient has shortness of breath. And on examination, 100% patient had pallor, 98% had icterus, and the 97.6% had pedal edema, 96.4% had ascites, 73.8% has petechial rash over body, and the 51% had splenomegaly, and the 2.4% has hepatomegaly. And the etiologies are found to be maximum sepsis related that the 41.7 percent sepsis can be, we found the sepsis can be secondary to the LRTI and the spontaneous bacterial peritonitis, and the 2% of the patient had sepsis related to the UTI also. And the second most common cause we found out the alcohol related injury, and the third is the idiopathic. We could not find out the cause of acute on chronic liver failure in the 9.5% patient, and the hepatitis B related is the 9.5%, the hepatitis C 2.4, and the drug induced 2.4. Maximum drugs are we have only 3 patients that had the drug induced acute on chronic liver failure. Both all 3 patients are having a injury secondary to the anti-tubercular drug, and the outcome assessed, 84.5% patient required ICU support during hospital stay, and the total 63.1 patient required mechanical ventilation in form of BiPAP for intubation, and the 64.3% patient were dead, and the 35 were discharged. And the mortality rate was within 7 days of admission for 47.6% of the patient, and within 14 days of admission for 14%, and within 21 days of admission for 1% of the patient. And the for Cliff-Sofa score in the day 1, day 3, day 5 was found statistically significant higher among the patient who were dead as compared to the patient who were discharged. P value is less than 0.05. And Apache 2 score is also day 1, day 3, day 5 found significantly higher in the patient with who are discharged. Discussion, we found that the most common complaint was upper GI bleed, followed by hepatic NCAF, and followed by acute onset ascites. And in our study, we also found the most common precipitating factor was sepsis related, alcohol related, and followed by hepatitis B, idiopathic drug induced, and the hepatitis C related. And the 84% patient required ICU support, and the 63% required mechanical ventilation, and the mortality rate was highest within 7 days of admission. In our study, we also found out that patient who expired during hospital stay have higher Cliff-Sofa score and the Apache 2 score. So these 2 score can be used as a predicting mortality at the time of admission in cases of ACLF. Thank you. Thank you, sir.
Thank you, sir. Now we are proceeding for scientific program. We have our first guest faculty, Dr. Ashish K. Saxena, consultant, Diabetes and Heart Center, Dr. Saxena's Medi Center, Ludhiana, who will be presenting on the topic Noise Pollution and CV Risk, the Noise Stress Concept.
Very good morning, everybody. I think so. I'm the opening batsman for the lectures today. Special thanks to Dr. Vitul for inviting me for this conference. This was a concept which I was thinking for quite some time. We are in an environment where we have continuous interaction. Interaction with air, interaction with wind, interaction with the sun, interaction with the pollutants, interaction with noise. Now this is a concept of noise which is causing stress. And there are certain problems which are coming up, which are creeping up. So this is my topic for the day, noise stress concept, the assessment of risk and what are the needs for research in this. I'll be talking about the background of noise pollution in our country. I'll talk about the impact of the long-term exposure of this noise and the dose which can cause a cardiovascular disorder. The road traffic noise, the blood pressure, hypertension, noise associated with coronary artery disease, with stroke, evaluation of risk for our population, solutions, research needs, and policy interventions. So now, what is the permissible limit of noise level in our country, and what is the permissible limit which actually helps? Now, guidelines have been laid for permissible limits in our country at different areas. For industry, it is around 75 decibel during the daytime and 70 at night. For commercial areas like malls and other places, it is 65 and 55, 65 during day and 55 at night, and residential area is 55 to 45. Now, this is the ecosystem which is being destroyed or which is being altered. At home, we are watching our TV at a higher decibel. At our workplace, the noise level of the machinery is very high. During the industrial areas, the pollution of the honking of sounds, the machineries goes so high. Now, what is the effect which is going to happen to us? This is the example of various sound levels from various sources. Now, if you see, if we are whispering, it is 20 decibels. What I am talking is somewhere around 40 decibels. If a medium-sized truck moves across, it is 80 decibel, a large truck 90. A rock concert is around 110, it goes up to 120 also. And an aircraft takeoff is at around 120, and a pain barrier is around 130, where the ears go into a problem. Now, when we go to an airport, we see that the Indira Gandhi International Airport or the Chhatrapati Shivaji Airport at Mumbai, they have made areas where you have no announcements. That is because they want to prevent noise pollution. There is a concept behind everything. Yes, you have heard about Moradabad, the city of brass, the city of utensils, and this happens to be topping as one of the most noise polluted city globally by the United Nations Environment Program. This report identifies 13 noise pollution cities in South Asia, 5 of which, including Moradabad, we are fortunate that we are number 1 in it. Calcutta having around 89 decibel, Asansol 89, Jaipur 84, and Delhi 83. I know, Delhi looks very crowded, but this is the noise index which has been seen across. Now, what is the impact of this long-term exposure? Long-term exposure to environmental noise, it creates death of about 12,000 premature people, contributes to about 48,000 new cases of ischemic heart disease as per seen in the European territory, and around 22 million people suffer from chronic high annoyance, and 6.5 million people suffer from chronic high sleep disturbances. The cardiovascular effect of noise, how it comes, the long-term and the short-term environmental noise, they cause a stress reaction, annoyance, there is disturbance of sleep, emotional reactions, cognitive dysfunction, the effect on the autonomic, sympathetic, and endocrine systems, elevated catecholamines, cortisol concentration, these all lead to changes in the lipid metabolism. And lipid metabolism causes changes in the glucose metabolism and blood pressure, and it causes an increased risk in the cardiovascular area. Now, this is the noise effect module, which clearly shows that persistence and acute exposure to noise leads to increased cause of cardiovascular risk by raised blood pressure, lipids, blood sugars, increased cardiac output, increased blood viscosity, and activation of coagulation factors. And this is causing mental and psychological stress reaction. Long term, this can cause clinical manifestations of cardiovascular disease like hypertension, CAD, heart failure, arrhythmia, and stroke. Because if you look over here, the psychological stress, the homeostasis is disturbed. The sympathetic nervous system is activated. The endocrine systems, the hypophysis, the adrenal glands, they are all activated, and they are all the risk factors which are contributing to blood pressure, cardiac output, coagulation, viscosity, ultimately leading to the causes of cardiovascular disorders. Now, there is always a dose-responsive relationship of noise for cardiovascular risk. And it is taken at the level of increment of every 5 decibel for evening and 10 decibel for the night. And this is the way it has been shown. If you see the blue line on the top is the aircraft, and if you see the aircraft cardiovascular disk, how it increases. As the decibel increases from 58 to 63 to 68, the level increases. And this is how it causes the endothelial dysfunction and the stress hormone level. This is how things reflect by every 10 decibel rise of noise level. Coming to transportation noise, increased risk for cardiovascular disorders, it significantly increases. If you have a chronic exposure to one pollution type or both the pollution types, more and more cardiovascular risk factors come. Road traffic noise, blood pressure, and hypertension. This was a meta-analysis which was done around 24 cross-sectional studies to study the relationship of road traffic noise and prevalence of hypertension. And it was seen that every 10 decibel rise in a 16-day average period, it causes more and more risk of cardiovascular disorder. Similarly, stronger and significant association is seen in men and older subjects above 65 years of age. So there is no direct actual evidence linking noise and coronary artery disease, but many studies have been done which shows that hypertension indirectly reflects the relationship between noise and CAD. A meta-analysis done by 4 cohort studies and case control studies shows this association, that when you decrease the noise level, the risk of cardiovascular disorder decreases. Yes, noise causes stroke. Residential noise, having traffic above 60 years of age, 65 years of age, with every 10 decibel rise, there is a more risk of developing a stroke. Aircraft noise, several studies in the past 10 years have demonstrated higher prevalence of annoyance, cardiovascular disease, or medication intake in personal exposure to aircraft. That is why Heathrow Airport stops all flights in the night, and so that because the environment is getting disturbed, because they are environmental friendly people. Risk evaluation, the process of risk evaluation comprises of health hazard identification to look to the exposure, dose-related assessment, categorization, and management. Now, this is very, very important because as a result of risk evaluation, we'll be able to protect ourselves. Now, this, if you see on the left-hand side, is a scale where we look to the time of exposure is on the y-axis, and on the x-axis, on the y-axis is the decibel of exposure. For each task, suppose if somebody is on an exposure of say about 93 decibel for about 1 hour, so this task gives an exposure of 80. And if you keep on adding this every hourly, you come to know how much is the risk of exposure for the population and how much the person is getting involved with this risk. So now these are the solutions. These are the hierarchy of controls like elimination, substitution, engineering control, administrative, and personal protection. So elimination is physical removal of the hazard, substitution is replacement of the hazard, engineering control is isolation of those patients from that hazard, administrative control is change the way people look. And the most effective is to eliminate, then to substitute, then to engineering control. And personal protection is very, very difficult. We move on the roads and we say the personal protection of the helmet is not there, the seat belt is not there. So how do you expect at a workplace? They want to be free when they want to work. So actions to reduce noise at the workplace: quiet equipments, less noisy equipments, maintenance, lubrication, reduce vibration, isolate the noise source in an isolated room, isolate the employee with that source.
The WHO guideline says in our outdoor living area, for 16 hours if somebody is sitting, at least the limit should be around 50 to 55. Hospitals as low as possible, ceremonies and festivals up to 100 decibels, music through headphone is 85. What we do is we increase the music when we are listening to the headphone. We are exposing ourselves to noise. The honking of cars, that is exposure to noise. So these are the guidelines which has been laid down, and this is where we need a lot of research to actually analyze the demographic area. We go in the hills, we feel very, very comfortable because there's no noise. We feel peace. Similarly, this has to be maintained where we are working. So the next step, the team plan to examine the data is more details for the insights to look to the source of transportation may have a great impact on health. Policy intervention should be done at every level, like enforcement of noise ordinance, rules for air traffic, low noise tires for vehicle, better building insulations for all these things. So in summary, many cities have got an alarming high level of noise, 12,000 premature deaths, 48,000 new cases of ischemic heart disease being contributed by one factor which can be avoided. Persistent and acute exposure to noise leads to more and more of cardiovascular risk, hypertension, anxiety, loss of sleep. Further research is needed and policy intervention for long-term exposure is needed. So thank you all for your patient listening, and this is what I wanted to contribute for this session.
Very nice, Dr. Saksena. I think the only thing is, probably we are living in a world these days. 20 years ago, you see the number of vehicles on the road, you see you could hardly count them. I mean, the number of vehicles today we have, probably I think this is a part and parcel of our life. You see, we can't avoid it. Can we?
We actually can't avoid it. That is why these hazards are coming, and when these hazards are coming, we need to avoid.
Talk about all the elimination and other things. You see, I think one can try. The only thing is, but day by day we are getting more and more of this noise pollution.
And that is why if you see a lot of patients, they come to our place with anxiety, lack of sleep. Now these are the causes, because their house somehow turns out to be in a mid street where there's a lot of honking or going around, or the television which has come into the room, the Netflix, the movies and all, they are at a high volume. So all these things are indirectly creating a problem. So this is the main topic why I took was just to identify that this is one problem. We need to look into it and we need to intervene so that slowly things can come back.
Because see, I think you are right. Because I've been in London, you see, and I know I was staying near Heathrow Airport, Hounslow. And every 40 seconds, there was a flight coming or going, you see. And the noise was so much, you see, people couldn't sleep. That's why they stopped all the flights at 11 o'clock in the night, you see, no flights from 11 to 5 in the morning.
Just because looking into the environment. So this is what their government has done.
Yeah.
For the benefit of their
I don't know anybody has done any study of the cardiovascular disease at that time, but what we have shown now today, maybe you see we are coming to that part only.
Yes.
Okay. Dr. Ashish, just wanted to, by wearing some devices like some earplugs which can reduce the noise, can that be helpful in?
Yes, sir. Yes, that can be helpful by wearing those earplugs, because this is mainly for our people who are working in industry. Now there is a lot of machinery involved, and the noise is above 110 decibel. So wearing something which can cover the ear, which can reduce the noise, or the machinery which can be of less noise, these things will actually improve. Now if you see, machinery is old, they are not greased, they are not serviced. So the noise level increases. So this indirectly creates a problem. So this is a professional occupational hazard, like we had silicosis. Similarly, this is also an occupational hazard which we are having in our country.
But I think it is very good, awareness lecture, because in India, noise pollution is not considered as pollution at all. You will see on roads, people honking, pressing horns just for the sake of fun.
And those musical horns which also create a problem.
And one of my friend came after 40 years to India. ਉਹਦੇ ਨਾਲ ਗੱਲ ਹੋ ਰਹੀ ਸੀ ਵੈਸੇ ਹੀ, ਕਹਿੰਦੇ ਯਾਰ ਹੌਰਨ ਬਹੁਤ ਵੱਜਦਾ। ਉਹ ਮੈਂ ਕਿਹਾ ਯਾਰ ਉਹਦੇ ਬ੍ਰੇਕ ਫੇਲ ਹੋਣ, ਕੋਈ ਪ੍ਰੋਬਲਮ ਹੋਵੇ, ਬੰਦਾ ਗੈਰੇਜ ਨਹੀਂ ਜਾਂਦਾ। ਹੌਰਨ ਨਾ ਚੱਲਦਾ ਹੋਵੇ, ਬੰਦਾ ਗੈਰੇਜ ਜਾਂਦਾ ਕਿ ਯਾਰ ਕਾਰ ਠੀਕ ਕਰਾ ਲਈਏ। ਸਾਡੇ ਉਰੇ horn driving ਹੈ, and we are not at all sensitive to noise pollution. So such lectures are definitely very informative, awareness generating, and I think government is also not sensitive to noise pollution at all.
I
Thank
remember,
you,
sir,
Dr.
when I was
Ashish.
in Germany, I was talking to my sister and she said that if we press a horn, the other person feels offended.
Offended, definitely. Definitely.
And over here, if you don't press a horn, he feels offended.
So that is why we call it as horn driving.
So that is why I took this topic, because it is actually creating a problem. Maybe another 10 years it will become something very big. So let us work today.
ਸਹੀ ਹੈ ਸਰ, ਉਹਨਾਂ ਨੂੰ ਹੌਰਨ ਤੋਂ ਬਾਅਦ ਜਦੋਂ ਤੱਕ ਹੌਰਨ ਨਾ ਚੱਲਦਾ ਹੋਵੇ, ਘੂੰ ਘੂੰ ਨਾ ਹੁੰਦੀ ਹੋਵੇ, ਉਹਨਾਂ ਨੂੰ ਫੀਲ ਹੀ ਨਹੀਂ ਆਉਂਦੀ ਵੀ ਮੈਂ MLA MP ਹਾਂ।
और सर गाड़ी में बैठे हैं ना, तो वो म्यूजिक सिस्टम भी बहुत ऊंचा हो जाता है. So these are all indirect things where we can reduce. These youngsters are here, they can understand the concept much better. So at least things can improve.
Thank you, Dr. Ashish, for coming to Bathinda.
Thank you,
and
sir.
we are really honored with your presence and lecture. Thank you very much.
Thank you so much.
Thank you, sir. For the next guest lecture, I would like to invite Dr. Sonu Sharma, DM Cardiology, Consultant Cardiologist, Delhi Heart Institute and Multi-Speciality Hospital at Bathinda, who would be presenting on the topic Recent Updates in Intervention Cardiology.
Good morning, everyone. Today we are here. Today I am here for discuss some of the recent changes which occurs in last 5 to 10 years in the field of cardiology, particularly the intervention cardiology field. So to start, before any intervention, we should have some knowledge of the drugs that are recently added in our cardiology unit. First, earlier we all know that warfarin and acetylom are the traditional anticoagulants we all use in our day-to-day practice. But now we have many options as anticoagulants like direct thrombin inhibitors, which includes dabigatran, then direct this factor 10 inhibitors like rivaroxaban, apixaban, and edoxaban. Basic doses for these newer anticoagulants is dabigatran 150 mg twice a day, apixaban 5 mg twice a day, edoxaban 60 mg once a day, and rivaroxaban is 20 mg once a day. So why they are why acetylom is, we all know that acetylom has many complications. Like first of all, they have acetylom has increased risk of intracranial bleed. Second, it requires frequent PTNR monitoring. So these are the basic two advantages which these NOACs are giving to our patients. Limitations of these are, first, of cost is much higher than that of acetylom. But now many companies have reduced patent and the dose is quite reduced as compared to 5 to 10 years earlier. Second is lack of antidote. Third is they are contraindicated in patients with history of post-valvular surgery because they have shown increased risk of valve thrombosis as compared to acetylom. Third is they are not to be used in patients of severe MS, while in other valvular disease they can now be used. Other contraindication is pregnancy and breastfeeding. Then in lipid lowering drugs, traditionally we all know that statins are the main drugs that are used to control our lipids. But now there are many other drugs that are added apart from statins. These are PCSK9 inhibitors. Basically, these are PCSK9 is an enzyme that leads to destruction of LDL receptors. But with the help of PCSK9 inhibitors, this receptor is prevented from destruction and LDL receptors level increases and ultimately reduction in the blood, reduction in the LDL level occurs. Other advantage of PCSK9 inhibitor is it is injected once a month or once in 15 days. Then third drug that is added for lipid control is this bempedoic acid has undergone approval by FDA in 2020. It is a non-statin drug. Mechanism of action is similar to that of statin, but in the same pathway as of statin. The main advantage is that it is only converted to active drug in the liver, not in the muscles. So one of the side effects of statin that is which leads to fatigue or this myopathy, problem in muscle, that is not seen with this bempedoic acid. It can be given along with statins or any other antilipidemic drugs. Then in heart failure, there are certain drugs that are added and shown advantages over the traditional guideline directed medical therapy. Traditionally, we have ACE inhibitors or ARBs, then aldosterone antagonist, then we use diuretics for symptomatic improvement. So these were the main, and lanoxin. These were the main drugs for heart failure 5 to 10 years earlier. But now we have ARNI. It has shown that in patients, even on control on ACE inhibitors or ARBs, we have to switch to ARNI because it is giving over and added mortality benefits and symptomatic benefits to the patients with heart failure. Then ivabradine. Traditionally, beta blockers are used for control of heart rate in heart failure patient, but if beta blockers are contraindicated, or even if patient is on beta blocker but still his heart rate is more than 70, then we can add ivabradine to further reduce the recurrent hospitalization in patients with heart failure. And third drug is SGLT2 inhibitors. We all know that these are mainly drugs that are used for diabetes management, but now they can be used in heart failure patients, even in non-diabetic heart failure patients as a heart failure drug across all the spectrums of heart failure patient, even in patient with heart failure with reduced ejection fraction or patient with heart failure with preserved ejection fraction, they have shown benefits in these patients. Then after drugs, we move on to investigations. Various newer investigations like 3D echo. Earlier we have traditionally 2D echoes, but now 3Ds we can have the knowledge of depth also, particularly useful for interventions like ASD closure. They are very useful. Then CT angio. CT angio has a sensitivity or specificity around, in 64 MD CT has around sensitivity of around 94% and specificity of around 97%. They are particularly beneficial in our day-to-day practice because most of the patients post-bypass lost their records. We don't know how much grafts we have implanted, and if they have symptoms of angina and we want to do an angiography without knowledge of the graft, it is very difficult to locate a graft. So in these types of patients, with the help of CT angio, we can easily know where are the grafts and how much grafts are there, and we can easily do the angio of that patient. Then MRI is now available in every field. It is also in cardiology, particularly useful in patients with cardiomyopathies because with the help of MRI, we can easily differentiate whether this is because of LV dysfunction is because of ischemic or non-ischemic. And in non-ischemic, it can be various specific factors that like mid-myocardial this enhancement occurs in patients with idiopathic cardiomyopathy, myocarditis, sarcoidosis, and other various diseases. Epicardial enhancement is seen in sarcoidosis, myocarditis, and subendocardial global enhancement is seen in amyloidosis and sarcoidosis. Like this is a patient, 47-year male, presented with complete heart block. What we usually do is we implant a pacemaker in these type of patients. But if we do a cardiac MRI of this patient, then we see a certain mid-myocardial enhancement, then this could be a patient of sarcoidosis, and sarcoidosis has increased risk of ventricular tachycardia. So, so in this patient, the treatment of choice would be ICD, not a pacemaker. Now in interventions, like there is ultrasound in every field, or similarly we can do the ultrasound of the coronary arteries. With this IVUS, we can see all the 3 layers of the coronary artery, and we can diagnose the percentage stenosis, and particularly useful in patients for intervention. If they develop complication, we can know that what is the reason for no flow or reduced flow in a coronary artery post-intervention. Like an example, these 2 arrows, in a normal angiography, there is not much stenosis is seen in both these arrows. But the upper one arrow, in an IVUS, there is almost no blockage inside the coronary artery. But at the lower arrow, which is seen here, there is around 50% stenosis inside the coronary artery. So we can easily calculate various plaque stenosis with the help of IVUS. Then similar to IVUS, if infrared rays are used, then it is known as OCT. OCT is similar to IVUS. We can use, see the intracoronary stenosis and various types of plaques that are present in the coronary artery. Then thrombectomy catheters are used for particularly in acute coronary syndrome. The most there is thrombus formation inside the coronary artery, which leads to blockage of the coronary artery. Then these thrombectomy catheters, with the help of these catheters, we can remove the clot. Like these are the clots which we remove from coronary arteries. Then there is embolic protection devices. They are particularly useful in patients with graft intervention, because when we do the graft intervention, there is clot can go forward. With the help of these embolic protection devices, we can prevent the complications like no flow in the grafts. They are also useful in this carotid intervention to prevent the embolization of plaque inside the brain. So these are the main benefits of these embolic protection devices. Then valvular lesions. First of all, in valvular lesions like MS, we can do balloon mitral valvuloplasty like BMV in these patients. These are the instruments used for BMV. This is how a BMV is done. We go through the femoral into the RA, then into the LA, pass a wire across the LA and do the balloon valvuloplasty of the mitral stenosis. I think video is not playing. Then second, after MS, if there is PS, we can do the balloon pulmonary valvuloplasty of the pulmonary wall. This is a patient of pulmonary stenosis. There is gradient across the pulmonary wall. RV is hypertrophied, RA is dilated. Then these are the gradient across the pulmonary wall. These are the stills. We do a RV angiogram. There is stenosis at the pulmonary stenosis is there. This jet is narrowed at this point. Then with the help of balloon, we just dilate the pulmonary wall and we can treat the patient without any major surgery. So after MS and PS, for aortic stenosis, there is transcatheter aortic valve implantation. TAVI is now generally accepted as a new standard of care for patients with symptomatic AS who are not an candidates of open surgery. Around 1/3 of the patients with severe AS in real world are unsuitable for surgery. For these types of, and they have a high mortality and morbidity. So these types of patients, we can do TAVI. And now this transcatheter aortic implantation in recent studies have shown even patients with moderate risk factors for surgery, they have gone equivalent resistance to that of the surgical patients. These are the various valves that are available for transcatheter aortic valve implantation, like SAPIEN XT and the core valve. So after aortic valve, we can do transcatheter pulmonary valve implantation also without need of surgery, that like other interventions go through the femoral route and we can implant the pulmonary valve inside the pulmonary annulus. Two types of valves that are approved for pulmonary valve implantation, these are Melody and the SAPIEN. Then for mitral regurgitation, we have MitraClip. These are to be, this is approved to be used in patients with primary abnormalities of mitral apparatus that have increased risk of valvular surgery. Though we can use MitraClip to reduce the mitral diameter and prevent and reduce the severity of mitral regurgitation. It can also be used in patients with secondary MR with severe LV dysfunction, in which surgery is not possible. This is how a MitraClip looks like. Then there is, then we can do for mitral valve, we have transcatheter mitral valve implantation. So aortic valve implantation, pulmonary valve implantation, and mitral valve implantation. This is under research purpose, is not approved still. All these valves are not approved for management of a patient, but in upcoming years they may be approved for treatment of a patient. Now after the valves, there are certain devices. This is a leadless. Earlier we used know that there is in a pacemaker there is a battery that is inserted below the infraclavicular area and a lead that is inserted inside the RV. But now we have leadless pacemaker. There is no need for lead. Just a AAA battery size pacemaker inserted through the femoral vein inside the RV, and there is no stitch mark or no sutures. Simple plantation of the pacemaker can be done with minimal risk of infection, and there is no lead related complications with this. This is how a leadless pacemaker look like. Then similarly, ICD, there is also a battery implanted traditionally below the infraclavicular area, and the leads is placed inside the RV. But now the newer subcutaneous ICD is there, in which we can implant a lead just below the skin, parallel to the sternum, and a battery is inserted below the 4th to 5th intercostal space, and there is no need to go transvenous inside the vein. So lesser risk of infection with these types of ICDs. Then for LV dysfunction, patients with having LVEF less than 35% with LVVB, in these type of patients, we can do the CRT, which can increase the ejection fraction of the patients. This is how CRTD look. There are 3 leads in this. One lead is placed inside the RV, second in the RA, and third in the lateral wall of the LV. So apart from these, for neurology point of view, we have certain interventions like in stroke. We all know that AF is the most common cause of stroke in a patient. It affects around 1 to 2% of general populations, and 90% of stroke that occurs in a patient, the thrombus is originated from the left atrial appendage. So if we clamp or isolate the left atrial appendage, we can reduce the risk of stroke with AF by around 90% without the use of drug. So we all know that warfarin is used in a patient with AF having stroke, or patients with AF which increase risk of stroke. Warfarin is used which reduces the risk of stroke by around 60% and all-cause mortality by around 26%. And the antiplatelet which we use reduce the risk of stroke by around 22%. Mortality reduction is not seen with antiplatelets. So this is the Watchman device, which leads to left atrial appendage closure and can reduce the risk of stroke in patients with AF. It is approved to be used in patients who have contraindications for anticoagulation therapy, or who developing recurrent stroke in spite of having acetrom. So this is the device, just close the left atrial appendage. Then for PDA, there is a PDA occlusion device. So there is no need for surgery, just go through the femoral vein and insert this device and block the PDA. This is how there is a connection between aorta and pulmonary artery. This is PDA. This is the device. We implant the device, and the connection is stopped from blood is stopped from going from aorta to the pulmonary artery. Then his bundle pacing. Earlier in the pacemaker, we used to pace the RV, which leads to left ventral branch block pattern and ultimately leads to LV dysfunction in the long run. So to treat this problem, there is now research for pacing of the his bundle. So it will be a more physiological process and physiological pacing. So ultimately, LVV pattern will not occur, and the LV dysfunction which we see in with the while pacing the RV will be reduced. For tachyarrhythmias like SVTs, this EP study and RFA radiofrequency ablation is treatment of choice. It can lead to around 95% success rate in patients with tachycardias, particularly SVTs, and patient can be removed from drugs, any drugs, and can have a normal life with these interventions. This is how these are the various catheters that are used for radiofrequency ablation. For carotid stenosis, a patient with stroke having carotid stenosis, we can do the stenting of the carotid stenosis and reduce the recurrency of the stroke in these types of patients. Then for peripheral artery disease, we can treat them by simple balloon angioplasty, or stenting can be done. Balloon angioplasty for infra knee lesions and stenting for above knee lesions. Then for aortic aneurysm, earlier we used to do aortic surgeries which are having high mortality and high morbidity. Now these can be treated with the help of endovascular aortic repair. This is how endovascular aortic repair is done. This is an infrarenal aortic aneurysm. This is endograft that is inserted inside the aorta from transfemoral route, and that aneurysm is separated from the aorta, and it will gradually shrink. There is no need for major aortic surgery. Then for renal artery stenosis, particularly in patients with refractory blood pressure, even on 3 or more antihypertensive patients, on antihypertensive drugs, BP is not controlled, and on ultrasound Doppler, we found there is renal artery stenosis or there is recurrence flash edema in these, if any patient with renal artery stenosis, then renal artery intervention is to be done. This is how, before renal artery stenosis, there is around 90% stenosis in the renal artery, and post stenting, thus there is a good result with not a significant stenosis within the renal artery. This was done on both the sides of the patients, and the patient which was earlier on four drugs but still having BP more than 160, his blood pressure comes under control with the help of single Amlong 5 mg after these stenting. So these are the various interventions that are coming up and which we are doing in the recent 5 to 10 years. These are the various advantages a cardiology has come across. Thank you for your patience listening.
Any questions?
Any question?
Thank you, Dr. Sonu, for an excellent talk. And we come to know what you are in fact doing in Delhi Heart Center. And I think technological advances are a great boon for cardiology. Thank you very much for delivering this lecture during
for giving
MAPICON.
this
Thank you
opportunity.
very much. Thank you.
Thank you, sir. For the next lecture, I would like to invite Dr. J.S. Bhaiya, MD Medicine, Professor, Department of Medicine, MMMCNH, Kumarhatti, Solan, who will be presenting on the topic Immunity and COVID.
Very good morning, all of you. So, the first of all, I must say thanks to the organizer of MAPICON, Dr. Professor Bitul Gupta, so who has invited me to deliver a lecture on COVID and immunity. So, immune system is a very debatable issue because of COVID, because of lot of pandemics are there. Human civilization is always having threat because of the invisible enemies, microorganisms like viruses and bacteria. In the past, a lot of pandemics occur. So, here is the college where I belong to this city, but so I work at MM Medical College, Solan. So, my lecture includes pandemics, immunity, COVID, and vaccines. Because a lot of debates on vaccine, whether we should use RNA vaccine or not, but what is the safest vaccine, and what sort of vaccines are safe, effective, and having long-lasting immunity. The immune system, when you are going to give a vaccine to someone, you are going to stimulate the immune system. That immune system is responsible for the protection. Immune system is responsible for that protection. So a lot of see the pandemics, the first, we still remember it's called Black Death. Black Death occurred way back in 1345 to 1350. So in the span of that year, it almost killed about 75 lakhs to 100 lakhs people. So still one of the biggest killer in the human history. The Black Death. It's Black Death is nothing, it's a bubonic plague. Plague is spread by the rats. So you can imagine how deadly it was in the era when there was very less antibiotics and health facilities are very very less common and available to the all common people. So after Black Death, there was a Spanish flu, you may call influenza. That influenza almost wiped out near about half of the population of Europe and America too. After that, the HIV pandemics occur. And recently, we don't know whether it's over or yet to be over, the COVID, and killed near about, you can see, it supersedes already more than 65 lakhs. Data is debatable. Some countries are saying that it's underreported. The lot of hue and cry about the Lancet study recently, India is underreporting the COVID death. But, okay, still, it's according to the American tracking system, the 65 lakhs, it's more than the Spanish flu, more than the Spanish flu, the influenza. So, immunity, second is immunity. Immune system, when the foreign body is going to enter in our body, there is a protection of our body from these foreign elements. So, immunity may involve specific or non-specific components. Non-specific barriers like skin, like body secretions are the non-specific barrier which can eliminate the pathogens. And the specific one can generate a specific type of immunity against that. So type of immune system, you can see the type of immune system. This is the immune system, how the immunities work. Innate immunity and then adaptive immunity. Adaptive immunity again subdivided into naturally. Okay, someone may have infection naturally, and like a very good example is known as chickenpox. In chickenpox, when the exposure occurs and body is immune for lifelong. Second is passive immunity. Okay, through the placenta we can get from mother, through the placental blood, the antibodies, and that can protect us from that. This is from the foreign element, from the pathogens. This is the natural immunity. Then artificial immunity, like we are going to immunize the patient, like a COVID vaccine would produce a specific type of cell type of immunity and antibodies. And passively you can introduce the antibodies and specific cell mediated cell which are ready-made. So innate and adaptive immunity. Innate immunity is present in all multicellular organisms, and adaptive immunity is present only in the vertebrate animals. Innate immunity produces two types of response, inflammatory and phagocytosis. And innate immunity is responsible for prevention from the infection and maintenance of homeostasis and contribute in the formation of adaptive immune response. Three functions: prevention, maintenance, and contribute in the form of adaptive immune response. So adaptive immunity, it's a so-called tailor-made response, specific to the specific antigen. Specific to the specific antigen, and very advanced form of lymphocyte. B lymphocyte and T lymphocytes are involved. B lymphocyte produce the antibody and T lymphocytes are responsible for cell-mediated immunity. And these specific lymphocytes are responsible for distinguish self and the foreigner. And that's called immunity. Adaptive immunity is it's a specific mediated lymphocytes are present. And as I told earlier too, it could be adaptive immunity, could be natural, could be artificial. Natural, when the body exposure occurs to the pathogens and body is going to produce antibodies and cell-mediated immunity. So this is the natural immunity. Natural immunity, the very good example is the chickenpox. okay, or exposure to the COVID may have antibodies, artificial delivery action of vaccination through the artificial route. So, adaptive immunity could be natural by the exposure of pathogens and artificial through the vaccination. Through the vaccine. Adaptive immunity, again active and passive. Active is when you are going to give the exposure and body is going to produce the antibodies. And passive is when you are going to antibodies, synthetic antibodies and synthetic activated T cell. Is the, but the passive immunity is short-lived and may require booster dose. See, same is here. Okay, the natural adaptive immunity could be natural, could be artificial, and natural could be passive or active through the infections. The passive is through the placental blood. Artificial, okay, you are going to immunize the patient and going to produce the antibodies and cell-mediated immunity. Passive, and you are going to transfer the antibodies and T cells. So, adaptive immunity, lot of cells are involved in adaptive immunity. One is going to produce the antibodies. Second is cell-mediated immunity and like having the memory cells. So, B cells generally are responsible for the production of antibodies and T cells are responsible for the memory cell, production of memory cell and cell-mediated response. So other specialized cell also involved in immunity, natural killer cell and T cell and B cell and the leukocytes are also taking part in the process of immune system. So herd immunity, you must have heard the herd immunity, that much percentage of persons either may have natural exposure to the disease or through the vaccination. If more than 70% population or community is having antibody or exposure to the disease, is called a sufficient amount of herd immunity is there. Now, in COVID, they are saying that 80% herd immunity must be there. The term is related to the immunity, and when we are saying we are protected and we are having a sufficient amount of herd immunity if it is more than 80% in case of COVID. So now COVID, you all know is as very well known and it's but the modified form proved to be killer. And that disease, that virus emerged in the Wuhan. Okay, that's why it's called COVID-19 disease. It's first time detected, that variant is detected in Wuhan. And it's the virus is quite similar to if you identify with the bad coronavirus. The coronavirus, it is a zoonotic disease, it's present, the reservoir is in the. And if you want to see, this is the structure of that virus, okay? The lot of spikes, the crones are present, okay? And is having the core, the RNA, the genetic material, RNA, and then the envelope, that is the envelope, then having the protein, spikes of protein, okay, S, E, and M proteins. We are going to produce the vaccine, okay, by stimulating through the virus M protein and S protein and G. So the membrane protein and envelope protein and the nucleocapsid proteins and the spikes protein S are present in this. This is the structure of that virus and helps. You all know the symptoms of COVID, and COVID is having the mortality rate is 2 to 3%. But you imagine the bubonic plague and Spanish flu is having the mortality rate is more than 10%, okay, 10 to 12%. So still it's proved to be, I think, the great killer in the human history. So very less percentage of people having the severe COVID symptoms who are immunocompromised and having the comorbid conditions. So this is all. So you all know it's a transmission occurs through either droplet infection and contaminated surfaces, okay, and So diagnosis, you know that the diagnostic test is PCR. PCR is the diagnostic test. There are all other diagnostic techniques are available, nothing to see. How this COVID is responsible for infection, serious infection, and can infect the lungs, brain, kidney, and heart. Why it's so? It's all because of this, okay, renin-angiotensin RAS system. It's going to act on that. You all know angiotensinogen is converted to angiotensin 1, and then converting enzymes are responsible for conversion of angiotensin 2. This 2 is having a receptor. This is going to act on these receptor. Those are the receptors are, okay, enzyme and converting enzyme 2 receptors are available on the surface of lungs, lung tissue, and heart, kidney, and brain. So it's going to enter the host cell. How it's going to enter in the host cell? You see. So here is the first part is the virus where how it's going to enter the human body, and second part how the immune system or vaccinated person or person is having sufficient amount of immunity is responsible to tackle the COVID. So here this virus is going to enter in the nasal mucosa. After that, this is epithelial cell through the converting enzyme 2 receptor. Then it's going to produce a lot of ions. So here is the term one is, you must be knowing that one is the transcription, second is the translation. Transcription is the formation, reverse transcriptase is the enzyme responsible for formation of DNA from RNA. If transcription is DNA to RNA, then translation, this RNA is responsible for formation of the protein, the viral protein. That viral protein is responsible for transmission of disease, lot of viral proteins. So how the mild to moderate COVID? This is the storm, the very severe, there are a lot of inflammatory markers are present and lot of cells are involved in COVID. And this is called so-called inflammatory storms occur. That inflammatory storms can block the small blood vessels, capillaries, and patient may have difficulty in breathing and may have the severe feature of ARDS, may have myocarditis, or may have kidney failure, and may have even then stroke too. Because of blockage, you can see here lot of migratory macrophages and lot of lymphocytes and neutrophils. All cells are involved, and in the mild form they can tackle here. This is the you can see this is the virus, and here the lot of cells are coming, and lot of inflammatory markers are released by these cells and responsible for blockage of the small blood vessel, and patient may have severe respiratory distress. So entry may affect the respiratory system. You all know in the nervous system, the first is the olfactory valve, and patient may have symptoms like loss of smell and the brain stroke too. So cardiovascular system, 20% may have acute, 12% patient may have acute myocardial injury and higher incidences of thrombosis and MI and the venous thromboembolic phenomena too, because of blockage of the small blood vessel. So GI2 may affect the gastric ulceration and upper and lower GI bleed too because of COVID. Can affect all the organs. Kidney is very much important. The autopsy was done in the patient who died because of COVID in China and New York, and found that 30% patient is having kidney failure. It's all because of blockage of this. So I was telling the laboratory findings are indicators of elevated of lot of inflammatory marker, interleukins 2, 7 and 6, and then GMG, colony stimulating factor, then interferon gamma induced proteins, monocyte, chemoattractant proteins attract more and more cell macrophage inflammatory proteins alpha and TM, tumor necrosis factor, are responsible for cytokine release syndrome. Cytokine release syndrome. So cytokine release syndrome additionally is very much important, is elevated, can cause cytokine release syndrome. How we can diagnose with the help of, if a lot of markers are present, then elevated CRP, okay, LDH, D dimer, and the ferritin level. For monitoring the treatment and patient in ICU, D dimer is, that's why it's very much important for titration and monitoring the patient in ICU. So vaccine okay, the concept of vaccine, either RNA vaccine or subunit vaccine or viral vector vaccine. So how to tackle this this COVID distress syndrome or acute respiratory syndrome, severe acute respiratory syndrome, renal failure or thrombotic phenomena? Okay, it's all because you should have sufficient amount of immunities. Okay, to boost the immune system, to produce the immunity, to achieve the herd immunity in the community or in the population. In that situation, the people thought the emergency use of vaccine. We need to produce vaccine because it's very difficult to attain a herd immunity level with the natural infection. So they proposed various methods to produce the vaccine, is either RNA vaccine. The most common and most effective vaccine is till date is RNA vaccine. How this conceptual diagram showing how the RNA encoded number 1, the virus, then the surface protein, then the vector virus. Okay, all are stimulating the immune system and producing the sufficient amount of antibodies and cell-mediated immunities. Why is the cell-mediated immunity is important? Because sometimes with the passage of time, the antibody level is going to decrease. But if the memory cells, T memory cells are present in sufficient amount, they will recognize the reinfection and would produce antibodies when it's required. So this is not important. So RNA vaccine basically are same diagram. RNA vaccine is this sort of diagram is going to explain. Okay, the RNA is going to introduce in the human cell. It's going to translate and would produce. Translate is the translation is the formation of protein from RNA and would produce a lot of protein, and these proteins, viral protein, is going to simulate the immune response and produce both antibodies and T cell mediated immunity. Okay, this is how RNA, this is written RNA. The most common is the Pfizer and Moderna vaccine available in India and US and European country is on the basis of either RNA or RNA messenger. Then adenovirus vaccine is also very much available in India and in the European country. Is the most common is Oxford and AstraZeneca vaccine, in which these vaccines are example of non-replicating viral vector vaccine using the adenovirus shell containing DNA encoded with COVID virus protein. Here is that's why it's called adenovirus vector vaccine. Vector is the adenovirus and encoded with a COVID S protein or M protein, and it's going to produce the antibodies. It's a non-replicating virus, but is responsible for the production of adequate amount of immunity. Same is here, same diagram. So inactivated viruses, lot of part of viruses may be S protein, may be N proteins, okay, are viruses are cultured then denatured either with the heat or formaldehyde. Their parts are responsible for induce the immunities. And this is the Indian covaxin which is available. Subjoint vaccines, the part again same, the same technique. Some part of virus is responsible for the production of antibodies, anti-T cell mediated immunity. Other types of virus like particle vaccine, DNA, plasmid vaccines are also under process for to tackle the COVID. So vaccine, basically vaccine RNA or the emergency use of vaccine is quite a debatable issue. Our body is having DNA. So if the RNA is going to give in our body and may have some harmful effect. Second, the emergency use of these virus vaccines. Emergency use. So all the formation of vaccine, this is the abstract of this journal. The formation of vaccine required lot of safety trials and efficacy trials and side effect trials. So all these vaccine we are getting in the form of first dose, second dose or booster dose, they have given a permission to use in emergency use. So in this process, some safety norms are compromised. Still, it seems to be we are nipping in the bud and we are controlling the great pandemic, okay, which is the second largest cause of death after Black Death. Thank you very much. This is all about the COVID. Thank you.
Thank you, Dr. Bhaiya, for a good talk on immunity and COVID, because this is rather important topic on which I think Baba Ramdev has earned crores and crores. You know, asking people to take his medicine to boost immunity. Thank you very much. And we are honored to have a director, producer, actor and singer, as well as professor in medicine here during MAPICON. Thank you very much, Dr. Bhai.
Thank you, Ji.
Thank you.
Thank you, sir. Any other question? But basically the immunity, the branch of study of immunity or immunology is coming, and some institutes are going to start a DM immunology. It's already started at SGPGI Lucknow. Immunology, DM in immunology. Thank you, sir.
Thank you.
Thank you, sir. Our next guest speaker is Dr. Srishti Arora, MD Radiology, DMCH, Ludhiana, Consultant Radiologist, Star Imaging and Diagnostics, Ludhiana, who will be presenting on the topic Imaging in Small Bowel Obstruction.
So it is always good to have young doctors enthusiastic, and next time we are planning to have half of the lectures by doctors less than 35 years. It is really motivating to have you, Dr. Srishti, here. Thank you very much for coming.
A very good afternoon to all present. I would like to thank you, sir, for having me here, and I would like to congratulate you on organizing this academic extravaganza. The topic for today is small bowel obstruction and the advances in imaging. First, a few words about the incidence. 12 to 16% of hospital admissions are due to small bowel obstruction for the evaluation of acute abdominal pain, and the mortality ranges from 2 to 8%, but it may increase to as high as 25% if bowel ischemia is present. The learning objectives of today's session are to substantiate the importance of imaging in the diagnosis of small bowel obstruction and to illustrate the imaging findings of different causes of small bowel obstruction. A few words about the causes of small bowel obstruction. They can be divided into intrinsic causes, extrinsic causes, and the intraliminal causes. Intrinsic causes include the wall abnormalities like the inflammatory diseases, tuberculosis, Crohn's, eosinophilic gastroenteritis, neoplasias like primary tumors or secondary tumors, vascular lesions, hematoma, intussusception. They all account for intrinsic causes. Extrinsic causes are adhesions, which is the most common cause of small bowel obstruction, hernias, endometriosis, and hematomas. The intraliminal causes include gallstones, bezoars, and foreign bodies. What are the goals of imaging? Why do we go for radiological investigations? The first is to diagnose small bowel obstruction. Second and most important is to assist in therapeutic decision. That is whether to go for conservative management or to go for surgery. And third is to detect the complications that require prompt surgery. That is the strangulated obstruction and closed loop obstruction. Five major questions that imaging addresses are: first, is the small bowel obstructed? Second is, how severe is the obstruction? Where is it located? What is its cause? Is it simple or complicated? And the various imaging modalities that are used are radiographs, ultrasound, barium studies, multiplanar CT, and MRI. When a patient comes to you in the emergency department with abdominal pain, vomiting, distension, the first investigation that is done is radiographs, that is X-rays. It is widely available, inexpensive, but it is diagnostic only in 50 to 60% of the cases of small bowel obstruction. The findings of small bowel obstruction on a supine radiograph are dilated, gas-filled small bowel, more than 3 centimeter. We can see that the small bowel loops are dilated here, and there is minimal gas in colon. On erect radiographs, the finding of small bowel obstruction, particularly high-grade obstruction, is multiple air fluid levels, at least 3 air fluid levels, each more than 2.5 centimeter in width and at unequal heights in the same loop. X-ray is very useful in detecting this grave complication of small bowel obstruction, which is pneumoperitoneum. It happens in cases of bowel perforation, and we can see it as free air under the dome of diaphragm. But X-ray provides a diagnostic challenge in cases of gasless abdomen. What is gasless abdomen? The dilated bowel loops are fluid-filled, and fluid is seen as completely white on X-rays. We cannot see the dilated small bowel loops. It cannot diagnose high-grade obstruction, which is filled with fluid. The bowel loops are filled with fluid, and it cannot diagnose complicated obstruction. Barium, a word about barium studies. It has no role in high-grade obstruction or suspected perforation and a very limited role in low-grade obstruction. It allows the evaluation of mucosal abnormalities only and provides no information about the bowel wall, peritoneal cavity, and the abdominal solid organs. Ultrasound also has a limited role when it comes to small bowel obstruction. The role is only when the bowel loops are filled with fluid. This is in contrast to X-ray we discussed. Then when the bowel loops are dilated and gas-filled, then X-ray is useful, and ultrasound is useful when they are dilated and fluid-filled. The findings of small bowel obstruction on ultrasound are dilated fluid-filled small bowel loops, which measure more than 2.5 centimeter, to and fro peristalsis, and grave signs which indicate that high-grade obstruction is present are free fluid, aperistalsis, that is no peristalsis, wall thickening. Wall thickening can indicate impending ischemia. This is an ultrasound picture of small bowel obstruction in which we can see the dilated small bowel loops. The best imaging tool with sensitivity and specificity of 95% is multi-detector CT. What are the advantages? It helps in identification of transition zone. What is transition zone? It is very important to diagnose small bowel obstruction. The transition zone is when the dilated bowel loop transitions to the collapsed bowel loop. CT is also useful in determining a specific cause of obstruction, and it provides an excellent evaluation of the bowel wall, its vessels, and adjacent mesentery. It is also very useful for diagnosing bowel perforation. A major question that comes to all of our minds when going referring the patient for CT scan is, what kind of CT scan? Do we need to give oral contrast or not? Do we need to give IV contrast? I will be discussing it all. Oral contrast. If an abdominal radiograph, bowel loops are dilated, proceed for CT without any oral contrast. It's of no use in putting the patient through so much distress when we know the patient is already in obstruction, giving him more and more fluid, loading him up with fluid. And oral contrast should not be used if high-grade small bowel obstruction is known or suspected. Oral contrast when to give? When there is a clinical uncertainty of diagnosis and a possibility of low-grade obstruction. And try to give neutral contrast agent, not the positive oral contrast, because when giving positive oral contrast, it also appears as white on CT scan. And we cannot appreciate the wall thickening if we give positive oral contrast. Intravenous contrast is recommended as a routine unless there is a contraindication. Why? To assess the bowel wall enhancement and to detect vascular thrombosis. Now, coming on to the questions that CT answers. Is the small bowel obstructed? When do we say it is obstructed? When there are dilated small bowel loops measuring more than 2.5 centimeter proximally, and distally we have normal caliber or collapsed bowel loops. This is an axial CT image showing dilated proximal small bowel loops. And distally, as we go, there we can see that the bowel loops are transitioning to narrower caliber. And how severe is the obstruction? Whenever there is a 50% difference in caliber between the proximal dilated bowel and the distal collapsed bowel, it is indicated as high-grade obstruction, that is severe obstruction. And the presence of small bowel feces sign is also an indicator of severe obstruction. What is small bowel feces sign? Normally we see feces in colon only on CT scan. If intraluminal particulate matter mixed with air is seen in small bowel, it indicates that the obstruction is severe. This is a coronal reformatted image in which we can see the small bowel feces sign, and this is very beautifully depicts the zone of transition. Dilated proximal small bowel loops, and distally there are collapsed small bowel loops. Where is the transition point? The transition point is determined by identifying a caliber change, as we have already discussed, and usually the small bowel feces sign is seen just proximal to the transition point. And CT also helps in finding the cause of obstruction. A rule of thumb is answer is almost always in the transition point. Most intrinsic bowel lesions manifest as localized mural thickening at the transition point. Most extrinsic causes are seen adjacent to the transition point, and most intraluminal causes manifest as endoluminal foreign objects. We'll be discussing a few cases. We'll be seeing a few cases and the causes of small bowel obstruction. First, intrinsic causes. This is a case of 48-year-old male with vomitings and abdominal pain. In this we can see coronal image, we can see that this proximal jejunum is dilated, measuring 4.8 centimeter in caliber, and there is asymmetric diffuse circumferential wall thickening here, with wall thickness measuring 12.4 mm. Normal wall thickness of small bowel is just 1.1 to 2 mm. And adjacent to this, we can see that there are multiple lymph nodes. So this was a case of jejunal adenocarcinoma, causing proximal small bowel obstruction. Second is the case of 54-year-old female with chief complaints of pain, abdomen, vomiting, and distension. This is a case of severe intussusception. We can see the bowel within the bowel appearance. A large segment of small bowel has proximally gone into the proximal small bowel, causing obstruction along with its mesentery. Next is the case of 60-year-old female with abdominal pain, distension, and vomiting. Proximally dilated small bowel loops are seen, and as we go caudally in the right iliac fossa, we can see the thickening of terminal ileum, which is collapsed, and fatty proliferation of the mesentery. This is a case of Crohn's disease. This is a case of 59-year-old male who presented with abdominal distension and vomitings. In this coronal image, we can see that there is a long segment non-opacification of the superior mesenteric artery, and gas is seen within the bowel wall. This is a case of arterial mesenteric ischemia with pneumatosis intestinalis. Coming on to extrinsic causes, a 56-year-old male with history of appendectomy now presented with abdominal distension, pain and vomiting. Proximally, we can see the dilated small bowel loops, and this image depicts the transition zone. This is the transition zone, the proximal dilated small bowel loop, and distally the collapsed small bowel loop. And adjacent to the transition zone, we do not see any wall thickening inside the bowel loop or any SOL. So this was a case of adhesions due to previous appendectomy, causing small bowel obstruction. Then is a 50-year-old male who presented with abdominal distension and pain. This was a case of ventral incarcerated hernia causing proximal small bowel obstruction. In this case, the female presented with pain, abdominal distension, and the dilated small bowel loops can be seen, and we can see the swirling sign of the mesentery. It is a case of midgut volvulus with intestinal obstruction. In a few intraliminal causes of small bowel obstruction, patient with severe pain and right hypochondrium, fever and abdominal distension, dilated stomach, small bowel loops are seen, jejunal loops are seen. In this image also, we can see grossly distended stomach, grossly dilated jejunal loops. And in this section, we can see the cause of the obstruction. A stone impacted in the jejunal loop. This was a case of gallstone ileus. Another question that is addressed by CT is it simple or complicated? CT is a very useful imaging modality in detecting bowel ischemia or strangulation and perforation. Signs of bowel ischemia are bowel wall thickening, mesenteric edema and of fluid in the adjacent mesentery or peritoneal space, abnormal decreased bowel wall enhancement, and pneumatosis with or without gas in mesenteric or portal veins. In this coronal CT image, we can see the gas within the bowel wall. This is a sign of pneumatosis intestinalis, bowel ischemia. And this is pneumoperitoneum, free air in the intraperitoneal cavity. A word about MRI. MRI is not routinely used for the diagnosis of small bowel obstruction. The only indications are pregnant patients with known or suspected small bowel obstruction and younger patients with repetitive episodes of obstruction to minimize the radiation exposure, like young patients with Crohn's disease. They need frequent CTs for monitoring. So we go for MRI in them. A word about CT and MR enteroclysis. The only indication is low-grade small bowel obstruction, but it is an invasive procedure in which nasojejunal feeding tube is inserted and enteral volume challenge is given to provide optimal bowel distension. So the take-home message is radiographs are and will be the initial imaging modality. Multi-detector contrast-enhanced CT is the best imaging tool for evaluating high-grade small bowel obstruction. CT enterography is the preferred modality for low-grade obstruction, and MRI is currently reserved for specific indications only. Thank you.
Thank you very much for an excellent talk in such a brief time on this vast topic. So I think next year I invite you to present us with the future of radiology.
Thank you so
right?
much. Sure, sir.
Because half of us don't know what is going to happen in the future. It is like, a science fiction type of a thing.
Yeah.
So I invite you for next year. I extend my invitation to you now.
Thank you so
devise
much.
a good
It's a
topic
privilege.
so that we know what is going to happen in future in radio diagnosis. Because I think radiologists are the most intelligent people because they have to know each and every subject to perfection. So that is how you are going to diagnose whether it is medicine, it is eye, it is ENT. Every person is going to come to you. So thank you, Dr.
Thank you, sir.
Sristi, for this excellent talk. And keep in mind that you are going to come next year also for MAPICON.
Thank you so much, sir. Thank you.
Thank you, ma'am. For our next guest lecture, I would like to invite Dr. Anjali Bansal, MD Pediatrics, PG DHM, Senior Consultant, Women and Children Hospital, District Hospital Bathinda, who will be presenting the lecture on pubertal problems in office practice.
A very good morning, everyone, all my seniors and the colleagues and delegates. First of all, I want to thank Dr. Vitul Gupta for giving me the chance for a pediatric presentation over this platform. So, before wasting much time, we would like to go ahead with our lecture today. Puberty, as all of we know, it's an important part of one's life. So daily as a pediatrician and also as even some of the medicine consultants might be having pubertal kids or adolescent age groups in their OPDs or clinics for routine problems. So we will be discussing today the office problems occurring during this age group. So puberty is when it gets difficult for the parents. So how do we define this? It's a transitional state from childhood to adulthood and manifested by physiological changes and development of secondary sexual characters. Does puberty occur at the same time in boys and girls? Anyone knows? So we'll be discussing this. What is the age of onset of puberty? What are the order of events in girls and boys? This is an important topic for my MBBS students also. So here in this slide, we'll be discussing what are the physical changes. In males, as we can see in the slide, there is growth spurt, there is increase in lean muscle mass, changes in body composition, increase in penile length, pubic hair, and testicular enlargement. Similarly, in females, there is growth spurt, there is breast development, there is changes in body composition, pubic hair, menarche, and increase in fat mass. So what is the sequence of order in boys and girls? So in puberty in girls, first there is thelarche, that is the growth of breast, which occurs usually at the age of 9 to 10 years, then followed by pubarche, that is pubic hair, 11 to 12 years. Then last, it is menarche, that is 12 to 13 years. In boys, the first change as we see the boy enter a pubertal age is increase in the testicular volume. That is at the age of 11 to 12 years. Normally, the size, the volume of the testes increases to more than 4 ml. Then there is pubic and facial hair at 12 to 13 years, penile growth 13 to 14. Then there is height spurt 13 to 14 years, followed by spermarche, that is sperm start appearing in the urine at 14 to 15 years. And then there is 10th spurt at 15 to 16 years. So these are the sequence of events as we see puberty in girls and in boys. So here in this slide, we are here to see the peak height velocity. So mostly the common question which comes to the parents is, my girl has started menarche, is she be having increase in her size later on in her life, or for how long there will be increase in size? Similarly in boys also there is a lot going on in the mind of the parents that whether the boy will reach his maximum height or not. So here in this graph, as we see, the peak height velocity, that is about 8 to 9 centimeter, it is between the breast development, SMR staging 2 and menarche. Still after menarche, the girl reaches its height, but the velocity is less, that is 4 to 5 centimeter. In boys, the increase in height as is seen in the graph is up to 18 years. So the maximum increase is seen in between 12 to 15 years. That is when there is pubic hair stage 2 to the sperm in the urine, that is spermarche. In that period, we see the peak height velocity, which is around 10 centimeter per year. But boys tend to grow till 18 years of age as compared to the girls who stop growing around 2 to 3 years after menarche. So as we have already studied in our MBBS time also, the SMR staging, which is an important part of examination of an adolescent child, when he or she comes to your OPD. Then there are various stages according to the Tanner staging we have to assess. Like the breast development, there is stage 1, 2, 3, 4, 5, from pre-pubertal to the elevation of breast and papilla. Then there is enlargement, then there is separation of mound above the breast, and then there is the final stage. And similarly of the pubic hair, the stages are 1 to 5. So we have to examine the patient and diagnose as staging to the patient. Then the external genitalia in male also we can have Tanner staging from the prepubertal to the enlargement of testes and scrotum in stage 2. Then there is enlargement of penis. Then there is increase in size and development of glans at stage 4, and then there is stage 5. So what is the summary of pubertal events? What happens? Chemically, FSH and LH, they rise moderately, they start rising moderately before the age of 10 years, followed by a rise in estrogen. Initially, in the initial years, right, at 6 to 8 years, or we can see 1 to 2 years before puberty, the LH pulse frequency increases first in sleep, but slowly its increase in pulses, it start increasing throughout the day, and also it is appearance is feasible. The final adult pattern of LH pulse frequency is around 1 to 5 to 2 hours interval. It is seen around mid-puberty. Then there is increase in level of estrogens resulting in the maturation of secondary sexual characters, increased in skeletal growth hormone, and then there is increase in growth hormone and IGF-1 also. So first we will be discussing, this is a picture of 13 years old male. He had bilateral breast enlargement. He's very conscious and embarrassed, and he says that there is a lump behind his nipple. Parents are worried. So this is a case of gynecomastia. Bilateral gynecomastia is there, as we can see in the picture. So how would we approach? What are the causes? What are the red flag signs? So here the diagnosis is idiopathic pubertal gynecomastia. How can we say that? First we have to examine the breast. We should know the breast examination so that we can differentiate between gynecomastia, lipomastia, and a tumor. So as we can see in the diagram, we'll palpate the mass between the thumb and the 2 forefingers, and we'll feel for the consistency. If it is attached below to the areola and is firm and rubbery, then it is gynecomastia. Usually lipomastia is not attached to the areola and it is slightly harder. And tumors, as we know, the consistency is much harder, irregular borders, and non-attachment. So what is the take-home message in a case of gynecomastia? When can we say that there is no need to worry for a boy? If the gynecomastia is present in less than 17 years of male, plus the breasts are not more than 4 centimeter enlarged, and gynecomastia is not persisting more than 1 to 1.5 years after the onset. Usually the idiopathic one has an onset between 12 to 13 years of age, and it goes before 17 years of age, then we can say that it is idiopathic. And what are the other take-home messages? The first sign of puberty in boys is increase in testicular size, as we have already discussed, volume more than 4 ml. Pubertal gynecomastia is common and occurs in mid-puberty. Reassurance and weight loss is the only treatment. Apparent micropenis is common in obese boys, and true micropenis may be a sign of hypogonadism. Next, we'll be discussing delayed puberty. So here in this case, till what age would you wait before evaluating a case of delayed puberty? Options are no menses till 15 years, till 4 years after thelarchy, that is the breast development is there but 4 years have been passed but there is no menarche, or till 13 years if there are lack of any pubertal signs, or all of the above. So the answer here is all of the above, but we will be discussing delayed puberty in detail in the next few slides. So delayed puberty, it is either the delayed onset, that is the breast bud does not appear till 13 years of age, or menarche does not occur till 15 years of age in females, or it is the delayed progression, that is menarche does not occur within 4 years after the breast bud. So we can define in boys if there are no signs of testicular development by 14 years, and in girls, as already discussed, no thelarchy till 13 years or no menarche between 15 years, before 15 years. So we can remember this, that the boys' age is between the girls and the girls' thelarchy and menarche. That is 13, 15 and boys is 14. So what are the important causes? Either it can be constitutional delay due to the pubertal growth, can be familial due to chronic illnesses like thalassemia, chronic renal disease, celiac, chronic hepatitis. Endocrine causes can be there due to hypothalamus, hypopituitarism or hypothyroidism. Then there is congenital anomalies of the abnormal development of the reproductive system. Another are the androgen insensitivity syndrome, exercise and eating disorders. As discussed, what are the common symptoms in girls? No breast growth by 13, more than 5 years between thelarchy and menarche, and no menarche by 15 years. In boys, no testicular enlargement by 14, no pubic hair by 15, and more than 5 years have been complete, but the adult genital growth has still been achieved, not been achieved. So what are the investigation? So initially we'll work up for the chronic conditions by history taking, development history, any history of operations, any history regarding testicular anomalies, oncology, radiotherapy. Then as discussed earlier, clinical examination including Tanner staging is very much important. Plotting growth height chart and then finding the mid-paternal height. Bone age is very much important to assess whether the kid is going with increased bone growth velocity. Then serum LH and FSH level are very much important. Imaging, ultrasound to assess uterine and ovary size, testes, ultrasound to see cryptorchidism or any masses, then MRI of the brain for any craniopharyngioma. So additional workup for the hemoglobinopathy, CBC, TTG, thyroid profile, prolactin, DHEAs, growth hormone, IGF testing, GnRH stimulation test is another important investigation to see whether for the initial evaluation. And then lastly, if we are suspecting any chromosomal anomaly like Turner syndrome in females, then we will be going for the karyotyping. So the treatment is the basic treatment using medication for a few months to increase the hormone levels and trigger the start. Then there is specific treatment for treating the underlying cause. In males, we give IM forms of testosterone because it is more appropriate due to the liver toxicity due to oral testosterone. But in female, oral estrogen is more acceptable than the IM forms. So permanent hypogonadism in males, we treat with low dose of IM testosterone until gradually over time till we achieve the adult levels. In females, the initial treatment is low dose estrogen until we achieve breakthrough bleeding, and then subsequently we put the girl on combination of estrogen and progesterone as HRT, or it can be also put with the transdermal estrogen patches with oral progesterone. So what are the take-home messages for delayed puberty? Either there are absence of secondary sexual characters by 13 years in girls and 14 years in boys is a clear-cut indication for delayed puberty. Then secondary causes are the common, and ultrasound along with FSH can suggest a clue toward the diagnosis. We need not go for many more investigations. Simple 2 investigation can lead us to the diagnosis. Then Turner syndrome need to be picked up initially. So next case we will be discussing, a 7-year-old girl comes to the OPD with breast development. So what would you do? Is it a cause of concern? What would be your line of treatment? So we can say, we had already discussed that the thelarchy starts at 10 years. If a girl comes to the OPD with at 7 years of age, then definitely it is a red flag sign. But what we would be looking next is whether she is having other secondary sexual character development, or she is having peak growth velocity, then it points to definitely to the precocious puberty. But if these two things are absent, then we can label the case as benign isolated thelarchy, which occurs at the age of 6 to 8 years, does not progresses more than SMR staging 2, In this case, there will be no other secondary sexual characters. There will be normal height velocity, normal bone age. So what are the red flag signs? Precocious puberty we label, patient less than 8 years with other signs of secondary sexual characters, significant history of SGA, headache, visual disturbance, abdominal pain, cafe all sport, accelerated growth, bone age more than 2 standard deviation. So this is a case of 10 years old Asha who has developed thelarchy. Mother is worried and asks, when will her periods will start? What will you tell the mother? So we can tell her that there is a period of 2 to 3 years gap between the onset of thelarchy till the onset of menarche. So she has to wait and watch. In the meantime, this is the time for the girl to achieve maximum height velocity. So we will be concentrated on her proper nutrition, calcium, vitamin D supplementation. So Asha is now 13 years old. She has menarche at 12 years. Now she is having very heavy irregular periods needing 6 to 8 pads per day. So what is the most likely diagnosis? How would you manage her problems? So the most likely diagnosis here is initially the periods are anovulatory. So there can be menorrhagia, irregular menses. So the diagnosis is AUB, that is abnormal uterine bleeding. We will be managing the problem with simple hematinics. And then would you give OC pills? No, initially we will not recommend until unless the menorrhagia is disturbing her routine school life. So should we think of any other cause? Yes, we should always rule out other bleeding disorders in this case. So discussing a little bit details of the precocious puberty as we defined earlier, the norms for gender and race or ethnic background, if they are more than 2.5 standard deviation, then it is defined as the precocious puberty, or the onset of breast development less than 8 years, onset of menarche less than 10 years, or testicular enlargement before 9 years. Here again the age of boys is between the two ages of the girl. Remember in the delayed puberty, it was 13, 15 and 14 in boys, and here it is 8 and 10 in girls and 9 in boys. So what is the classification? We broadly classify into central precocious and peripheral precocious. Central, which is due to the premature activation of the hypothalamus pituitary gonadal axis, and peripheral because the production of peripheral sex steroids, they are not influenced by the HPG axis. Then there is mixed type, which is seen in CAH and McCann-Albright syndrome, and then there are incomplete forms or pubertal variants. What are the causes? It can be familial, obesity, IUGR, environmental, or endocrine. The causes of central precocious puberty are broadly classified due to the CNS insults, trauma, CNS diseases, CNS irradiation, tumors of the CNS like hypothalamic hamartoma, astrocytoma, glioma, then structural defect of the CNS, then tuberous sclerosis, Sturge-Weber, due to cerebral palsy, IUGR, and then other are the genetic causes. Causes of peripheral precocious puberty are different in both boys and girls. It can be GnRH independent in girls, can be isosexual and heterosexual. Isosexual means the same sex steroids are seen in increased amount in the female only. Can be due to the ovarian disorders, ovarian cysts, McCann-Albright tumors, choriocarcinoma, adrenal tumors. Heterosexual, that is the male hormones are found in increased concentration in the females, as seen in CAH, masculinizing adrenal or ovarian tumors, and then familial glucocorticoid resistance. So the causes similarly in boys are isosexual due to CAH or tumors. Then there is one more variant, familial male limited precocious puberty, that is seen only in males. Then there are testosterone secreting tumors or pineal gland tumors or HCG secreting tumors can lead to GnRH independent precocious puberty in boys. So how we will evaluate? The most important is the hormonal evaluation. Here comes the role of gonadotropin stimulation test or GnRH analogs. So after giving the GnRH agonist, we see the level of LH, that is luteinizing hormone. So the luteinizing hormone in central precocious puberty, the levels are more than 5 to 8, and that are very diagnostic. But as we see the peripheral precocious puberty, it is independent from the HPG axis. So there is no response seen to the GnRH agonist. FSH is seen raised in premature thelarchy. Another is serum estradiol. More than 20 suggests that puberty has started. More than 100 suggests that there may be estrogen secreting hormones in the body. And between 30 to 100 suggest mid-puberty. Serum testosterone, again less than 30 suggests prepubertal, 10 to 30 may indicate early puberty. So basal levels are seen higher both in CPP and peripheral. Adrenal androgens, we can look for them to see the causes of precocious puberty. Serum androgen is useful in girls to differentiate between premature adenarche and virilization. Then thyroid, prolactin, HCG, alpha phyto, these are seen in partial precocious puberty. Then going to the imaging studies. Look for bone age, bone dysplasia to rule out McCann-Albright, CT MRI of the brain to look for etiology of CPP, CT MRI of the adrenals, pelvics and abdominal ultrasonography, testicular sonography to look for asymmetric testes to diagnose Leydig cell tumors of the testes, then bone scan and skeletal surveys. Then the treatment, normal variants, they do not need any treatment for central precocious. Identify the underlying pathology like tumor, they need surgical resection. Then there is GnRH hormone analog therapy. In precocious, peripheral precocious puberty, the exogenous sex steroid should be stopped. CAH needs to be treated with glucocorticoids, tumors to be surgically removed, and then autonomics, MDPA. So, and, finally, coming to the another messages, what are the age of puberty in girls is 18 to 13 years and boys it is 9 to 14 years. Breast development before 8th birthday warrants evaluation. Growth chart, bone age, ultrasound, pelvis are the only investigation needed. Isolated thelarchy needs close follow-ups. Rapidly progressive puberty needs urgent evaluation. Menarche before 10th should be investigated. Phase between thelarchy and menarche is important for maximum growth. Counseling and reassurance is must. Then an organic pathology should be ruled out. So quickly going to the rapid fire question, here is a boy who want to build his muscle mass. What would you advise him when he should start going to the gym? Quickly, the students from the AIMS. Any guesses? So I'll give the answer quickly. The answer that he should join the gym only after there is epiphyseal closure. Before that, since the calcification of the bones is not proper, so there are high chances of getting fractures. Okay? Then there is anemia of puberty. The girl is sleepy. She is having social causes, increased menstrual bleeding. So we should supplement with hematinics. So what is this? Quick. This is called as Prader archidometer. So it is used to assess the testicular volume at different age by the size of the bead in the. So what is this? Would you recommend use of breast enhancing or reducing creams? What is there is in these creams? So ideally we should not recommend, these are full of estrogens in breast enhancing creams, or maybe in reducing cream there are testosterone or other hormones, so ultimately it will harm the patient. So would you recommend fairness creams? Yes or no? So there was one report that these creams also contain steroids. They lead to steroid-induced glaucoma. Plus, skin cancers are more common by using this because they decrease melanin. So what we understand with puberty is it is a low self-esteem state, full of anxiety, full of low self-worth, there is fear of rejection and low self-confidence. So we need to tackle puberty with great conscious and with great resilience with our kids. Thank you.
Thank you, Dr. Anjali. I think the clapping is indication of your lecture and excellent lectures, because this myths and realities is, I think, generating the market economy. Lot of people spend lot of money on such things which are not effective, and you and all the doctors come across several things कि 2500 रुपए ਦੀ ਚੱਪਲ ਹੈ ਜੀ ਇਹ ਪਾ ਕੇ ਰੱਖੋ 3 ਮਹੀਨਿਆਂ ਚ 2 ਇੰਚ ਵੱਧ ਜਾਂਦਾ ਹੈ. So excellent talk. Any questions?
Thanks for the patient listening.
ਅੱਧੇ ਤਾਂ ਸੰਗ ਦੇ ਨਹੀਂ ਪੁੱਛਦੇ ਹੋਣੇ ਜੀ. So I must
So they can come
congratulate.
personally to me also.
Yes.
Always welcome.
I must congratulate
you, sir.
you on the choice of the topic. Excellent awareness topic for non-medical as well as medical people. Thank you very much. Next. So there is 1 minute delay because of the change of the battery. Camera भी बेचारा कितनी देर चले.
Thank you, ma'am. Our next guest speaker is Dr. Mohit Madhukar, pathologist, Civil Hospital Bathinda, who will be sharing his views on the topic sample collection and techniques.
I must thank Dr. Mohit to prepare this lecture in 2 days because there was a drop lecture and I requested him to fill in. Thank you, Dr. Mohit.
Thank you so
and
much, sir.
in fact, his topic also was CBC clinical interpretations. That was already chosen by some speaker. I don't know whether he will come or not. So he changed his topic also. So we are highly obliged with this gesture. Thank you very much.
Thank you so much, sir. Good afternoon, all my seniors, and, colleagues and friends. And I am thankful to Dr. Vitul, sir, for giving me the opportunity to present at MAPICON. And I think it is all possible due to his efforts only. So without wasting any time, the topic is sample collection and techniques. Though it is a new topic for interns and PG residents, and it will be a revision for others. So why sample collection is important? So if there is any error in the sample collection, the value of the result will not be proper and it will hamper the clinical diagnosis. So coming on to the introduction, so accurate and precise methodology is essential to avoid any misleading information due to technical errors. So next, the sample should be drawn in a proper vacutainer so that required test can be performed. And lastly is that there should be proper storage and transport of the sample to the place where test is to be performed. So now coming on to the types of blood collection. So 3 types of blood samples are usually collected: arterial, venous, and the capillary. So most common type of blood sample is venous. All the types of blood test or the biochemical routine investigations can be performed on the venous blood, whereas in case of arterial blood, we will go for the blood gas analysis, and it will also help in direct monitoring of the arterial pressure. So capillary blood is required in the cases of infants or neonates. So capillary blood is the method of choice in them. So now coming to the vacutainer system. So a vacutainer system is a system which contains a needle, needle holder, and a vacuum tube. So vacuum tube will create the vacuum and requisite amount of blood or desired amount of blood will flow in a vacutainer. So parts we have already discussed. The only advantage is that the blood flows in a requisite amount. So there is no excess or less amount of blood in a container. So this is the vacutainer system which contains a needle, needle holder, and a vacuum tube. So instead of the needle, we can also use a butterfly needle if the amount of sample is to be taken in serial monitoring. So what are the advantages? The advantages are it is simple to use, quicker method, safe, and it is a clean. The chances of contamination are very, very less. So now we will discuss the vacutainers one by one. So number 1 is the red top, or we also label it as a yellow top. So yellow top vacutainer will have a gel and red top doesn't has any gel. So there is no additive in this vacutainer. There is a clot activator which will help in clotting of the blood quickly.
So routine investigation, biochemical investigation, serology can be performed in this vacutainer. Next is the light blue or the sodium citrate vacutainer. It contains the sodium citrate in the concentration of 3.2 milligram per ml. The important point to remember in this type of vacutainer is that it is provided with a mark. So the sample should be till that mark only. It cannot be low or it cannot be above that mark. So concentration needed to maintain is 1:9. One part will be of the anticoagulant and 9 parts will be of the blood. So mechanism of action of sodium citrate is that it will chelate the calcium and it is used for performing the coagulation assays like PTI, APTT or the D-dimer. Next, coming on to the lavender tube, it contains the EDTA, ethylene diamine tetraacetic acid. The concentration is 1.5 milligram per ml. So it is usually in performing the hemogram, HB electrophoresis or HbA1c profile. So we should, while withdrawing the sample, mix it 2 to 4 times up and down so that anticoagulant is mixed properly. Now coming on to the black top, it is used for ESR erythrocyte sedimentation rate, ESR estimation. In the concentration of the anticoagulant is same, 3.2 milligram per ml of the sodium citrate, but the point to remember is that in this ratio of anticoagulant to blood is 1:4. In the previous it was 1:9. Next is the green top, which contains sodium heparin or the lithium heparin. So it is, mechanism of action is that it inhibits the action of thrombin. So fibrin is not formed. So it is used in performing the tests like osmotic fragility test, immunophenotyping and flow cytometric studies. So disadvantage is that we cannot use it for performing the peripheral smears as it darkens the background. Next is the gray top, which contains sodium fluoride as the additive in the concentration of 2.5 milligram per ml, and it will inhibit the magnesium, so which is enhances the glycolysis. So glycolysis is inhibited, so that's why it is used in the estimation of blood sugar and ethanol levels. So coming on to the blood culture, so blood cultures are commonly required in the indoor or the admitted patients in the cause of fever is not found. So it contains a special glass bottle which contains a glucose broth. So we should, first of all, we have to collect the sample. We will collect the sample of the blood culture followed by the others. The result for the blood culture usually arrives within 3 to 7 days depending upon the type of technique used. So what will be the order of the draw? If we have to draw the multiple samples, multiple tests are required. So first of all, we will collect the sample in the blood culture tube, followed by the sodium citrate tube, which aids in the coagulation assays. Then is the red top for biochemical assays. Then is the green top for cytometric studies, followed by the lavender or the EDTA tube for routine hemogram and others. Then is the gray top for estimation of the blood sugar, and the last will be for ESR estimation, that is black top. So what is the phlebotomy procedure? So first of all, it begins with the identification of the patient and the requisition form which is sent along. So the requisition form will contain the details of the patients like name, age, sex, indoor number and the details of the referring doctor. And we should check whether the requisite test which is labeled or not. If it is not mentioned, then we will look for the miscellaneous, either whether it is mentioned in the miscellaneous category or not. If the form is not complete, then we should ensure that it must be completed. Then comes the labeling of the vacutainers. So before withdrawing the sample of a patient, we should label the vacutainer priorly. So what details should be there, like name, age, what is the ID number of the patient, and if possible, we should also ask the person who is withdrawing the sample or the phlebotomist to put his initials over the vacutainer. So what is the needle size? So needle size for the adults will be 21 to 23 gauge, where for the children it will be the 26 gauge. And butterfly needle is used when the sample is very small vein is there, so that it can go easily and withdraw the sample. So normally the sites is the vein in the antecubital fossa. If there we are not finding any site even in the peripherals, then we can go for the jugular vein or femoral vein for the sampling. So vein selection. Again, the vein selection is very important. We should select the vein which are large and accessible. If the large veins are not well anchored in the tissue or there is obstruction, then we should hold it with non-dominant hand so that it does not slip while doing the puncture. And we should avoid the sites which contains scarred areas or the bruises or hematomas. So what are the inappropriate sites for the venipuncture? So any site containing the burns, scars, tattoos, the vein is damaged or there is any hematoma, edema, or the arm containing the cannulas or the where the drip is going on, we should not take the sample from that area. Now coming on to the arterial blood. So arterial blood sample is important in evaluation of the blood gas analysis. So in the adults, the site for the preference is the radial followed by brachial and the femoral arteries, whereas in neonates, if there is indwelling umbilical artery catheter, then it is best we have not do multiple punctures. Otherwise, we will go for the capillary puncture to contain the arterialized capillary blood. Now coming on to the method how to take the arterial blood gas sample. So for every procedure, first of all, we will clean the site and then feel the pulsations of the artery and insert the needle at the most likely 90-degree angle, and arterial blood sample will be confirmed by the pressure the blood comes in the syringe. After withdrawing the needle, we will compress the site for 2 to 3 minutes with a sterile gauze piece. So this is a pictorial representation how to collect the arterial blood. So what are the uses? Uses are acid-base balance, evaluation of PaCO2 for ventilation, evaluation of oxygen saturation, and oxygen carrying capacity of the blood. So what are the advantages? It allows the easy sampling when multiple samples are needed and provides a continuous monitoring of arterial blood pressure. Now what are the disadvantages? As the site is deep, it can result in bleeding, hemorrhage, infection can be there, laceration can be there, or obstruction of the vessel can occur. Now what are the important points to remember in the arterial blood gas sampling? There should be no air space till the completion of the sample. And we should roll the syringe gently 15 to 20 times to mix the anticoagulant properly. Sample should be labeled, and during the transportation, the sample should be cool. It should not be frozen. Why cold temperature is required? Because it will minimize the consumption of the oxygen by the leukocytes. Now coming on to the capillary blood. So in the capillary blood, sites are again for adults and children. It can be the ring finger or the earlobe. In the case of infants, it is the plantar surface of the heel, whether medial side or the lateral side. So this is the site of collection in cases of children. The procedure is again, we will clean the site and puncture the wound, and after that, important point to remember is that we will wipe off the first drop of blood because it contains the tissue fluid and it will give the erroneous results. Now what are the advantages? Advantage that it is an easy procedure and it can be performed at home in the case, especially in the case of diabetics who can check their sugar with the help of glucometer in routine once or twice a day. Now what are the disadvantages? Disadvantage is that only a limited amount of blood can be withdrawn. The values of parameters like hemoglobin, hematocrit and red cell come apparently high. Platelets will be low due to the adherence of platelets at the punctured site. And it can also result in the false elevated sugar levels, electrolyte levels and the blood count. So now the post-phlebotomy procedure. So important checkpoints in the post-phlebotomy procedure are again, we should match the ID number on the vacutainer as well as in the form and whether the sample for the requisite tests has been taken or not. So now coming on to the complications, what complications can arise during the sample collection? One is the procedure related, which involves the hematoma formation, iatrogenic anemia, and aberrant arterial pressure, infection of the site, and last is nerve injury. Patient related, patient can experience the syncope or the fainting. Excessive bleeding can occur if the underlying artery is punctured. There can be anaphylactic reactions And lastly, or the we can say the least is the seizure. Now, misleading results. Coming on to the misleading results can arise at 3 steps. First of all, is during the pre-collection. The sample was required fasting, but the patient has taken the meal. So, it will be false result. Then is the smoking. Physical activity. Patient has done excessive physical activity. He is climbing the stairs up and down. That will be again leading to the false result. There is stress, or patient has consumed any drug or dietary supplements in last 8 hours. So what errors can arise during the collection? Number one is a diurnal variation. So some tests like cortisol show the diurnal variation. In that we should know the time of the sample collection. Incorrect type of tube or incorrect type of sample. Sample was required venous, but phlebotomist has taken as the venous sample. So again it will be the erroneous results. Prolonged tourniquet will result in the hemoconcentration. And if there is excessive negative pressure while withdrawing the blood, it will result in the hemolyzed sample. So handling of the sample, in the handling, there was inadequate anticoagulant or the coagulant was not mixed properly. There is error in the patient name or sampling, or the sample is mismatched. There is inadequate sample collection, and there was delay in the transportation of the sample. If there is a delay in the transportation of sample, we should keep at a proper temperature, or we can keep it in the refrigerator. So what are the causes of the rejection of sample? Sample is rejected if the sample is hemolyzed, if it is clotted, sample is insufficient, sample is collected in a wrong vacutainer, storage of the sample was not proper, and the sample was not labeled properly. So while collecting the sample, the spill can occur, the sample can fall, or the vacutainer can open, it will result in the blood spilling over the floor. So hospital staff should treat every sample as the infective. So when the sample has been fallen on the ground, one should wear the gloves and look for any sharp. If there is needle, or that should be removed with the scalpel, and 1% hypochlorite should be poured and kept for 30 minutes. Again after 30 minutes, that gauze piece should be discarded in the yellow bin, and then it will be again cleaned by 1% hypochlorite solution. Now is the major spill management. So major spill management, when it is more than 30 ml, procedure will be the same, but the sodium hypochlorite concentration will be 4 to 10% in that case. We will leave it for 30 minutes, and then again we'll clean with 1% hypochlorite. Thank you.
Thank you, Doctor, for an excellent talk. And again, I extend my thanks to fill in for a drop lecture. Thank you very much.
Thank you, sir. For our next guest lecture, I would like to invite Dr. Rohit Bansal, DNB Anesthesia, Consultant Critical Care, Delhi Heart Institute and Multi-Speciality Hospital, Bathinda, who will be presenting on the topic Recent Advances in Advanced Cardiovascular Life Support.
Good afternoon to all present. I, Dr. Rohit Bansal, in charge of Critical Care Department of Delhi Heart Institute, will first of all like to congratulate Dr. Vitul Gupta for organizing such a beautiful conference in our city, and thank the organizing team for giving me the platform to discuss the topic of recent advances in adult ACLS. Though it is a very vast topic, but I will try to cover it in my allotted time. American Heart Association is a non-profit organization in the United States. AHA is a major task force for setting the guidelines for basic life support and adult and advanced cardiac life support. All this work done by the AHA is published in their annual journal Circulation. These are some of the abbreviations which will come across the presentation. The AHA, American Heart Association, CPR is cardiopulmonary resuscitation, ECC is emergency cardiovascular care, OSCA, out of hospital cardiac arrest, ISCA, in hospital cardiac arrest, BLS, basic life support, ACLS, advanced cardiac life support, AED, automatic external defibrillator. ROS is return of spontaneous circulation. So with the ongoing efforts of AHA, look how far we come in the last 10 years. There is almost double the number of bystanders providing CPR from 31% to 62% by the teaching protocols of AHA. AHA committee includes a physician and scientists from all over the world. It spends around $3.4 billion in each. Sorry. It spends about $3.4 billion each year on collecting data and using it for improving CPR guidelines. Sudden cardiac arrest is the leading cause of death among adults. Approximately 7 lakh cardiac arrests occur globally each year. Survival in sudden cardiac arrest is inversely correlated to time of patient waits before receiving treatment. Chances of survival in cardiac arrest decreases directly proportional to a delay in fibrillation. It is shown by the graph which shows when the delay in the defibrillation, the chances of survival decreases. Bystander CPR before arrival of emergency services doubles the survival chances from sudden cardiac arrest. Early resuscitation can increase the survival chances by 60%. The research has found that when we are doing chest compression, 28% of the time we are too slow, 40% of the compression that not deep enough, and also 60% of the time we are ventilating too fast. It means there is no ROS or delay in ROS. Chest compression fraction. That is, we are doing chest compression only 52% of the time. Survival is directly proportional to the increase in chest fraction time. This shows if when there is the shorter the pre-shock pauses, the higher are chances of patient survival. So now, not wasting time, we'll come to the basic life support. We'll give a brief review of the basic life support. Basic life support is a sequence of procedures performed to restore circulation of oxygenated blood after sudden pulmonary or cardiac arrest until they are given full medical care at the hospital. BLS does not include use of drugs or invasive skills. It can be provided by any trained medical personnel, including paramedics or anyone who knows it, how to do it, anywhere, immediately without any other equipment. What is the purpose of CPR? Its purpose is maintaining circulation and oxygenation in order to maintain a cardiac output to keep the vital organs alive. By doing a BLS, we need to follow a chain of survival. It includes 5 links: early recognition of cardiac arrest, activation of emergency response system, early CPR to provide blood supply to organs, early defibrillation to restart the heart, comprehensive post-cardiac arrest care to restore quality of life. So, let's see the scene first. You find an adult lying on the ground unconscious. So we start with the BLS. It means check for the patient response and then look for the breathing. If there is no breathing, normal breathing, then just feel the pulse. If there is no breathing, no pulse, then we'll start the CPR and wait for the AED to come. As soon as AED comes, we'll check the rhythm and further analysis. Actions which are performed for adult CPR are assess scene safety, determine the responsiveness, check carotid pulse, perform chest compressions, open the airway, check for breathing and deliver the breath. First is assess scene safety. Second is assess responsiveness by shouting, "Are you all right?" Third is check the circulation by feeling the carotid pulse for not less than 5-10 seconds. Shout for help and get the AED. If there is no pulse, no or abnormal breathing, then start the CPR. To start the CPR, lie the patient in supine position of firm, flat surface, kneel down to the patient's side and locate the position of chest compression on person's chest. This is a simplified BLS algorithm which shows unresponsiveness, activate the emergency response system to get a defibrillator, and then start the CPR. Push hard, push hard. Check rhythm every 2 minutes. This is the main change which was brought in the recent guidelines. It's a CAB approach. It includes first the circulation, then the airway, breathing, and defibrillator. CAB is compressions, airway, breathing. For the compressions, chest compression, locate the lower one-third of the patient's sternum in between the nipples in the midline of the body. This is the way you should give the chest compressions. Good quality chest compression is the key to success for CPR. Push hard, push fast, allow for full chest recoil with each compression, allow for only minimum interruptions to chest compressions, deliver 30 compressions initially, push hard at a rate of 100 to 120 compressions per minute. High quality CPR include 30 compressions to 2 breath ratio, 100 to 120 compressions per minute, not too fast, not too hard, only 5 to 6 centimeter depth. After giving the chest compressions, open the airway. Give 2 rescue breaths, each lasting of 1 second, and assess for visible chest rise with each breath. Opening of the airway can be done by 2 maneuvers, head tilt, chin lift, and jaw thrust maneuver. Then giving rescue breath. Each rescue breath should be approximately 1 second. Watch for chest rise, allow time for the air to expel from the patient. Now methods for giving rescue breath. There are different methods for giving rescue breath: mouth-to-mouth breathing, mouth-to-nose breathing, mouth-to-stoma ventilation, bag and mask ventilation, ventilation with advanced airway. We'll not go into details of this. Then one cycle of adult CPR is 30 compressions to 2 rescue breaths. Perform 5 cycles of CPR before assessing the rhythm. Continue CPR. If there are two providers, switch roles between compressor and rescuer after every 5 cycles. As soon as this is an automatic external defibrillator, AED is an automatic external defibrillator device that has the ability to detect irregular heart rhythm and automatically delivers the defibrillatory shock to stop irregular heartbeat and allows the normal rhythm to resume. AEDs are designed to be used by laypersons. As soon as the AED arrives, assess the rhythm, and if it's a shockable rhythm, go for shock. If it's non-shockable rhythm, continue CPR. This is the procedure for using the AED. You attach the pads on the bare chest, let the AED analyze the rhythm. If it's a shockable rhythm, AED will shout, it's a shockable rhythm, then say you clear, I clear, all clear, and AED will give a shock. Some key points for the BLS. Perform chest compression at a rate of 100 to 120. Compress to a depth of at least 2 inches. Allow full chest recoil after each compression. Minimize pause in compression. Ventilate adequately. There should be uninterrupted chest compression while applying defibrillator pads. A rhythm analysis is not occurring. Assume chest compression immediately after the shock. Rhythm analysis after 2 minutes of compression and breathing. Defibrillate only for VF and VT. Continue resuscitation until there is a qualified help arrives and takes over. The victim starts breathing normally. Rescue is exhausted. If after all your efforts the patient gets revived, then lie down in a recovery position which looks like this. Steps for the recovery position are like this. Then if the patient is not revived, then we'll go for the advanced cardiac life support. Advanced cardiac life support is circulation by cardiac massage, airway management by equipments, breathing by advanced techniques, defibrillator by manual defibrillation, different interventions based on ECG rhythm, drugs, medications, special situations like pregnancy, drug overdose, and new technologies which includes the echo and the internal CPR. This is the algorithm for the advanced cardiac life support. After assessing the rhythm, there are two pathways which are followed. One is the shockable rhythm and other is the non-shockable rhythm. Now, what are the shockable and what are non-shockable rhythms? Shockable rhythms are ventricular fibrillation and polymorphoventricular tachycardia. Non-shockable rhythms are asystole and pulsar electrical activity. If it's a shockable rhythm, we'll give a shock and resume the CPR for 2 minutes. In between, we get the IV access, then assess the rhythm after 2 minutes. If it's a shockable rhythm, we will give a shock, continue CPR, and give epinephrine every 3 to 5 minutes, and consider placement of advanced airways. After 2 minutes of CPR, we'll again assess the rhythm. If it's a shockable rhythm, we'll give a shock, resume CPR, and then next are the antiarrhythmic drugs, amiodarone. If it's a non-shockable rhythm, there are two possibilities, asystole and PE. If it's a asystole or PE, give epinephrine as soon as possible. This is a major change in the recent guidelines, which I will coming later. Assume CPR for 2 minutes, get an IV access, give epinephrine as soon as possible. Check the rhythm after 2 minutes. If it is a shockable rhythm, go to the shockable algorithm. If it is a non-shockable rhythm, continue CPR for 2 minutes. Then some salient features are advanced. Will not go into details of advanced cardiac life support. Some salient features of advanced cardiac life support are epinephrine is the only drug which just comes out with some role. Early epinephrine non-shockable rhythm, asystole and PAE increases the chances of ROS and increase the neurological survival. About the antiarrhythmic drugs which are used in advanced cardiac life support, it are used for shock refractory VF or polymorphic VT in restoration of and maintenance of ROS. Amidon has come out to the only drug which is used in VF and polymorphic VT. Lidocaine is again has got entrance into the algorithm for an alternative of amidon. Routine use of magnesium for polymorphic or polymorphic VT is not recommended. Routine use of soda bicarb in cardiac arrest is not recommended. While doing the advanced cardiopulmonary life support, always look for H and T's. H includes hypovolemia, hypoxemia, hydrogen ions, hypokalemia, hyperkalemia, hypothermia. And the T's include tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, and pulmonary coronary thrombosis. After we have achieved a ROS, then the latest changes are the getting a targeted temperature management, which includes cooling the patient to 32 36 degrees for at least 24 hours. Then they should continue monitoring care for temperature, maintain normoxemia, normal apnea, euglycemia, provide continuous or intermittent EEG monitoring. Other things which including advanced cardiac life support are tachyarrhythmias, bradyarrhythmias, opioid overdose, stroke, cardiac arrest in pregnancy. We will not go into details of all this because it's another one-day lecture on this. So now coming to the summary of the major changes which are brought in 2020 guidelines in adult and basic life support. All these are summarized in the 2020 American Heart Association guidelines in the journal Circulation. Some major guidelines are it is recommended that it's recommended that laypersons initiate CPR for presumed cardiac arrest because the risk of harm to the patient is low if the patient is not in cardiac arrest. Secondly, previous recommendation about epinephrine administration has been reaffirmed with the emphasis on early epinephrine administration as shown by this algorithm. It's written epinephrine as soon as possible. Then other major changes in the advanced cardiac life support was introduction of capnography, confirmation of placement of advanced airway techniques, re-entry of lignocaine in the dose of 1 to 1.5 milligram per kg body weight as an antiarrhythmic, then consideration of cardiac coronary revascularization as soon as patient achieves the ROS. Other changes are continuous measuring of arterial blood pressure and end-tidal carbon dioxide during ACS resuscitation may be useful to improve the CPR quality. IV access is a preferred route for medication administration during ACL resuscitation. Intraosseous use is acceptable only if IV is not available. Routine use of double sequential defibrillation is not recommended. This double sequential defibrillation was in very trend in the 2015 guidelines, but with the research showing there is no benefit of stage defibrillation. So only single defibrillation is beneficial. Use of real-time audiovisual feedback is suggested as a means to maintain the CPR quality. These are some of the audiovisual feedback devices which are used to CPR to assess the quality of the CPR. Care of the patient after the return of spontaneous circulation requires close attention to oxygenation, blood pressure control, evaluation of percutaneous coronary intervention, targeted temperature management, and multimodal neuroprognostications. The major change which is brought in the AHA chain of survival in the adult and in hospital and out of hospital cardiac arrest was this is shown, which is the initial 5 points are same. The last one is the recovery phase, which has gained very importance in the recent guidelines. Then during the recovery, there is initial stabilization phase, which is continued in the management and the additional include. The initial stabilization phase includes the airway management, management of respiratory parameters, which includes maintaining a saturation of 92% and PCO2 of 35 to 45%, then managing the hemodynamic parameters, systolic blood pressure of more than 90 and arterial pressure of more than 65. Then the other things are the maintaining a targeted temperature control, obtain a brain CT, EEG monitoring, and other critical care managements. Because recovery from cardiac arrest continues after long, the initial hospitalization, patients should have formal assessment and support for their physical, cognitive, and psychological needs. After resuscitation, debriefing of lay rescuers, EMS providers, and hospital-based healthcare workers may be beneficial to support their mental health and well-being. Enhanced algorithm and visual aids provide easy-to-remember guidelines for BLS and ACLS resuscitation. Management of cardiac arrest. Management of cardiac arrest in pregnancy focuses on maternal resuscitation with preparation of early perimortem cesarean delivery if necessary to save the infant and improve the chances of successful resuscitation of the mother. These are the guidelines. First is the manual lateral uterine displacement, and second is the planning for team planning for the perform peripartum cesarean delivery if infant has to be saved. Few changes which were done in 2015 guidelines and which are continued in 2020 guidelines are chest compressions were updated from the 2010 it was more than 100 to 15 and the continued 2020 are 100 to 120. Push hard and push fast. Initially the chest compressions were more than 5 centimeters. 2015 it was 5 to 6 centimeters or continued in 2020. They should be fully chest recoil. Do not lean on the patient's chest. Respiratory rate should be 30:2. Avoid hyperventilation. Then this was included in the basic life support algorithm. If the patient is pulse is not felt and patient is not pulse is felt and patient is not breathing, then provide him a rescue breath every 6 seconds. In 2015 guidelines, it was stated that either a bag mask ventilation or advanced airway may be used in both in-hospital and out-hospital cardiac arrest. Waveform capnography came out a most reliable method for confirmation of the placement of advanced airway technique. After placement of advanced airway, one breath every 6 seconds, that is 10 breaths per minute with continuous chest compressions. 2010 guidelines were the respiratory rate was 8 to 10, more than 8 to 10, but in 2015, which was continued in 2020, where around 10 breaths should be given, avoid hyperventilation. Then a role of focus in cardiac arrest has come in very large amount. Do feel to do a echo in CPR. If you have got the ability to do a echo during CPR, and a qualified sonographer or an ultrasound machine is there, then it should be used as adjunct for the CPR. Focus is done for to see are we doing the CPR right? There is a if the heart is able to generate the volume or not. So how we can do better? Keep calm and push fast. Cardiac arrest management is a PIT-Q approach team, means it's a team-based approach. What can be done better? Code management is most effective when a rescue team works together to provide patient care. Coordination of code management resuscitation efforts improve outcome for cardiac arrest patients. The resuscitation team is comprised of following roles. There should be team leader at least, chest compressor, airway manager, and AED operator. Take-home message from the lecture is, taking the right action quickly and confidently can make the difference between life and death of a patient dealing with a cardiac arrest. Thank you. Any questions are welcomed.
Thank you, Dr. Rohit, for an excellent talk. I think this is the most important and talked about topic. You go anywhere, cardiac management, especially in a rest condition, outside hospital, to put defibrillators at public places and how to resuscitate. Thank you very much for enlightening us. Any questions? Thank you, Dr.
Thank you,
Rohit.
sir.
Thank you very much.
Thank you, sir. Our next guest speaker is Dr. Arun Thapar, MD Medicine, Consultant Physician, Gomti House, Mall Road, Ludhiana, who will be presenting on the topic sleep disorders, causes and management.
So I will like to introduce Dr. Arun Thapar as a famous physician for Ludhiana. This is his individual capacity, but I am really honored to host son of our very famous teacher, iconic teacher, legendary teacher, Dr. Thapar, because from Patiala Medical College, any doctor who was Dr. Thapar's student, whether Vice Chancellor, Chief Minister, anyone, it was used to be talked about ਕਿ ਕਹਿੰਦਾ ਜੀ ਮੈਂ CMO ਲੱਗ ਗਿਆ ਕਹਿੰਦੇ ਹੈ ਤਾਂ ਡਾਕਟਰ ਥਾਪਰ ਸਾਹਿਬ ਦਾ ਖੋਤਾ ਹੀ ਨਾ because his talk was like you make one small mistake his khota and the students who don't know what khota is it is donkey ਸੋ ਕਹਿੰਦੇ ਹੈ ਤਾਂ ਥਾਪਰ ਸਾਹਿਬ ਦਾ ਖੋਤਾ ਹੀ ਜਿੰਨਾ ਮਰਜ਼ੀ ਇੰਟੈਲੀਜੈਂਟ ਹੋ ਜੇ ਇੱਕ ਵਾਰੀ ਤਾਂ ਥਾਪਰ ਸਾਹਿਬ ਦਾ ਖੋਤਾ ਬਣਿਆ ਹੀ ਹੋਏਗਾ So we are really honored to have you here, sir. And it gives us an impression. Your face is just like Dr. Thapar. So we remember Dr. Thapar a lot and we respect him. And what we are is because of teachers like Dr. Thapar at that time. Thank you for coming, sir.
Thank you, Dr. Mittal, for giving me this opportunity. Yeah, my father was an excellent human being, a par excellent teacher, and so many good memories are there for him. Yeah. Well, that's life, you can say. I'll briefly discuss this topic, sleep disorders, touch the subtypes, causes, and management. A good laugh and a long sleep are the best cures in doctor's book. A little bit of definition. Sleep is a reversible behavior, a state of perceptual disengagement and unresponsiveness to one's environment. What we medicines have the definition a little different, as a period of rest for the body and mind, during which volition and consciousness are in partial or complete abeyance and the body functions are partially suspended. Usual sleep phenomena in human is always in a supine state with eyes closed, but we do observe unusual sleep phenomena in patients like sleepwalking, sleep talking. Different species have different sleep patterns and they have different brain functions become activated. For example, dolphins, they sleep in an upright position and only one hemisphere of the brain is active. Horses and giraffes, they sleep less than 3 hours, whereas armadillo and opossums, they sleep more than 18 hours a day. Little bit of history from 1950, sleep was always considered to be a passive process. But with the advent of time, active rhythmic neural processes were studied. 1960, benzodiazepines came into play and the narcolepsy came into existence. 65, sleep apnea entity was labeled. And only in 1968, the rapid eye movements were observed and labeled. And it's only in 2012, the American Academy of Sleep Medicine has established the new scoring, which we are following now these days. So we can say that sleep is not a passive process, but it's an active one. This phenomenon is supported by the PET scans and the functional MRIs, where we can see that in even REM sleep, we have so many of red areas which denote a higher activity of the brain function. A third of human life is spent in sleep. That's an important thing. Now, why do we sleep? There are so many theories, but I've picked up few which are accepted in the current turmoil. One is a protective behavioral adaptation. Another theory, there's an energy conservation, that when we sleep, we conserve the energy, but doesn't hold true to great extent. There's a hormone regulation, which is created during the night only. There's a memory consolidation and creativity, which I'll touch later. There's a brain restoration phenomenon, and immune functions regulation get accelerated during the night, especially the natural killer cells. And emotional balance and mood I'll touch also, because these phenomena, they lead to substance abuse. Regarding hormone regulation during sleep, we have 4 hormones: melatonin, cortisol, thyrotropin, and growth hormone. Melatonin starts producing before the advent of the sleep and it peaks during the midnight, whereas cortisol, thyrotropin, and growth hormone, they peak in the midnight and then have a fall. And cerebral blood flow also peaks during the midnight. Immune function regulation gets accelerated during the night, especially the production of natural killer cells. The memory consolidation or creativity, whenever we meet in the day, anyone, or we learn a lot, and there's a process of encoding, then there's a storing, then there's a recall, and brain restoration involves clearing of waste products, just like a vacuum cleaner, and removes the waste and the toxic products. Emotional and balanced mood theory. If there's a sleep deprivation, it leads to excitation of amygdala, which in turn leads to phases of irritability, anger, and mood fluctuations. And amygdala excitation is one of the precursors for the substance abuse. In contrast, the prefrontal cortex exerts suppressant effect on the amygdala. Sleep plays an important role in maintaining normal hemostasis of the body. Now, briefly, I'll touch the sleep is divided into 2 parts: NREM, which I'm sure you all know, NREM sleep and REM sleep. NREM sleep is further divided into 4 stages: 1, 2, and 3, 4. 1 and 2 are known as N1 and N2. And now, lately, stage 3 and stage 4, they are not labeled as stage 3 and 4, but they are collectively known as slow wave sleeps. The different stages in NREM sleep, the stage 1, it constitutes just to 3 to 8%. The body starts to feel relaxing. Patient tries to, or the person tries to fall asleep. Stage 2, brain slow, stable, light sleep is there. If anybody walks close by, he can be aroused. He knows who is coming up. And stage 3 and 4, which are slow wave sleep, is a deep sleep, is a deep restorative sleep rather. It's a body and tissue restoration takes place. And last is REMs, or rapid eye movement sleep, in which the learning and memory consolidation takes place. And it's called the dreaming sleep. We have the dreams only in the REM and not in the NREM. Now, NREM sleep constitutes 75 to 80%, whereas REM sleep constitutes 20 to 25%. And stage 2 in NREM is the maximum 75 to 80%. The EEG, EOG, and EMG help in collecting different waves from the brain, alpha, beta, and they help us in differentiating which sleep stage the person is going on. Slow wave sleep occurs in the first half of the sleep and leads to increase in the vagal tone, decreased sympathetic activity, which further lead to decrease in the heart rate, a decreased blood pressure, and decreased cardiac workload. I've just mentioned over here a few sleep cycles in order to brush up your memory that NREM sleep has 4 stages, 1, 2, and 3, 4. They're followed by REM sleep. And each sleep cycle consists of 1 NREM and 1 REM sleep. 4 to 5 sleep cycles take place in a single night. Initial part of the night has a slow wave preponderance, while the later part of the night has REM sleep preponderance. The REM sleep keeps on increasing as the night progresses. It's a hypnogram where the initial part of the night can be seen as a slow wave preponderance, which is shown in the red part, and the later part of the night there's a REM sleep preponderance, which is shown in as a blue graphs. Polysomnograph is a graph which is carried out in order to do a sleep study, where we have electrodes placed all over the brain, and we collect all the waves from here. I'll not go into much of the details. I'll touch basically the clinical aspects of the sleep, which we encounter in the clinical part. Stage 1, it shows a slow wave of activity. Stage 2 has K complexes. These are the K complexes over here, spikes with the spindles. REM sleep. Now, what is the physiology of the sleep? Just for a brief part, we have two factors, factor S and factor C. Factor S is a homeostatic factor, and the factor C is a circadian factor. They all play in conjunction when the sleep has to take place. During the day, when there is a light, suprachiasmatic nucleus gets activated, blocks the pineal gland so that melatonin is not secreted, and the person remains awake. And later on, when when the darkness takes place, there's a melatonin production from the pineal gland, which leads to the sleep. Now, awake and sleep states, process C and process S, they play in conjunction. We have a circadian rhythm alerting signals, and sleep homeostatic drive is their place, so that in the morning time we are awake, and after 9 or 10 we start feeling sleep because of the production of melatonin. Wake control mechanism, it's one hormone which has come into play, orexin. Now, orexin is a hormone which is secreted by the hypothalamus and plays a major role in weight promotion and appetite stimulation. Lately, it has been observed that the lack of this hormone leads to obesity, and excessive hormone production leads to narcolepsy. The non-REM sleep takes place through the ventrolateral preoptic areas. They get suppressed, the orexin, whereas REM sleep is controlled by the lateral and posterior pontine neurons, which are cholinergic in nature and lead to REM atonia. It's a flip-flop model where so many hormones take place. One is, we have on one side the adenosine, the GABA, the galanin, and the melatonin, and on the other hand, there are norepinephrine, histamines, and serotonins. So it's a sleep and wake switch is there. Whenever the hormones, they get activated, we have arousal, and on the other hand, when they get activated, we have the sleep part. Infants have a sleep of 14 to 15 hours, whereas toddlers and teenagers go up to 8 to 9 hours. Adults have a sleep for 7 to 8 hours, and elderly have a very less sleep, up to 6 hours. The normal sleep is dependent on quality, quantity, and the timing of the sleep. Now, that's the purpose for which I have come. It's a classification. The classification, the latest classification which is coming up is the ICSD-3. We can group the subjects according to the pathogenesis, prognosis, heritability, and the treatment. We divide this classification into 7 parts. Insomnia. Number 2 is sleep-related breathing disorders. Number 3 is hypersomnias. Number 4 is circadian rhythm sleep disorders. 5th is parasomnias. 6th is sleep-related movement disorders like restless leg syndrome. And 7th is isolated symptoms. I'll touch the 3 only. One is insomnia, circadian rhythm, and the parasomnias, because it's going to take a lot of time. Insomnia is, despite the opportunity to have the time to sleep with a good congenial environment, the person doesn't sleep, we label it as insomnia. It's one of the most common disorder seen in 10% of the population, and inability to initiate a sleep is one of the things for which the patient presents to you, or getting up early, and poor maintenance of the sleep is taking place. It is associated with the day headaches and body aches. Mood changes are observed, like irritability, and inability to concentrate on the work, and the extreme forgetfulness takes place. Insomnia is of 2 types, chronic and short-term. Chronic we label as if it's more than 3 months and more than 3 times a week, and short-term is less than a week or so. Now, sleep-related breathing disorder, this is a very important topic. Obstructive sleep apnea, we all encounter such patients. We have obstructive sleep apnea in adults and obstructive sleep apnea in the pediatric group. Then the same way we have central sleep apnea syndrome, where there's the absence of airflow and effort. Sleep-related hypoventilation disorders, and the last is sleep-related hypoxemia disorders, where marked low oxygen saturation is observed. Now, wave patterns, obstructive sleep apnea, mixed and central sleep apnea. In the central sleep apnea, we have all the three straight lines, total cessation of the respiration, whereas in obstructive sleep apnea, we have the different wave patterns. We diagnose these entities only through polysomnography. What is the criteria for obstructive sleep apnea? Patient complains of sleepiness, non-restorative sleep, fatigue or insomnia symptoms. Patient wakes with a breath holding, gasping or choking. Bed partner reports habitual snoring, interruptions in the breathing, or even both. Patients diagnosed with hypertension, cognitive dysfunctions, mood disorders, coronary artery disease, cerebrovascular accidents, cardiac failures, diabetes, or atrial fibrillation, they do have these phenomena. Treatment lies in the lifestyle management or the changes. Loss of weight has to be there. A regular exercise. Quit smoking alcohol in case you're indulging into it. Use of nasal decongestants, and avoid all anti-anxiety or sleeping pills. If the obstructive sleep apnea is an established entity, we have the CPAPs and the oral devices, full face mask, and later, if possible, surgery is taken. Hypersomnia is excessive sleep. Too much of sleep is there. Narcolepsy, type 1, type 2, idiopathic hypersomnia, Klein-Levin syndrome, hypersomnia due to medical or psychiatric disorders, and hypersomnia due to medical or substance abuse. And last is insufficient sleep syndrome. Circadian rhythm disorders, it's a delayed sleep-wake phase disorder. A person sleeps at 4 a.m. in the morning or 5 a.m. in the morning, but with a duration of 7 to 8 hours, gets up at 12 in the afternoon or 1 in the afternoon. It can be advanced sleep-wake disorder, which is seen in elderly. Elderly people, they sleep pretty early, maybe 6 or 7, then they get up around midnight, and they can't sleep after that. Irregular sleep-wake rhythm disorder, non-24-hour sleep-wake rhythm disorders, these are all entities which have been mentioned. Shift worker disorders, those who are working during the night, the guards, and jet lag syndrome when we travel abroad. We have a flight of 10 to 12 hours, there's always a sleep dysfunction. Parasomnias is an abnormal behavior which is observed during the sleep. They could be sleepwalking, they could be sleep talking, striking or hitting the partner, and even nightmares. Two types, NREM-related parasomnias and REM-related parasomnias. And sleep-related movement disorders. Basically, the first entity which we encounter a lot of patients, restless leg syndrome in our clinical life, periodic limb movement disorders, sleep-related leg cramps or bruxism, benign sleep myoclonus of infancy, propriospinal myoclonus at sleep onset, and sleep-related movement disorders at the sleep onset. Now, a little word about the restless leg syndrome. An urge to move legs accompanied by or thought caused by uncomfortable or unpleasant sensation in the legs. They begin or worsen during the periods of rest, such as when the person is lying down or sitting. It is relieved by walking or stretching the limbs, or as long as some sort of physical activities is taking place, and occurs exclusively in the evening or the night. Treatments, we use gabapentin or pregabalins, ropinirole, pramipexole, or rotigotine. That's it. Thank you so much.
Thank you, Dr. Thapar, for an excellent talk. In fact, sleep is gaining more and more, sleep topic is gaining more and more importance these days. Half of the patient comes ke doctor sahab sota jana ji, swere uth ke aaya lagda hai ki neend hi nahi aayi ji.
Yeah, true, that's right.
So such type of problems are great problems, and I want to have your comments क्या है जो मरीज़ों का की करना चाहिए.
Take home message should be that we should not use much of the sleep drugs. That's the one thing. Lifestyle modifications should be advised. If there's a person is not taking exercise, he should walk at least 60 minutes of walk or 10,000 steps, we all say, like in a day. Less use of alcohol, quit smoke, and stress-free as far as one can do some yoga or some music therapy. He should be indulging something in a different protocol apart from his daily job.
Any other questions? कि सारे सुत्ते पे हैं.
As you mentioned, I think what Dr. Vitul said, you mentioned that the human beings, they sleep in supine position. But I think in the auditorium, you can see a lot of people who may be sleeping in a sitting posture also. So I think that's
very true.
So that's a bit of change.
Yeah.
And elderly people, the sleep cycle maybe slightly changes. Maybe because the duration of the sleeping hours are less. So if they sleep early, they wake up early,
Yes.
or they sleep late. Normally, what is the sleeping pattern in the elderly?
In the
Elderly.
That's why I mentioned that sleeping pattern early, they just tend to sleep early because of the hormone release. They have a melatonin production which comes up early. They don't have anything to do. They're basically inactive lifestyle and tend to sleep around 6 or 7 in the evening itself. And the sleep is only for 6 to 7 hours, and he's bound to get up at 1 in the night. And if we use more of benzodiazepines or the sleep-inducing drugs, there's a chances that he may have a fall when he's going to using a washroom after that. So use less of the benzodiazepines and tell the person that he should maintain a sleep. He should start the sleep pattern only around 8 or 9 in the evening.
A lot of people, they do complain that they cannot sleep without any benzodiazepines, etc. Otherwise, their whole day is wasted. So what should be done?
Sir, that's a habituation drug.
Yeah.
When you are addicted to a drug or like any Zolfresh or without mentioning any trade name, I mean, the best is not to use these drugs. That's what we can advise to our patients, to our colleagues, everybody.
Thank you, Dr. Thapar. It is really honor to host you here in MAPICON 2022. Thank you very much.
Thank you, Dr. Vittal. Thank you so much.
Now we are going to have the sessions which are recorded lectures, and we are thankful to our speakers who couldn't come and send their recorded lectures. I am Mulkesh Gupta, Dr. Girish Mathur, he is President API, Dr. S.S. Chatterjee, Dr. T.P. Singh, Dr. Sandeep Suri, Dr. Sajid Ansari, and Dr. B.K. Agarwal. And last lecture, we will have again physical lecture of Dr. Navdeep Singh from Ludhiana. So if he comes early, so we can have his lecture, physical lectures before that. So I'll request to start with the recorded lectures.
Now, for the recorded lecture, we have Dr. Mukulesh Gupta, and the topic is when to start and stop statins.
This is very important topic because statins are being used now
Good
and
morning
then
to
very
all.
frequently.
At the outset, I express
No, I think
my
you have
very sincere
gone in
thanks
for
to
a
Team
wrong
MAPICON.
lecture.
So, good
Yes.
afternoon, everyone. First of all, at the very outset, I would like to thank MAPICON and especially Dr. Vitul for giving me this opportunity to share my thoughts on statin. This is a very pertinent topic. So I'll be talking about when to start and when to stop statins. We are all aware that excuse me. We are aware about the challenges of the cardiovascular diseases in India. More than 1 out of 4 deaths in India are attributable to cardiovascular diseases. And more than 50% of cardiovascular mortality in India occurs in individuals less than 50 years of age. And if we talk of the cardiovascular disease, its prevalence in Indian patients, 10% of the heart attacks occur in Indians less than 40 years of age. And also that CVD affects Indians almost a decade earlier. And if we talk of ASCVD, then dyslipidemia is the strongest contributor of acute myocardial infarction. Now, if we talk of ASCVD and dyslipidemia, LDL sits in the center, and this is the culprit in most of the cases in ASCVD, and this is proven across various randomized controlled trials, animal studies, data coming from familial hypercholesterolemia, so on and so forth. We are also aware that small, dense LDL-C particles, which are more atherogenic than the larger, more buoyant ones. In addition, it is more susceptible to oxidation and also contains ApoB100, which undergoes conformational alteration and also has got higher affinity for proteoglycans. All these make lesser clearance by the LDL receptor, so they are retained in the milieu for more period of time, contributing to atherosclerosis. And nowadays we talk of LPA, which is the lipoprotein little a, which is genetically modified form of LDL-C, and it has got higher propensity for oxidation than LDL-C, particularly for Indians, as we have higher prevalence of elevated LPA. So this is a moot question. Does lowering of LDL-C reduce events? Certainly, if we see across the board, then the major vascular events, whether we talk of patients having diabetes or no diabetes, whether they are male or female, whatsoever is the age, whatsoever is the BMI, whatsoever is the smoking status, if you see, then the data is clearly in favor of the use of a statin. If we talk of angiographic trials of statin therapy, whether it is the steroid trial or RECAS, and we know that very low LDL-C levels can lead to regression of atherosclerosis. Talking about the numbers needed to prevent one episode of cardiovascular event, then if we are decreasing the LDL-C significantly, and here it is a comparison between 20% reduction and 50% reduction, and we can clearly see that the numbers needed to treat or to prevent one CV case is relatively less, that is 26 against 63, if we go or decrease the LDL levels significantly. Similarly, if suppose we decrease 39 milligram of percent of LDL by statin, that reduces 21% of major risk of the vascular events, and this is once again, which is data available, and it is presented in a Lancet. If we talk of more recent, then this is the comparison where we are continuously decreasing the LDL-C and then preventing the major vascular events which can be avoided per 10,000 patients, and we can clearly see that more you reduce LDL, more number of such events they can be prevented. And so LDL-C reduction and baseline risk will determine the reduction in the cardiovascular event, and the guidelines they recommend that we have to determine the risk of the patient first, and then we need to plan the treatment intensity according to the risk. And certainly we will have to target the LDL-C. This is more recent sort of guideline revision which has been proposed, that there is, this is focusing that there is more personalized prevention which is required, because one size will not fit for all. Then we have to be age specific, and then we have to focus on to the patient, and certainly the patient has to be taken into the center of the discussion. Then the risk stratification system is updated, and the newer goals for LDL-C, they have been presented. Shared decision making is something very important if we are trying to address to this issue. Then coming to the use of statin, all guidelines, they recommend use of statin as the first line of medication for the treatment, and all guidelines also now agree on analyzing the 10-year CV risk calculation that is recommended for the dosage and intensity of the statin in primary prevention. So now if we talk of the treatment goals for LDL-C across the categories of the total CVD risk, higher is the risk, the target for the LDL-C is also stricter. So here you can see that if suppose the person is sitting on a very high risk, then the LDL-C target is somewhere around 55 milligram per deciliter. Yes, we know that there are differences in various guidelines, because whether we talk of the Canadian guideline or the European guidelines, because there is a difference in how these guidelines they are analyzed. Say, for example, the Canadian and the European guidelines, they do not focus on statin intensity, but more on the targeted reduction in the plasma LDL-C. While the ACC, AHA, and the NICE guidelines, they recommend statin dose or intensity based on the patient clinical profile and characteristics. At the same time, various guidelines also use different calculators for assessing the risk of that individual. So now, not going into the detail of this algorithm, basically what we need is to reduce the LDL-C to 55 milligram per deciliter and LDL-C reduction of more than 50% from baseline in patients, those who are apparently healthy, but less than 70 years of age at a very high risk. Similarly, if the person is not at very high risk, but at a high risk, then the target are somewhere around 70 milligram per deciliter of LDL. So it is recommended that high intensity statin is prescribed to the highest tolerated dose to reach the LDL-C goals set for the specific risk group. And if suppose the target is not achieved with the statin, then a combination with ezetimibe is recommended. For primary prevention patients at very high risk, but with familial hypercholesterolemia, if the LDL-C goal is not achieved with this combination, then PCSK9 inhibitor are considered. So this is what is the recommendation, which is there on the ESC-EAS guideline to 2019. And for this, the class of recommendation is 1 and level is A. If we talk of what can be done in terms of reduction in the LDL-C by various agents, then the moderate intensity statin is capable of decreasing the LDL by 30%, high intensity statin approximately 50%, high intensity statin plus ezetimibe approximately 65%, PCSK9 alone can reduce LDL-C by 60%, and a combination of high intensity statin plus PCSK9 inhibitor nearly 75%, and all the three together can reduce LDL-C by 85%. So this is what can be used as a strategy to decrease LDL. Now going into history and some interesting facts, we know that statins, they are naturally also occurring. Say for example, lovastatin is occurring in the oyster mushroom, and other statins that is also naturally occurring Aspergillus terrace. Akira Endo in 1971, a Japanese biochemist, basically started working on the cholesterol-lowering drug, but the Nobel was backed by Joseph Goldstein. Of course, he gave credit to Akira Endo for his work on cholesterol-lowering agents. If we talk of the classification, then they are divided into source of the statin that is naturally occurring, like pravastatin, simvastatin, lovastatin, or it can be synthetic like atorvastatin or fluvastatin. If we talk of the solubility, then they are divided on the solubility factor, lipophilic or hydrophilic, and this is how we divide statins, and there are some minor differences in their actions. This brings me to the question at hand today, statins, when to start and when to stop. So I'll be discussing this topic in another 10 minutes or so in various sort of situations, because we know that we use statins very clearly in the secondary prevention. I'll be talking about the primary prevention. I'll be talking about what is the status of use of statin more than 80 years of age, and in the setting of advanced life-limiting illnesses, also what should be the target of LDL, and then concerns on the side effects, because we know these are the side effects which we normally encounter and talk about. That is the muscle getting involved, cognition getting involved, new onset of diabetes, liver enzymes going up, kidney factors can be affected, some increase in the incidence of hemorrhagic stroke, fatigue, erectile dysfunction, alopecia, some increase in the cancer, and so on and so forth. But majorly, there are 4 statin management groups. The clinical ASCVD, where the secondary prevention comes in. The second category is where there is clear-cut elevation of LDL-C more than 190, age group between 20 to 75. The third, where the person is having diabetes, and LDL of 70 to 189. And the last one is the primary prevention group, where there is no diabetes, and the LDL is in the range of 70 to 189. But everywhere, risk stratification has to be done. Why? Because in apparently healthy persons, CVD risk is more frequently the result of multiple interacting risk factors. And this is the basis of the total risk estimation. And this also basically makes us to take better action and to avoid both under and the over treatment. But the problem here is that various guidelines use various risk calculators. Say, for example, ACC, it uses the ACC CVD risk calculator. Whether we talk of ESC, they use SCORE as a risk calculator. whether we talk of Framingham, and whether we give some sort of adjustments to these risk calculations, we are knowing that there is a fact that risk is underestimated for South Asians. Now, this is the recommendation coming from ACCHA as far as the risk estimation is concerned, and various level of recommendations which are given in a particular setting. Say, for example, in adults between 40 to 75 years of age, it is the class of recommendation 1 and level of evidence B. Similarly, in patients where there is borderline risk or intermediate risk, it talks of talking with the patient and then understanding about the pros and cons, and then deciding upon the statin initiation in these patients. If there is some confusion, then certainly the coronary artery calcium scoring comes in picture, and this is also taken into cognition by the ACCHA guidelines. But grossly, what we can do in our day-to-day practice, because calculating every time probably becomes difficult for a practitioner, so we can basically remember these 5 or 6 points. Whether the person is having documented cardiovascular disease, or the person is having long-standing diabetes, whether the person is having familial hypercholesterolemia, whether the person is having significant CKD, EGFR less than 30, or whether there is some demonstrated carotid or femoral plaques in the patient, or whether the carotid artery calcium score, if it is more than 100, or LPA elevation is significantly there, or maybe the calculated risk score, if we are able to do that, if it is more than 10, risk of fatal CVD. So these are the important points which will give us an assessment about the high risk individual what we are treating. Then coming to the question of the primary prevention. So can the statins be used for primary prevention? Previous systemic review was statins basically focused on to the secondary prevention population, but now we know that most of the guidelines they talk of is starting statins in the primary prevention group as well. But certainly we know that once we are exposing more patients onto statins, then certainly the risk of adverse effects will also go. But the conclusion of the systemic review and meta-analysis, which is published in BMJ in 2021, it says that for primary prevention of cardiovascular disease, the risk of adverse event attributable to statin was low and did not outweigh their efficacy. If we talk of more evidence than the primary prevention, for the primary prevention, we can see that the ESCOT trial or the FCAP or WASCOF trials, they have all given us that insight that if suppose we are lowering the LDL significantly, then the CHD event rate will also go down significantly. If we talk of the conclusion coming from this, another article published in the Journal of American Heart Association in June 2021, that also supports the use of statin in primary prevention against the cardiovascular disease or death in 18 months surviving low-risk patients with type 2 diabetes with highest effect on elderly and adherent patient, because adherence is something which is very important. And now if I talk of a current update, which is recently published in JAMA 2022, a few days back, that also is recommending that for primary prevention in adults aged 40 to 75 years who have one or more CV risk factor, then certainly it is making a sense. Similarly, it is talking of the in the elderly population more than 76 years old, then evidence is probably insufficient here to continue statin or to start statin. So now, just briefing up when to start a statin. So the clear-cut data as on date, that LDL, if it is more than 190 mg/%, we have to start a statin. In patients with diabetes who are 40 to 75 years of age and those determined to be at sufficient ASCVD risk, then certainly statins have to be there. In children with familial hypercholesterolemia or in contrast-induced nephropathy, these are the places where these statins have to be initiated. And this is the chart which is given by ESC. Here we can focus our attention onto the red and the yellow boxes, which indicate that we have to put in statin in place. And on the top row, we can see that there is the level of LDL which is mentioned. And in the second row, we can see what is the risk of that individual. And in the first column, we can see primary prevention and the secondary prevention groups. So in the primary prevention, if there is high risk and there is higher LDL, then certainly the guidance is there to start a statin. And similarly, if we talk of secondary prevention, they are already on the high risk, and therefore, in most of these patients, statins have to be given. If we go on to the ACC guidelines, they recommend to reduce the LDLC by 50% for optimal SCVD reduction. And here, the green ones where there is the class of evidence is 1. And in the orange, we can see that the class of recommendation is 2B. And then it also talks of 3 factors: the age of the person, the level of LDL, and the risk stratification. Persistently elevated LDLC more than 160, whether the person is having chronic kidney disease in the background, metabolic syndrome in the background, some inflammatory diseases like rheumatoid arthritis, psoriasis, etc. So these factors, they have to be considered if suppose there is a confusion. So taking into account all these factors, the statin therapy has to be put in place. Talking about the recommendation of statin use in diabetes, just focus your attention onto the green. The age, if it is less than 40 years, no risk factors, recommendation of statin is not there. In rest of the phenomena, whether the person is having less than 40 years of age and having some risk factors, or whether the person is having more risk factors and higher age, in all these categories in a diabetic subject, we have to start statin. And if we talk of the acute coronary syndrome, then the suggestion is that we have to decrease the LDL by more than 50% using high dose statin. And here it is the class of recommendation 1, level A. Similarly, if suppose the control is not achieved with the use of high dose statin, then certainly PCSK9, they have to be considered. So now coming to a very important aspect, if we talk of our Indian subset, then we know that we are following American and European guidelines since 1988. The CVD mortality has increased in India by 42% since then, whereas it has declined by more than 50% in Western and the European countries. Because we know that approximately 40% of the Indians with CAD are less than 40 years of age. Approximately 25% of those are dying of CAD are less than 40 years of age. And we developed CAD 10 years earlier than the other ethnic group. At the same time, we have got increased prevalence of atherogenic dyslipidemia, other traditional risk factors, central abdominal adiposity, risk factors at younger age. Also, we have low control rates of hypertension, hypercholesterolemia, diabetes, and we have smoking and tobacco habits. Poor awareness, education level, cost, all these factors, they certainly they talk of and they give us poorer outcomes. And therefore, we need our own recommendation. So here there is a question: should we be happy with LDL reduction up to 70 mg%? Certainly no, because we need to reduce it further. Do we have some evidence here? Then here is the evidence that if suppose this is the meta-analysis of 8 statin trials, nearly 38,000 patients, and if we decrease the LDL from 75 down below to maybe 40, then certainly there is further reduction in the major cardiovascular events to the tune of 20%. There is more evidence in form of the IMPROVE trial, where in patients, those who have achieved the LDL targets of 53 mg%, there is significant reduction in the hazard ratio and the number needed to treat. More evidence coming from the ODC outcomes, where alirocumab is used in patients after acute coronary syndrome. And just focus your attention onto the orange block, which says that achieving LDLC target of 53.3 mg per deciliter can lead to further reduction of nearly 15% as in the primary endpoints. If we talk of the European guidelines, they also talk of getting the target of 55 mg% in very high risk individuals where there is already a severe CKD, or where there is the ASCVD score which is more than 10%, or diabetes with target or end organ damage. In this sort of category, certainly that phenomena of getting LDL to nearly 55 mg per deciliter is already suggested. Can we go down further? So there is a talk about, and we are talking about further reducing LDL to maybe somewhere around 30 mg%. Can it lead to more of CV benefit? And this is what we will be talking in a couple of slides. So here comes the data, or maybe suggestion from the Lipid Association of India, that talks of extremely high risk individuals, and that is also divided into 2 categories. That is category A, where there is CAD with more than one feature of high risk group, and CAD with more than one feature of very high risk group, or recurrent ACS within 1 year, despite LDLC less than 50 mg%. So these categories are very high risk categories, or they are labeled as extremely high risk category. And here there is a suggestion that we can go down further on the target LDLC, which may be somewhere around 30 mg%. If we talk of similar sort of guidelines, then AACE guideline, and just focus on the risk levels, high, very high, and extreme. And just see extreme high risk individuals, here there is a suggestion that we should go down of LDLC target to somewhere around less than 55 milligram percent. Is there a justification? Certainly that we are born with LDLC level of 30 milligram per deciliter. Hunter-gatherers have very low cholesterol and they practically don't have ASCVD in them. And Indians, certainly we are unique athenogenic class. And therefore, going down to less than 50 is something in Indian setting that is something favorable. And do we have some more evidence? The 4-year trial, here once again we can see that the median LDLC achieved through evolocumab to somewhere around 30 milligram percent led to decrease in hazard ratio with a significant p-value. Similarly, if we talk of this sort of meta-analysis of RCTs where more than 1,000 participants and more than 2 years treatment RCTs were picked up, 1.69 lakh subjects, and that also suggests that when even the baseline LDL is less than 70 milligram percent, reducing it to somewhere around 30 milligram percent demonstrated MACE reduction of 37%. So this is once again there available in the Lancet. If we talk of some sub-analysis from the Improve It trial, then 21 reduction of MACE in patients, those who achieved LDLC levels less than 30 milligram percent at 1 month compared to those with 70 milligrams. So a lot of evidence. And if we talk of the other aspects as far as the ASCVD is concerned, then here there is another analysis which is published in Circulation in June 2020, and it says that if suppose we reduce the LDLC concentration to less than 70, then certainly there is a regression of the carotid atherosclerosis. But here there is a caveat that it will not reduce the occurrence of new atherogenic carotid plaques. So we don't have a strategy to prevent atherosclerosis, and therefore this is responsible for the residual risk of ASCVD despite whatsoever we do, whatsoever level we attain as far as the LDL-C is concerned. This brings me to a very interesting area, when to stop taking statin. Obviously, if the person develops side effects or is intolerant to statins, or the statin therapy is not recommended in premenopausal patients with diabetes who are considering pregnancy or not using adequate contraception. Statins may increase hemorrhagic stroke, and therefore persons, those who are sitting at a high risk of developing hemorrhagic stroke, then certainly statins should not be given there. If the person is at the intermediate risk or at a borderline risk, and if the coronary calcium score is 0, then certainly we have to stop statin. We have also to stop statin if the CK elevation goes beyond 3 times of the patient's level, or if the limit crosses 10 times the normal. In both these situations, certainly we have to stop statin. And from where from the data comes, it comes from EAS-ESC guideline that the statin has to, they are not recommended in this premenopausal group, and the class is 3, level C. Similarly, when we are talking of the calcium scoring, if it is 0, we have to stop statin. This data comes from the ESC guideline, which recommend this. Another interesting area is that we are talking of risk calculators. But what happens to these risk calculators beyond the age of 79? Practically, they start failing. And if we talk of the guidelines, then we see here that the guidelines, they become weak and weak beyond a certain age. Say, for example, 76, where ACC, CCS, or ESCAS did not talk much about what to do about statins. The guidelines, they become weak here, excepting for the NICE guideline, which talk of continuing statin therapy even at the age of 86, but other guidelines, they become silent. Now there is the data, which also speaks that what should we do in older subjects. So here, it is analyzed that there is higher all-cause mortality trend with pravastatin beyond the age of 75 years. So this is something which we have to take into cognizance, that in older subjects, we have to take care about this. Another data, which is coming from the JAMA network, and here you can see that if suppose the person in the setting of advanced life-limiting illness, then once again you can see that the data is falling on the side where it is favoring discontinuation. That means here once again we have to rethink that in the advanced life-limiting illnesses, should we start statin? So these are the areas where I will request you to take a decision. Another thing is if suppose a person who is already on a good statin control, what happens if he suddenly stops? So stopping cholesterol lowering statin after long-term use of a statin is certainly very dangerous, because it is a double whammy in this situation, because it leads to increase in the C-reactive protein. At the same time, there is rapid rise in cholesterol. Both these things can be very detrimental to the person. So I hope I have made my point in addressing to the issue that when to start statin and when to stop statin in our day-to-day practice. Thank you so much for your patient listening.
Thank you, sir. As we know that all is uploaded on the
So
internet
good
nowadays,
afternoon.
so more and more patients are afraid about the side effects of statin, and thus they probably hinder themselves from starting statins. So now we are going to play the recorded lecture of Dr. Girish Mathur, President-elect, Association of Physicians of India.
and especially Dr. Vitul Gupta, the man behind this event, for making me part of this wonderful event. I'm so sorry that I am not able to make it physically, but maybe some next time I am lucky to be with you and to meet all the dynamic and lively persons of Bathinda. The topic allotted to me today is care of diabetes in elderly. I will share my slides. I hope my slides are visible. As we all know, diabetes is a major global health problem, and the burden of diabetes is rising progressively worldwide. At the same time, average lifespan of world population is increasing due to better access to food, comorbid conditions because of their socio-economic status. So we need to take special care of elderly diabetics. In next 15 minutes or so, I'll discuss the aspects of diabetic care in elderly which differ from diabetic care in young. The world population is increasing of the older people. Uh, in year 2013, the population above 60 years was about 15%. It is projected in 2050 it will be around 25%, about one quarter of the total population. And these changes present significant challenges to welfare, pension, and healthcare systems in the both developing and developed nations. There are many factors which affect diabetes management in the elderly, like obesity or sarcopenia, then reduced physical activity, unhealthy diet, coexisting illnesses, longevity, genetic factors, autoimmune phenomena, the polypharmacy, because there are many coexisting diseases, and the age-related changes in the glucose metabolism. There are many geriatric syndromes present in elderly people which are worsened with the presence of diabetes, like cognitive impairment and dementia, depression, reduced muscle strength and quality, disability, falls and fall related morbidity, and urinary incontinence. And at the same time, there are many physiological changes in elderly people which affect the medications in elderly with diabetes, like there is slowed peristalsis, which leads to longer exposure of medications to GI tract, like metformin and acarbose. There is decreased hepatic metabolism and blood flow, which leads to slowed elimination of drugs metabolized in liver, like netiglinide. There is decreased renal blood flow, which causes increased duration of action and potential for toxicity for sulfonylureas, insulin, and metformin. There are, in older age, we need to determine whether we need to have a stringent goals or we can have flexible goals. So if the person is of healthy functional status, there are no comorbidities, or there is short diabetes duration, then we can have a stringent goal for diabetes management. We can keep HbA1c target between 6.5 to 7.5%. But if there are recurrent hypoglycemia, there is short life expectancy, coexisting illnesses, geriatric syndromes, there are repeated falls and fractures, disabilities, functional impairment, and polypharmacy, then we should keep a flexible goal. We can keep HbA1c between 7.6 to 8.5 or even higher. There are many diabetes related complications in the elderly. These are the major causes of morbidity, disability, and mortality in the older populations with type 2 diabetes. They have microvascular complications like neuropathy, retinopathy, and nephropathy, and macrovascular complications like cardiovascular disease and stroke. And there is overwhelming evidence that the level and duration of glycemia influences the development of diabetes related complications. We talk about the patient risk factors. There are advanced age, recent hospitalization, intercurrent illness, chronic liver, renal, or cardiovascular disease, endocrine deficiency, loss of normal counter regulation mechanism, and hypoglycemia awareness. There can be poor nutrition or fastings. There can be prolonged physical exercise or alcohol use also. There are drug risk factors like use of sulfonylureas or insulins, which causes more incidence of hypoglycemia. Severe hypoglycemia accounts for almost 20% of all hospitalization for type 2 diabetes in the elderly, followed by chronic complications of diabetes 17%, acute cardiovascular events in 13%, intercurrent illnesses in 14%, and decompensated diabetes in 39%. So hypoglycemia is one of the biggest danger while we treat diabetes in the elderly. And older patients have less perception of hypoglycemia because autonomic symptoms and neuroglycopenic symptoms are subdued in old age. At the same time, attention to hypoglycemic symptoms will be reduced by depression, cognitive dysfunction, or other chronic conditions. And many elderly patients have limited knowledge about the symptoms of hypoglycemia. They are not aware about the symptoms of hypoglycemia, and there's sometimes a major problem when they experience hypoglycemia. As regard to screening and diagnosis in the elderly, the clinical presentation of diabetes in the old age is often asymptomatic and non-specific, and clinical diagnosis may be delayed. In general, screening for and diagnosis of diabetes in older age should be in accordance with the published international and national criteria and guidelines, and no age-specific criteria are there. The prevalence and incidence rates of diabetes mellitus in elderly subjects may be underestimated when you use only fasting plasma glucose as a diagnostic criteria. The presence of isolated post-challenge hyperglycemia is common in older subjects and should alert the clinician to screen for cardiovascular disease and institute risk intervention to minimize premature death, because isolated post-challenge hyperglycemia is the risk factor for myocardial infarction. In high-risk older subjects with a normal fasting glucose and where and oral glucose tolerance test is not feasible. Determination of HbA1c may be helpful in the diagnosis of diabetes. A value of HbA1c more than 6.5% may indicate the likely presence of diabetes. There are some special considerations while we manage type 2 diabetes in the elderly. Clinicians who manage older people with diabetes, they should require special skills if they wish to provide high quality care. Their approach is influenced by a multitude of factors such as the higher frequency of medical comorbidities, frailty, and socio-economic issues. The comprehensive geriatric assessment is a potentially important tool in ensuring that patients with diabetes receive a multi-professional assessment of their functional status and unmet needs. The management goals in the elderly diabetics are overall goals of diabetes management in older adults are similar to those in younger adults and include management of both hyperglycemia and risk factors. However, in frail elderly patients with diabetes, avoidance of hypoglycemia, avoidance of hypotension, and drug interactions due to polypharmacy are of greater importance than in younger patients with diabetes. In addition, management of coexisting medical conditions is important because it influences their ability to perform self-management. So what is the rationale for high quality management of diabetes in the elderly? Because of screening and early diagnosis, we can prevent progression of undetected vascular complications. There is overall improved metabolic control, which will reduce cardiovascular risk further. Improved screening for maculopathy and cataracts will reduce visual impairment and blind registrations. An integrated approach to management of peripheral vascular disease and food disorders will reduce amputation rates in general. As regard to complications of type 2 diabetes in elderly, we all know hypoglycemia is a major risk. Then there are cardiovascular complications. There are microvascular complications, cognitive like dementia, depression, falls and fractures, and peripheral neuropathy. There are general recommendations while we treat diabetes in the elderly. The glycemic control target should be individualized, taking into account functional status, comorbidities, history, and risk of hypoglycemia and presence of complications. We should begin oral glucose lowering therapy only when lifestyle interventions alone are unable to maintain target blood glucose levels. And this lifestyle measurement should be continued throughout the treatment. We should discuss with the individual and the principal caregiver care goals and medicine doses, regimes, and tablet burden before choosing glucose lowering agents. We should use the dictum start low and go slow principle in initiating and increasing medication and monitor response to each initiation or dose increase for up to a 3 months trial period. We should wait for at least 3 months before increasing the dose or adding another molecule. We should consider discontinuing ineffective and unnecessary therapies. We should also consider the cost and the risk to benefit ratio when choosing a medicine. There are some treatment priorities while we treat elderly diabetes. The elderly patient with diabetes is often a frail patient. Elderly people with diabetes are also at higher risk for hypoglycemia and hypoglycemia unawareness. Hypoglycemia is associated with many adverse consequences. The available data suggests that the risk of tight glycemic control exceeds the benefits in many elderly patients. The European Society and ADA recommended some guidelines about managing hyperglycemia and elderly diabetes. According to them, the glycemic targets for elderly with long-standing or more complicated disease should be less ambitious than for younger, healthier individuals. If lower targets cannot be achieved with simple interventions, an HbA1c of less than more than 7.5 to 8% may be acceptable, transitioning even upwards as age increases and capacity for self-care, cognitive, psychological, and economic status and support system declines. In the aged, the choice of anti-hyperglycemic agents is very important and we should focus on drug safety, especially protecting against hypoglycemia, heart failure, renal dysfunction, bone fractures, and drug-drug interactions. The strategies specifically minimizing the risk of low blood glucose may be preferred. If we discuss the individual drugs while treating diabetes in the elderly, the first and foremost drug in the use is metformin, but it should be used carefully in older populations, even with normal creatinine. You should watch out for comorbidities that increase the risk of acute renal impairment or lactic acidosis. We should follow closely for weight loss and GI side effects. As regard to sulfonylureas, they should be used with much caution in frail elderly who forget to eat or skip meals. Drug-induced hypoglycemia are common if there is renal or cardiac dysfunction and gastroparesis. So sulfonylurea should be avoided if there are risk of hypoglycemia. As regard to glutathiones, they are well tolerated, does not cause hypoglycemia, but they cause fluid retention, congestive heart failure, myocardial infarction, fractures, and bladder cancer. Alpha glucosidase inhibitors, they are fairly safe and effective, but are not used widely because of the flatulence and diarrhea are common with these group of drugs. As regard to DP4 inhibitors, which are the most suited group of drugs for treating diabetes in the elderly, there is reduction in HbA1c similar to younger patients. There is low risk of hypoglycemia and they are weight neutral. GLP-1 agonist, there is no risk of hypoglycemia monotherapy, but we need to take injections. But once weekly injections can be used and we should monitor diet intake and weight. As regard to SGLT2 inhibitors, they are associated with lower rates of heart failure hospitalization, all-cause mortality, and hypoglycemia, but higher rates of diabetic ketoacidosis is a risk, and weight loss is another risk in frail diabetics. So we should use with caution while treating frail diabetics with SGLT2 inhibitors. A word about insulin in elderly. Most trials on insulin therapy in type 2 diabetes exclude the geriatric population. Addition of insulin to oral antidiabetic drugs is safe, though data are limited. There are no evidence base showing superiority of one insulin regime over another. Before giving insulin, we must evaluate if the patient is physically and cognitive capable. We should administer appropriate insulin dose. We should monitor blood glucose frequently. We should recognize and treat hypoglycemia as and when it occurs. And we should reassess frequently. Rapid acting insulins can be used for those with erratic eating patterns, but we should use with caution while using regular acting insulin for risk of hypoglycemia. We should avoid sliding scale insulin. Premix insulins should be used in those with vision difficulty or dexterity, but they require a regular eating schedule. Watch out for nocturnal hypoglycemia because of early evening meals. To summarize, advancing age is a risk factor for the development of diabetes. Elderly onset diabetes should be diagnosed as early as possible in accordance with national guidelines to avoid the progression of vascular complications, retinopathy, and renal impairment. Hypoglycemia is a danger in elderly diabetes patients due to a higher level of hypoglycemic unawareness and medication combinations in this population. The presence of comorbidities presents a unique challenge for the management of early type 2 diabetes, and cognitive dysfunction, depression, risk of falls, fatality, and other comorbidities need to be addressed as part of comprehensive care. So, we must look for one of the most dangerous thing in treating diabetes and elderly is hypoglycemia. We should avoid drugs that cause hypoglycemia. We can have a flexible targets, and we should use the drugs rationally. Thank you so much for the patient hearing.
Thank you, sir. As we know that our geriatric population is rising and also as we are seeing diabetic epidemic, so your lecture on diabetes in elderly was really worth listening. So now we are proceeding for the next guest lecture for Dr. Shashi Shekhar Chatterjee, Senior Consultant Cardiologist, Cardiology Clinic and Heart Hospital, ex-director Indira Gandhi Institute of Cardiology Patna, past President CSI Bihar. The topic for the lecture is Journey of Rheumatic Fever 1944 to 2021.
इससे स्टार्ट करता है. At the outset, I want to express my thanks and gratitude to Professor Vittal and his team of MAPICON for inviting me to speak on this occasion. My topic of discussion is Journey of Rheumatic Fever. In 1944, Sir Dr. Jones published this monumental paper regarding the diagnosis of rheumatic fever, and this was not done in a year or two. Dr. Jones had joined as in charge of a Good Samaritan ward, which was reserved for the patients of rheumatic fever in Children's Hospital, Boston, because at that time, rheumatic fever and rheumatic heart disease was the second most commonest cause of death. And from 1920, after working for almost a quarter of century, he published this paper. However, the journey of rheumatic fever did not start in 1944. In the 18th century, it was known as atraumatic joint inflammation. Subsequently, people realized that they have some cardiac manifestations as well, and they coined the term rheumatism. After the development of stethoscope, physicians started beginning to notice that the rheumatism also have irregular heart sound, and I feel that the whole credit for the concept of rheumatic fever should go to Walter Chiddle, who in 1980s recognized that the rheumatic fever could be fever and arthritis plus something else, and this something else could be either carditis or chorea or erythema nodules. Rheumatic fever and rheumatic heart disease is a disease of poverty and illiteracy. Almost more than 33 million people worldwide are currently living with rheumatic heart disease, and more than 3 lakh people die every year of rheumatic heart disease. This is the world map showing the prevalence of rheumatic heart disease, and it's very clear it's prevalent in Africa, Southeast Asia, and some part of the South America. It's a multi-system disease resulting from an autoimmune reaction to group A streptococcal infection in genetically susceptible individuals. So this is the original Jones criteria, and he proposed that 2 major or 1 major and 2 minor criteria should be sufficient to make a diagnosis of rheumatic fever. If you see this slide, the criteria are more or less the same. The changes are that arthralgia has been made a minor criteria. History of previous uh, definite rheumatic fever or rheumatic heart disease was a major criteria there, which has been removed from here. Abdominal pain and epistaxis where minor criteria in the original Jones criteria have been removed from here, but I can vouch that I have seen patients of children of rheumatic fever having this, whether this was due to high dose of salicylates or not, I cannot, I'm not very clear about it. Then in 1951, a paper was published from the same group, Dr. Jones and Bland, a 20-year follow-up of 1,000 patients of rheumatic heart disease. And you can understand the amount of work they must have done because at that time there was no electronic recording system. And after 20 years, it was found that 1/3 of the patients were free of rheumatic heart disease, 1/3 patient had persistent rheumatic heart disease, and 1/3 patient died. In 1972, a paper was published regarding the long-term prognosis of rheumatic fever patients receiving regular intramuscular benzathine penicillin, and then here 79 patients having only mitral regurgitation or mitral and aortic regurgitation. When they were followed up after 9 years, only 14 had a persistent murmur. All others have disappearance of murmur, had disappearance of murmur. The Jones criteria was modified and revised subsequently by AHA and WHO multiple times, and the only criteria for this modification was that they wanted to have more specific more specificity in the diagnosis, and as you increase the specificity you are going to lose the sensitivity, and that is what happened in our part of the world. Arthralgia, which was a major criteria, was made a minor one. Erythema marginatum, which was a minor criteria, was made a major criteria all along, but I have never seen a patient of erythema marginatum in my patients of acute rheumatic fever. Pre-existing rheumatic heart disease was a major criteria, subsequently made a minor criteria, and then it was given other status. And recent evidence of this recent streptococcal infection was not even mentioned over here, was made a minor criteria and then made an essential criteria. In 1992, AHA came with their guidelines with 3 modifications. They made 3 exceptions in this diagnosis: rheumatic chorea, indolent carditis, and recurrence of rheumatic fever. And I'll come to that. But before that, this paper also had one important information that the increased ASO titer were reported to be present in 15 to 70% of school-going children, meaning thereby without any evidence of rheumatic fever or rheumatic heart disease, meaning thereby the presence of increased ASO titer does not mean rheumatic fever. They do not require secondary prophylaxis, which are being given by some of our colleagues. Positive ASO titer is present in only 80% of the patients with ARF, and even if you add 3 antibody tests, only 95% will have evidence of proceeding streptococcal infection. And the 3 things, recurrent attack in 2003, WHO came with the criteria with the same thing, and here the recurrent attack of rheumatic fever in a patient to establish rheumatic heart disease, 2 minor manifestations plus evidence of a preceding group A streptococcal infection was no major criteria was required, and rheumatic chorea and insidious onset rheumatic carditis, other major manifestations or evidence of group A streptococcal infection was not even required. So this was the clinical scenario where we had been working with patients of rheumatic fever, and there were multiple patients where we had a very strong suspicion of rheumatic fever, but the criteria was not being fulfilled. Let us see those situations. Polyarthralgia, which was not a major criteria. Monoarthritis, again, not a major criteria. Again, present echo evidence of mitral regurgitation, again, was not a major criteria because at that time murmurs were essential for the diagnosis of carditis, and negative ASO titer. In absence of negative ASO titer, it was difficult to make a diagnosis of rheumatic fever. This dilemma of diagnosis of rheumatic fever was very well expressed by a medical student who wrote in his diary about a patient, Eva, with rising fever. What does your workup show? Is there arthritis? A touch of streptococcus? A sound I hear, I fear, my dear, mark regurgitant flow. But Jones criteria have yet to appear to you, so you are still in FUO. This is what this dilemma persisted for quite a long time before in 2005 when Australian guideline came, and they made two important changes. That the presence echo evidence of rheumatic valvular disease was made equivalent to carditis, the murmur, and aseptic monoarthritis and polyarthralgia was made major criteria in high-risk group of patients, and we do belong to the high-risk group of patients. Then in 2008, New Zealand gave its guideline, which was all similar to the guideline given by the Australian, but there were two important concepts. One was the probable acute rheumatic fever and possible acute rheumatic fever. This concept was given for the first time by the New Zealand guideline. In the probable acute rheumatic fever, one major and two minor, with inclusion of evidence of preceding gas infection as a minor manifestation and not as an essential criteria. And possible is when there is strong clinical suspicion of ARF, but insufficient signs and symptoms to fulfill diagnosis of definite rheumatic fever. After that, in 2008, the Indian guideline came for diagnosis and management of acute rheumatic fever. And they unfortunately, they did not follow the Australian guideline. They went with the AHA and WHO guideline. But there's one important part of this publication that they have given doses of steroids which should be given, because there's a lot of confusion over here. The patients of carditis whom the steroids are to be given, they should be given in the dose of 2 milligram per kilogram per day for 2 to 3 weeks, and then gradually tapered off either 5 milligram every 3 days with adding aspirin, or gradually tapering it off in another 8 to 10 weeks, meaning thereby steroid must be given for 3 to 4 weeks in full doses, followed by 8 to 10 weeks in a gradually tapering doses in cases of acute carditis. In 2009, the circulation published this paper regarding the primary prevention, and they made a statement that even when started as long as 9 days after the onset of acute illness, penicillin effectively prevents primary attack of rheumatic fever. And these are the different drugs and doses for the prevention of for the primary prevention of rheumatic fever. In 2018, in 2012, World Heart Federation came out with the criteria of echocardiography diagnosis of rheumatic heart disease. This was a very major development, and it is a very exhaustive article, but anyone who wants to do echocardiography in rheumatic heart disease patient, they must read this one and follow this one. Then in 2012, Australian guideline again came, and then in 2014, the New Zealand guideline came. And after all these, ultimately in 2015, AHA revised its criteria for the diagnosis of acute rheumatic fever, and they accepted the Australian and New Zealand criteria, and they also accepted the New Zealand criteria for the possible rheumatic, the concept of possible rheumatic fever. In 2018, World Health Organization unanimously adopted a global resolution on rheumatic fever and rheumatic heart disease. This historic decision makes for the first time that the rheumatic fever and rheumatic heart disease have been recognized as the global health priorities on the world stage. This is a very major development, and this will definitely boost the research work in rheumatic fever. 2020, again, Australian guideline came, which was updated in 2022. And there, the minimum duration of secondary prophylaxis has been given in different groups. But we all know that we should remember that for severe rheumatic heart disease, you need this penicillin prophylaxis till the age of 40 years. And for patients who have got rheumatic fever but no cardiac involvement, should be given for 5 years, or after the last episode, or 20 years, 21 years, whichever is late. And for valvular heart, I mean, those patients who have valve surgery, the recommendation is that penicillin prophylaxis should be given for lifelong. Again, in 2021 paper came in New Zealand, in NEJM, regarding the secondary antibiotic prophylaxis for the latent rheumatic heart disease. And this was done in a group of children who during echocardiographic screening were found to have valvular heart disease, and they were given penicillin prophylaxis, and it was found that there was a definite significant reduction in the progression of disease in 2 years, establishing much more the importance of secondary prophylaxis even in patients who did not have a history of rheumatic fever but found to have rheumatic heart disease on echocardiographic screening. But there is one problem with the benzathine penicillin injection. Some of these patients die immediately after penicillin injection, and this has created a lot of problem in giving injection. But in 2021, this paper came from Jayadeva Institute, which showed that in last 5 years, means 2015 to 2020, more than 25,000 benzathine penicillin injections were given, and only 0.03% of the patient had anaphylaxis, and there was no death. However, we have seen patients dying immediately after benzathine penicillin injection, and uh, and the AHA has done a verbal autopsy of 10 patients who have died immediately after the injection, and these were the and after out of these 10 patients, only three had anaphylaxis, meaning thereby presence of urticaria or bronchospasm, and 7 did not have this thing. So it was hypothesized that these patients possibly had vasovagal syncope, and this vasovagal syncope leak because these were underfed, hungry patients coming to the hospital in a dehydrated condition, and they were given injection in a hurry. That the pain of injection, the fear of injection, and other comorbidities in patients with severe rheumatic heart disease lead to vasovagal syncope with hypotension and bradycardia, giving rise to coronary hypoperfusion, arrhythmia, and therefore they have proposed that in severe risk patients with mitral stenosis, aortic stenosis, ventricular dysfunction, and severe symptoms should be given oral penicillin, knowing even very clearly that these patients oral penicillin have got a lesser protection. And then in 2022, we have a paper from Israel. Is rheumatic fever is present is in a developed country. It is still relevant, and they have come to the conclusion that it remains an important cause of morbidity and mortality in the developed countries. And they have also added that the presentation of small joints as hips, although uncommon, should not exclude the diagnosis. So, coming to the end, the journey of rheumatic fever can be broadly divided into 4 subgroups: 30 to 1930 to 50, the decade of learning; 50 to 70, decades of dissemination; 70 to 2000, decades of stagnation; and reawakening after 2000 with Australian, the New Zealand, the revised AHA guideline, the World Heart Federation echocardiographic criteria, and most importantly, the WHO taking it as the global health problem. With this, there has been now people are working on the biomarkers of the diagnosis of acute rheumatic fever, like NT-proBNP for heart failure. They are also working for safer and less painful penicillin delivery and other antibiotics, which oral antibiotics, which can be used for rheumatic fever prophylaxis. And they are also working on streptococcal A vaccine development. In another few years, I feel we will have a vaccine for rheumatic fever, and then we will be able to contain or possibly eradicate rheumatic fever like polio and smallpox. In the end, I want to present this picture of a small child who was admitted under me with acute carditis, severe AR and severe MR and congestive heart failure. I tried to do everything for this patient, but could not save him. I dedicate this presentation in his memory. Thank you.
Thank you, Dr. Chatterjee, for an excellent talk. And in Indian setup, I think rheumatic heart disease gains a lot of importance. And I must compliment you for choosing this topic.
Walsall Manor Hospital, UK. And the topic is non-surgical treatment of severe aortic stenosis, a revolutionary therapy.
Hello, I am Dr. T.P. Singh. I am a consultant cardiologist now working at Walsall Manor Hospital, UK. The topic of my today's discussion is TAVR or TAVI, which is a non-surgical management of aortic stenosis, which is a new game changer, and it's a revolutionary therapy and boon for the elderly. So previously, the only option for patients having severe aortic stenosis was to do a surgical aortic valve replacement, which has now been replaced, I would say replaced by this TAVI or TAVR, which is a transcutaneous aortic valve replacement or implantation. Earlier, it started with patients, those who are very high risk for surgery, those who are quite old, more than 80, and they are not able to stand the stress of surgery. So this procedure was started for them. Gradually, it translated to procedure for intermediate risk for surgery patients. Now, even for low risk patients, the data has come up, which shows the equivalent benefits of this, rather this TAVI to be more on the beneficial side. So aortic valve stenosis, basically, it occurs when the valve of the heart, this aortic valve, narrows. Aortic valve is a valve which supplies blood to the whole of the body, because when blood from left ventricle goes to aorta, it is through the aortic valve. So aorta supplies blood through the whole body. When it is getting narrowed, so narrowing prevents the valve from opening fully, which will obstruct the blood flow from your heart into your aorta and onward to the rest of your body. Prevalence of aortic stenosis. Aortic stenosis is estimated to be prevalent in up to 7% of the population over the age of 65. It is more likely to affect men than women, and 70% of adults with symptomatic aortic stenosis are male. Coming to demographics, aortic stenosis is seen in 7% population, which is more than 65 years old. And there is another term called aortic sclerosis. Aortic sclerosis is the term where the aortic valve is thickened, but there is no narrowing. So you can hear a loud murmur, ejection systolic murmur, but there is no stenosis. It is seen in the 29% population, which is more than 65-year-old. This aortic stenosis is not a benign thing. It has got 50% greater risk of mortality and myocardial infarction. And in 9% of patients over 5 years, this aortic sclerosis progresses to aortic stenosis. What are the Indian demographics? The prevalence of moderate or severe aortic stenosis in patient more than 65-year-old is 5%. And it is the most common valvular heart disease of the elderly and increases with age. The prevalence is 7 to 8% at age of 75 years and 10% at 85 years. What causes aortic stenosis in adults? The commonest is age-related calcific aortic stenosis. Aortic stenosis in patients over the age of 65 is usually caused by calcium or calcific deposits associated with aging. So this is an age-related calcific aortic stenosis. Another common cause, which is seen in India, is rheumatic fever. But rheumatic fever, usually isolated aortic valve is involved in only 4% of cases. But as a multi-valve disease, it can be there in addition to mitral valve. Congenital abnormality. In significant number of cases, adults may develop aortic stenosis resulting from a congenital abnormality like bicuspid aortic valve. Some people, they have got bicuspid aortic valve, means they have only two cusps instead of normal three cusps. And with the wear and tear of age, of flow across the aortic valve, this valve starts, bicuspid valve, which is anatomically not normal, starts to get thickened and narrowed with age, with advancing age. So these are the major presentations. Normal valve is like this. This is a bicuspid. So you can see here there are three cusps, and here there are two cusps in bicuspid aortic valve. This is the rheumatic valve, and this is the degenerative calcific aortic valve. So this image shows the gradient across the valve. When it is normal, the gradient comes like this, velocity is quite normal. And when it is aortic stenosis, the aortic valve velocity is less than 2.5 meter per second, which is in the normal range. But in mild to moderate aortic stenosis, the velocity becomes more than 2.5 and it's up to 4 meter per second. And in severe aortic stenosis, this is the shape of the valve and there is very high gradient and velocity of more than 4. What can be the major risk factors? Independent clinical factors associated with degenerative aortic valve disease are increasing age, male gender, hypertension, smoking, and elevated LDL and lipoprotein(a). What can be the signs and symptoms? Symptoms can be angina, syncope, and heart failure. These three are the main presenting features of aortic stenosis. Patient starts having typical anginal chest pains, and sometimes we suspect that it's a coronary artery disease, but when we evaluate, it comes out to be aortic stenosis. Syncope is also one of the grave findings, and ultimately the patient goes into heart failure. Earlier, it can be a heart failure with preserved ejection fraction, but gradually patient this pumping capacity of heart starts falling down because of the severe narrowing of the aortic valve, and it becomes like a dilated cardiomyopathy with severe aortic stenosis. The signs can be typical carotid parvus at tardarus pulse, laterally displaced apex beat, soft second sound, crescendo, decrescendo systolic murmur, which can radiate to carotids, typical ejection variety, timing of peak murmur, timing of the peak of murmur, and not the intensity predicts the severity. So aortic stenosis is actually a life-threatening and progresses very rapidly. So when patient starts having angina in aortic stenosis, the prognosis, life survival is around 5 years. If patient comes with syncope, the survival is around 3 years. And if he comes with heart failure, the average survival will be 2 years only. Survival after onset of symptom is 50% at 2 years and 20% at 5 years. Intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. So this aortic stenosis has got sobering perspective. When comparing the survival, 5-year survival with other malignant cancers, the survival of severe inoperable aortic stenosis is just 3%, 5-year survival. You can compare it with other cancers like breast cancer, prostate cancer, colorectal cancer, and ovarian cancer. So this has got the severe aortic inoperable aortic stenosis got a worst prognosis. These are the echocardiographic parameters of severity as assessed while doing the echocardiography. Severe aortic stenosis, the velocity is more than 4, mean gradient is more than 40, aortic valve area is less than 1, and DVI, which is called dimensionless velocity index. It's a ratio of the gradient across the aortic valve and alveoli. If it is less than 0.25, it is severe aortic stenosis. These are the multiple modalities which may be used to diagnose severe aortic stenosis. First of all, we examine the patient and hear a typical murmur, then subject the patient to echocardiography and we diagnose aortic stenosis. And ECG may show left ventricular hypertrophy. And if we plan for further planning about TAVI or TAVR, we need to get a cardiac CT done and to measure the annulus and see the peripheral vessels. And ultimately, cardiac cath can also be done if required. So this is the echocardiographic parameters, how to measure the alveoli velocity, how to measure the alveoli diameter accurately, and then calculating the aortic valve area. These are the few echocardiographic 3D planimetry of aortic valve. There is another problem with severe aortic stenosis. Sometimes some of the parameters of aortic stenosis, echocardiographic parameter, they some are coming in the severe variety and some are coming in the moderate variety. Like aortic valve area is less than 1, but the gradient or velocity is less than 4, gradient is less than 64. And mean gradient is also less than 40, but aortic valve area is on the severe side. So what to do? So there are two subsets of patients where patients may have severe aortic stenosis, but the ejection fraction is quite low. So it cannot form such a gradient because of low ejection fraction, which comes in the severe gradient. So this is called low flow, low gradient, severe aortic stenosis with low ejection fraction. Another subset of patients can be low flow, low gradient, severe AS with preserved ejection fraction. Here, ejection fraction is preserved, but still aortic valve area is less than 1, but gradient is less than, mean gradient is less than 40. So this is seen in small females with small LV cavities. So they are not able to produce the enough gradient, but it is actually severe aortic stenosis. So up to 35% of patients with severe AS present with low flow, low gradient. For AVR because of low gradient. But these are the patients who actually require AVR. Aortic valve area less than 1 centimeter square, mean gradient less than 40, ejection fraction is less than 50%, and stroke volume index is less than 35. This is the typical subset of patients of low flow, low gradient aortic stenosis. How to prove it? Do a dobutamine stress echo if you suspect that aortic stenosis is actually severe, but due to low ejection fraction, the gradient is coming less in the moderate variety, but aortic valve area is less than 1. So do a dobutamine stress echo. We can determine if the AS is severe by reassessing the gradient across the aortic valve and measure the aortic valve area as well. We can also assess the myocardial contractile reserve. So what is paradoxical? As I told you, this is typically encountered in small elderly ladies with small LV cavities and marked left ventricular hypertrophy and frequently associated with long-standing hypertensions. The low gradients often lead to underestimation of severity of the disease. So many of these patients do not undergo aortic valve replacement. So here the EF is preserved, but aortic valve area is less than 1 and gradient is also less than 40. Ejection fraction is more than 50. with stroke volume index less than 35. So what to do in this patient? So where ejection fraction is low, we can subject that patient to dobutamine stress echocardiography. But here, what needs to be done is we should get a cardiac CT done. If focal calcium score of aortic valve is more than 3000 in male and more than 1600 in female, severe AS is very likely. Even if more than 2000 male, more than 1200, it is likely. But if it is less than 1600 in male and less than 800 in female, severe aortic stenosis is unlikely. So you can rule out severe aortic stenosis, the calcium score is less than 1600 and 800. So what are the options for treatment of aortic valve? So patients, those who are suitable for open chest surgery, usually the surgical aortic valve replacement is the surgery. And where patients are high risk or inoperable, this procedure is for those people. Transcatheter aortic valve replacement is TAVR, or if it is TAVI, it is transcatheter aortic valve implantation. So this aortic valve replacement greatly improves survival. It has been seen, study data demonstrate that early and late outcomes were similarly good in both symptomatic and asymptomatic patients. And it is important that among asymptomatic patients with severe aortic stenosis, omission of surgical treatment was the most important risk factor for late mortality. So even for asymptomatic patients, this aortic valve replacement greatly improves survival. So refer asymptomatic aortic stenosis patients to heart team for evaluation, whether he goes for surgery or goes for transcatheter valve implantation. So this decision has to be made by a multidisciplinary team. It has been seen that patients, there is very low percentage of aortic valve surgery, those who have severe aortic stenosis. Studies show that at least 40% of patients with severe AS are not treated with AVR. So what is this transcatheter? This is a replacement as an alternative to traditional thoracotomy, less invasive than traditional thoracotomy for patients considered to be high risk or now intermediate risk and low risk in coming times. So this TAVI is expanding the unmet clinical need. TAVI has expanded the options for untreated patients by offering a minimally invasive procedure that does not require cardiopulmonary bypass. What are the additional benefits? A shorter procedure with less pain, shorter stay in the hospital, shorter recovery time, normal aortic valve function, and improvement in overall life expectancy and function. The first TAVI procedure took place in 2002, and then with an increasing knowledge experience that led to much improved patient outcomes, and CE marking happened in 2007, and now it's gradually had reached a stage where we can offer this procedure to the low-risk patients. So this is how does it look like. This is a stenotic aortic valve, and this valve exhibits consistent radial strength and maintains its concentric shape even in a diseased annulus. So this is a valve. Many trials have shown that they have favored TAVI. This partner 1A, US core valve, Notion, partner 2A, they all had favored TAVI instead of surgical aortic valve. So what are the factors which do need to be considered by heart team for the decision between surgical or TAVI in patients who have increases? So there is a scoring system. If it is less than 4%, it favors surgical AVR. If it's more than 4%, it's TAVI. If there is severe comorbidity, it's TAVI. Age more than 75, it's TAVI. Previous surgery, frailty, restricted mobility, they all favor TAVI. But if there is suspicion of endocarditis, it favors surgical AVR. Some sequelae of chest infection, porcelain aorta, intact coronary bypass grafts, expected patient prosthetic mismatch, severe chest disformation, they all favor TAVI. But what favors surgical AVR? Short distance between corneosteal and aortic valve annulus, size of aortic annulus out of the range for TAVI, aortic root morphology not favorable for TAVI, valve morphology is not favorable, and presence of thrombi in aorta or left ventricle, they all favor surgical AVR. So severe CAD, which also requires revascularization by CABG, favors surgically. Concomitant mitral valve disease, tricuspid valve disease, aneurysm of ascending aorta, septal hypertrophy, they all favor surgically. So in TAVI or TAVR, there are two options. One is a balloon expandable valve, and it is now available in India as my valve from, and this other is Edwards sapien valve, and this self-expandable is Medtronic Evolute and Boston Accurate. So showing few cases, this is one of the patients which we did. You can see the tight aortic valve. These are echo before the procedure. And this was the maximum gradient of 88, mean gradient of 57, and aortic valve area of 0.72 centimeter square. So this was a procedure. This is the aortic root angio, and this is a valve which is placed across the aortic annulus. And this is the after inflation, we took a shot after this procedure, and you can see the valve here is well placed. There is no aortic regurgitation. So this is the echo after the procedure. You can see a clean aortic valve, clean area from the aortic valve, and gradient is minimal. This is another patient who had a COPD. He was 78 years male and severe COPD. Very high gradients, 91 and 52, aortic valve area very low, 0.49. And this is the procedure. And you can see the good aortic valve open. So this is the echo after the procedure. So TAVI basically needs multimodality imaging before going for the procedure. And some of the complications can be vascular injury, annular rupture, stroke, coronary obstruction, and need for permanent pacemaker. These complications are now occurring to very, very lesser extent because of the improvement in the designs of the valves and more precise placing and all these things. They have now decreasing the complications. So rate of surgical bailout has become very low for TAVR. So what are the key takeaways? Aortic stenosis prevalent with a high morbidity and mortality when symptomatic, and aortic valve replacement is the only treatment associated with improved outcomes. Low risk severe AS patients will benefit from surgical AVR. Low gradient does not necessarily exclude severe AS even when the ejection fraction is normal. And TAVI is the excellent alternative to traditional aortic valve surgery in high and intermediate risk for surgery patients. Thank you very much.
Thank you, Dr. T.P. Singh, for enlightening talk, as well as telling the progress of this procedure from complicated and severe patients to now becoming a routine procedure, even if patient is opting for open surgery. I think this procedure is good to decrease mortality. Thank you very much.
Now, for the next recorded lecture, we have Dr. Sandeep Suri, who will be presenting on the topic hyperuricemia management and dispelling the myths.
Hello, yes. Hello, everybody. So on my behalf, I am Dr. Sandeep Suri. It's a great pleasure to be here for MAPICON 2022. And I must thank Professor Dr. Vitul Gupta sir for inviting me to share my views on hyperuricemia, and especially asymptomatic hyperuricemia, because it's a really very topic which has got a lot of controversies attached, right from the treatment, whether we should treat it or not, right from the diagnosis, which are the criteria to diagnose it. Very common scenario, having serum uric acid high, very low cost investigation, so you can find it in lot of routine investigations having uric acid levels, but lots of controversies right from diagnosis, how to treat it, what are the cutoffs of also, what are the management issues related to it. So we are going to highlight all of these, and I have made my topic in a question answer form, and these are the selected questions which are pertaining to us for routine practice, very clinically relevant practical questions we are going to take today. Now, what is hyperuricemia? So hyperuricemia, the prevalence is 25.8% of Indian population have got hyperuricemia, and with or without gout. Serum uric acid more than 6 milligram per deciliter is taken as hyperuricemia. High uric acid levels are linked to several diseases, including painful type of monoarthritis, that is gout, and that is also due to deposition of monosodium urate, sodium crystal deposition in tissues, and it is an independent precursor of gout. Also, it is associated with various health conditions like heart disease, diabetes, kidney disease, and metabolic syndrome. What is the prevalence in India? There is a Vellore study. It was in 2020, the recent study that was there, that showed that if you take southern states of India, the prevalence is 31.6%, whereas Haryana, Punjab, Himachal, Jammu Kashmir and Madhya Pradesh have got second highest prevalence of 28.43%. As the age increases, prevalence of hyperuricemia, high serum uric acid level increases. Also, in the male gender, it is 57.31%, and the total number of subjects included in this study was more than 48,000 patients. They were included here, and here it was in male patient it was 57.31%, whereas for females slightly lower it is 42.69%. But as the age increases, the hyperuricemia or serum uric acid also increases. So it was a study that was published in International Journal of Research Medicine Science in 2020. And from where this uric acid comes? Uric acid comes basically it's a final product of purine metabolism. It is synthesized in liver, GIT, vascular endothelium, muscle, and kidney. And it is mostly it comes from the metabolism of endogenous purines. So mostly it is endogenous purines, and also tissue nucleic acid or pre-purine nucleotides which make a source of purine. And DNA, RNA, ATP, GTP, cyclic AMP, NADH, they are the most important sources of purine. Exogenous sources also contribute, but to lesser amount in comparison to endogenous source of uric acid. Eating purine-rich food, specifically red meat, and that adds only very small amount of uric acid food. Also, fructose also adds to a good amount of serum uric acid food. Xanthine and hypoxanthine are the products of purine metabolism. They get oxidized, they get converted, they are oxidized to end product, and this end product is uric acid. We don't have uricase enzyme active, so we don't convert uric acid to allotoin, because allotoin is much more soluble end product and that can be excreted. But we have uric acid. This is you can say non-functioning mutation which happens in liver, and uricase is not active here in human being and also in apes. But the uric acid, if once it is formed, 30% is degraded by gut microbiota, whereas 70% is excreted by kidneys. The most important enzyme or the key enzyme is xanthine oxidoreductase. This is the most important key enzyme which converts purine hypoxanthine to xanthine, and then xanthine hypoxanthine to uric acid. So it's a very, very important enzyme that has to be considered. Why hyperuricemia 12? And whether hyperuricemia leads to gout or not? It's a very pertinent question. Actually, it is due to, most of the time, 90% cases, it is due to inadequate renal excretion. 90% of our patients are under excreta. Actually, this is what happens, that 99% of uric acid which is excreted from glomerulus are being gets reabsorbed in proximal columnar tubule. After reabsorption, it is secreted by proximal columnar tubule, and after secretion, which is very important step, there is again extensive reabsorption in distal proximal columnar tubule. So 90% of patients are under excretor. It's the most common cause of hyperuricemia. 10% cases you find overproduction, and it is the only 10% is contributed due to overproduction. So these are the two important causes of issues related to hyperuricemia. Now gout. Gout can occur at any level of serum uric acid. So remember, gout can occur at any level of serum uric acid. Most importantly, gout patients have 41% less urinary excretion of uric acid. So they are, the most important effect is secretion at proximal columnar tubule, which is much more lower in those patients who develop hyperuricemia and gout. Hyperuricemia is definitely a risk factor for gout. It has been well observed that large proportion of individuals with hyperuricemia and never had gout flares. And usually it is a decade of hyperuricemia, then the gout flare is there. While some patients with gout can have even normouricemia. So recently their understanding about uric acid has improved in 2021. Normally male uric acid levels are greater than 7 milligram per deciliter, or female uric acid level are greater than 6 milligram per deciliter. They are considered as hyperuricemia. However, Verdis et al. Showed that the threshold for uric acid level increase lead to total mortality is only 4.7 milligram per deciliter, and cardiovascular mortality it is 5.6 milligram per deciliter, which was significantly lower than the clinical diagnostic criteria. So we have to look at serum uric acid in a different perspective. We know that gout is a very important relationship with hyperuricemia, specifically when it is more than 9%. But what is asymptomatic hyperuricemia? So as per definition of asymptomatic hyperuricemia, 7 milligram or more than that is in male is asymptomatic hyperuricemia when it is not associated with any sign or symptom of crystal deposition. So it's very important. 6 milligram or more than 6 milligram in female is considered as asymptomatic hyperuricemia, and this is above the normal upper limit, and the normal upper limit has got also variations like gender variations are there, ethnicity variations are there, diet related variations are there, age related variations are there. Then again the time of testing is important. Then lab technique which is required to look for uric acid is again very important. So these are the confounding or variable things which can be there, but level cutoff is 7 milligram above or 6 milligram above respectively from males and females. And the normal value in males is 5 plus minus 2 in the males, and for female it is 4 plus minus 2. So these are the normal values. But for asymptomatic hyperuricemia, there should not be any symptoms or signs of crystal deposition. There is also physicochemical definition, that is saturation point of monosodium urate in vitro at 37 degrees centigrade at pH of 7 is 6.8 milligram deciliter. So this is a cutoff of hyperuricemia. But in joints, even when you can have a less than 35 degrees centigrade at 6 milligram per deciliter, there can be deposition. There are various consequences like gout, there can be nephrolithiasis, but importantly it is also associated with hypertension, CV disease, stroke, and renal disease and metabolic syndrome. So we have both a good part also, because it is a very potent antioxidant. Uric acid is a very potent antioxidant, and also it is a neurotropic factor. And the good part is that if you decrease uric acid less than 3, the more chances of developing the dementia, Alzheimer, and Parkinson disease, and motor neuron disease. So more of neurological problems can be there if you go below 3 or more than or less than 3. But bad part is that it is associated with gout, tophi, and also nephrolithiasis. But very ugly part is that it is CVA and myocardial infarction which is related to hyperuricemia. So these are important clinical consequences. You can have gout, you can have renal calculi, CKD development and progression, metabolic syndrome, insulin resistance, cardiovascular disease, and acute urate nephropathy. So what precautions we should take while taking sample for uric acid? But the test which we require for diagnosis of asymptomatic hyperuricemia, we go for the uricase enzyme method. It is more specific, less cost, it's a cheaper test, and also it is, you can say, the colorimetric method which we are using earlier that overestimates uric acid by more than 1 milligram per deciliter. So it's a much more specific, much more sensitive, and very cost-effective method which can be used for the testing of serum uric acid. But importantly, these are the various important precautions which must take while checking for the serum uric acid level. Must be done after an overnight fast. At least 8 hours of fasting is required. Avoid alcohol intake in the day before. Avoid vigorous exercise before collecting a sample. Avoid drugs that can potentially interfere with uric acid level. Avoid dehydration. Avoid smoking. Smoking reduces uric acid level. But also, the elevation in serum urate concentration has to be correlated with renal insufficiency. It's a very, very important that if your serum creatinine is 1.5 or less than 1.5, 9 milligram indicates high serum uric acid level. Greater than 9 milligram is much more significant. Whereas if your serum creatinine is between 1.5 to 2, then it is around 10 milligram per deciliter. And if your serum creatinine is beyond that, or you have got more advanced renal failure, then the points to be considered of serum uric acid level maybe over the 12 milligram per deciliter. So renal insufficiency also contributes to the level of serum uric acid, and we have to see the cutoff values of serum uric acid in accordance with the serum creatinine value. Sometimes we may be requiring 24-hour uric acid excretion on purine-free diet with normal renal excretion is 600 milligram per deciliter. So when we require this, if to differentiate between either it is an overproduction or under excretion. So in purine-free diet, the normal value is 600 milligram per deciliter. Normal diet, it is less than 1 gram per deciliter, 1 gram per day. So on normal diet, the limit is 800 milligram cutoff for males and cutoff for female is 700 milligram. These levels are important when you are talking about young males, postmenopausal females, serum uric acid more than 11 milligram per deciliter, patient with gout, specifically young patients who are developing gouts, and there are family history of nephrolithiasis, family history of gout. So there you require this 24-hour uric acid excretion. This is the method. Sometimes calcium and phosphate levels are also being required, and these method of assessment are required to look for hyperparathyroidism, sarcoidosis, myeloma, and renal disease. But importantly, you have to rule out hypothyroidism. It's a very, very important factor that has to be ruled out when you are looking for serum uric acid levels. So which are the patients where you should go for the screening for asymptomatic hyperuricemia? The patient with gout, you should go look for the hyperuricemia. Also patient with having renal calculi, recurrent calculi, patient with CKD stage 3 and 4, patient on drugs known to produce asymptomatic hyperuricemia, patient receiving cancer chemotherapy, patient with metabolic syndrome, patient with cardiovascular disease. All these are the patients where screening for asymptomatic hyperuricemia is very important. Now, very pertinent question, very important question. We should know about the drugs which can produce asymptomatic hyperuricemia. Diuretics, loop diuretics, or thiazide diuretics. But thiazide diuretics like hydrochlorothiazide, if your patient is on hydrochlorothiazide and patient is developing hyperuricemia, there is no need to withdraw hydrochlorothiazide. Testosterone therapy, low dose aspirin, less than 325 milligram aspirin dose, cancer chemotherapy, nicotinic acid, antitubercular drugs, specifically ethambutol and pyrazinamide, levodopa, and immunosuppressant tacrolimus and cyclosporin, they all lead to asymptomatic hyperuricemia. Is there any link between asymptomatic hyperuricemia and cardiovascular disease? It's a very, very important and pertinent question. So, there are several epidemiological studies that have shown that there is a link between asymptomatic hyperuricemia and increased risk of cardiovascular disease and increased mortality also. Blood pressure specifically tends to have close relationship with hyperuricemia. It is also a risk factor for increased mortality in heart failure. Hyperuricemia and hypertension are very closely related, and 50 to 60% of subjects of having hyperuricemia, hypertension is present. So both are very much interlinked. And this is a word of wisdom way back in 18th and 19th century that clearly said that gout and hypertension was very well connected with each other, and this connection was very well recognized in 18th and 19th century. Now, hyperuricemia and hypertension, what are the causative pathways? There can be crystal pathway, crystal dependent pathway, and there is crystal independent pathway. But this is crystal dependent pathway is basically classical kidney pathway, deposition of urate crystal in urinary lumen leading to increased inflammation. There can be direct vascular toxicity, and due to pro-inflammatory response, there can be endothelial damage and dysfunction that can be there, and this can lead to hypertension. Crystal independent pathway, that means there is increased renin, angiotensin, aldosterone system activity, reduced endothelial nitric oxide production, upregulation of aldose pathway and polyol pathway, mitochondrial dysfunction, superoxide generation, and all these lead to endothelial dysfunction, endothelial damage, and there can be hypertension. So you can have not only onset of hypertension, not only onset of atherosclerotic cardiovascular disease, rather it is more progression of atherosclerotic cardiovascular disease that can be there, and even worsening of prognosis of cardiovascular disease can be there with hyperuricemia. But what we have learned in recent studies regarding hypertension, CVD, and hyperuricemia, it clearly indicates that and topiroxate, which are recently available. So these are the three drugs which are most commonly used. We have also uricosuric drugs like probenecid. We also have lesinurad in resistant cases, which can use. Also injectable therapy like uricase and pegloticase can be there. These are recombinant uricase enzyme or urate oxidase enzymes which are there, recombinant format. Most commonly we are using allopurinol and febuxostat. These are the molecules which are xanthine oxidase inhibitor working at allopurinol works at somewhat proximal in the pathway, whereas febuxostat is much more specific. It works only at xanthine oxidase pathway. But febuxostat, which we are using, that has got certain issues. And there was a controversy, very important controversy came out in 2018 due to this trial, that is a 4% high CV death and 32% high all-cause mortality. That was in 32-month study of case study. And that led to the black box warning regarding febuxostat, and that indicated that you have to take precautions when using febuxostat, and it is contraindicated in patient having atherosclerotic cardiovascular disease. But recently in 2021, there is a network meta-analysis of 10 randomized controlled trial, and that included more than 18,000 patients, that concluded that febuxostat is not associated with increasing risk of adverse cardiovascular events compared to allopurinol and compared to placebo also. Whether febuxostat or allopurinol reduce the risk of adverse cardiovascular events, that remains to be uncertain. This is EULAR, that is a league table of European Alliance of Association of Rheumatology, and this is a league table for febuxostat and allopurinol looking at 3-point MACE, non-fatal MI, non-fatal stroke, and CV death, and it clearly showed that there is no significant imbalance among those two drugs, febuxostat and allopurinol, for all these four adverse events versus placebo, and also in between these two drugs also. But we need much more stronger evidence to document that these molecules are absolutely safe in cardiovascular disease. Also remember, there are good number of cardiometabolic cardiometabolic drugs which have got lowering urate effect. So it's also very, very important to know about low serum uric acid efficacy of these molecules. These are angiotensin receptor blockers, losartan, calcium channel blockers, and also oral antidiabetic drugs like metformin, SGLT2 inhibitor, lipid-lowering drug like statins, fenofibrates, anorectic drug orlistat, sibutramine also, antiplatelet drug, high-dose aspirin and allopurinol. And this all indicate that when you are encountered with hypertension, coronary artery disease, atherosclerotic cardiovascular disease, stroke, or dyslipidemia, you are managing patient with serum uric acid, this is preferable option to use these type of drugs in these appropriate situations. Now, is routine testing for serum uric acid is completely in a completely asymptomatic patient is a prognostic tool or a screening for cardiometabolic risk factor? Is appropriate to look at serum uric acid as a risk factor for cardiovascular disease? No, it is not, because you have got much more potent risk factor and much more stronger risk factor are there for cardiometabolic risk, and they should be targeted, and only then you can think about factor for cardiovascular disease. So other factors like hypertension, dyslipidemia, obesity, smoking cessation, waist circumference, these are much more important targets for cardiometabolic risk. In a broader perspective, if you what is hyperuricemia? Basically, it is a marker of insulin resistance. It is all that also includes central obesity, also includes high triglycerides, low HDL, hypertension, pre-diabetes, and fatty liver. So this is a main thing which I wanted to tell you that according to cardiometabolic, think it as an insulin resistance marker. Now, is there any data to suggest reduction of serum uric acid with use of SGLT2 inhibitor is there or not? Yes, we have got EMPEROR outcome trial and also declared TB trial that clearly showed that the SGLT2 inhibitor has got uricosuric effect and they decrease serum uric acid and also gout risk also comes down. Now, does uric acid lowering therapy has any benefit in the prevention of progression of CKD? Yes. If specifically when you have got CKD stage 3 and 4 and once you have got your serum uric acid level more than 9 milligram or more than that. Now, how uric acid can damage to the kidney? It has moved from marker of kidney damage to a toxic effect for the kidneys. It leads to oxidative stress, it leads to endothelial dysfunction, it leads to increased reactive renin-angiotensin aldosterone system activity, increasing systemic and glomerular hypertension, increases ischemia, increases inflammation, increases fibrosis in interstitium, leading to interstitial injury and interstitial fibrosis. Now, importantly, the molecule febuxostat has got stabilizing effect on EGFR also, and renoprotective effect has also been eluded with febuxostat. But when you are using allopurinol, please bring down the dose of allopurinol depending upon the creatinine clearance level. That's a very excellent table which is there. If you have got normal creatinine clearance, 250 milligram per day is the dose that can be taken. But if you are having serum creatinine level going down, you can go even less than 50 to 100 milligram dose of the allopurinol that is there. So you have to modify the dose of the allopurinol depending upon the serum creatinine level. Now, coming to febuxostat, that is being preferred with CKD patient, specifically when it is CKD 3 or 4 and serum uric acid is more than 9. Febuxostat has got shown preference from, there are various trials, new flash trial, feather trial, all showed that in non-proteinuric CKD patient having EGFR of less than 60 or even up to less than 45, up to less than 30, these molecules this molecule has shown benefit in nephroprotection. Similarly, there are other trials also that FAST study also and FREE trial also indicated good safety profile of febuxostat versus allopurinol and better cardiorenal outcome of febuxostat versus allopurinol. Now, there is very pertinent question regarding food choices to decrease asymptomatic hyperuricemia. Foods rich in purine are likely to be associated with increased uric acid level. Dietary restriction should be recommended to all patients with asymptomatic hyperuricemia irrespective of symptom status. Red meat, organ meat, seafood are to be restricted, but there should not be any restriction to peas, lentils, beans, spinach, and mushroom and asparagus. No need of restriction is there. Alcohol intake has to be restricted, specifically beer intake has to be restricted. Yes, red wine can be taken, that has got certain protective effect. Intake of the food product reduces risk of asymptomatic hyperuricemia like low fat milk, cherries and coffee, they have got a protective effect against hyperuricemia. Remember, allopurinol can be toxin. It has got adverse event like Stevens-Johnson syndrome and DRESS syndrome, like drug reaction with eosinophilia and systemic symptoms that can be there, that can lead to 10% mortality. You have to, and also leukopenia. But guidelines say that you have to see HLA-B 5801 before starting allopurinol. So it's very, very important, specifically in patients with CKD. Now, what are Indian guidelines for management of asymptomatic hyperuricemia? You have patient with asymptomatic hyperuricemia, uric acid level less than 6.8, no indication for uric acid lowering therapy. Uric acid between 6.8 to 8.9. Look at the renal function. If you have got CKD stage 3, 4, start uric acid lowering therapy. Serum uric acid level, asymptomatic patient, more than 9 milligrams, start uric acid lowering therapy. Patient having normal CKD function, but recurrent renal stone, again you have to start serum uric acid lowering therapy. But no renal stone, no indication for uric acid lowering therapy. Among the choice of therapy, normal renal function, allopurinol, or you have to alter the dose of allopurinol depending upon the EGFR value. For CKD stage 3-4, febuxostat is very special drug that can be started, so you can start with 40 milligram dose. Now regarding target, it should be between 3 to 6 milligram per deciliter. Level below 3 are toxic for neurons, so neurodegenerative disorders can be there. Does asymptomatic hyperuricemia has an impact on diabetes? Regarding micro and macrovascular complication, if you look at the theory of endothelial dysfunction, insulin resistance, inflammation, it indicates it can increase micro and macrovascular complication, but we don't have strong definite evidence to implicate serum uric acid as a driver for increased micro and macrovascular complication in diabetic patient. Summarizing, no consensus on definition. Asymptomatic hyperuricemia is a biochemical abnormality and not a disease itself. Uric acid is one of the among most of the clusters of risk factor for metabolic disorder, but it may be working synergistically or not. We have to look at the very evidences. We definitely want more evidences. There is insufficient evidence on either sport to refute the use of uric acid lowering drug in these patients. Low purine diet, lifestyle changes are recommended therapeutic option. So these are the take-home messages. Short-term uric acid lowering therapy is a knee-jerk reaction. Try to avoid this. Transient correction of biochemical abnormality can be achieved, but it will not give you any clinical benefit. Unlikely to prevent crystal arthritis, cardiometabolic and renal disease. This practice needs to be stopped. Long-term has to be indefinite, but major guidelines do not endorse this approach for asymptomatic hyperuricemia. Thank you for the patience listener.
Thank you, Dr. Suri, for excellent talk. In fact, this is rather important topic because I think most of the physicians encounter asymptomatic hyperuricemia in day-to-day practice, and most of them are inclined to treat because patient comes to you, urea vada, sir. So urea, you don't know whether it is blood urea or it is uric acid. Generally, it pertains to uric.
Now, for the next recorded lecture, we have Dr. Sajid Ansari, who will be speaking on the topic microvascular angina, a diagnostic dilemma, what to do.
Hi friends, nice to see you. To manage a special entity angina in women, we know that while managing the angina, either it's obstructive, non-obstructive angina, microvascular, whatever it is, there is some differences in male and female because we know entirely if you see the anatomy of this coronary tree in the female, that is little bit thinner and more having discrete type of lesion. And entity like microvascular angina more common in the female. So that's why this need to discuss little bit separate entity, not entirely there is total differences in the female than the male. There's some minor differences there and later we will discuss it. Prevalence, we know, especially microvascular disease, angina related to it is more common in the female as male. And reason behind this is if you see some risk factor that related to female, it is the especially that is pertaining to female starting from the early life stage. They started from this use of oral contraceptive pill. That's a very important risk factor. While smoking and this alcohol, this is not very prominent in our country. Okay, all of this started because our situation is civilization going for the westernized. So smoking and this alcoholism is a definite risk factor, diabetes, chronic kidney disease. But few things pertaining that is especially needed to be considered for female, and that is a rheumatological condition that is more common in the female, and the other risk factor like postmenopausal women, eclampsia, pre-eclampsia, gestational diabetes, post-hysterectomy, when estrogen status is thin. So this is something condition where they need to pay special attention. And one thing I'll make clear, most of the time, not always, these female are having symptom of clear-cut ischemic heart disease, but when we are getting coronary angiography, most of the time there is no significant obstructive lesion coronary angiogram. But we go for the echo and TMT, definitely they are having the high feeling pressure and TMT is positive. The reason behind is the microvascular problem is a very important concern that is related to female patient. Endothelial dysfunction is a very important one. So this is a horizontal life course of women who are more prone for a premature sign of ischemic heart disease. Starting from this early childhood, genetic predisposition and teenager migraine is a risk factor. Whatever causes of vasculitis is there, we know that vasculitis and disease related to vasculitis is more common in the female. Starting from the vasculitis, there is a percentage that is correct to miscarriage, PCOS, gestational diabetes, preeclampsia, health syndrome, we know this is one definite entity. And coming to around this 40 early menopause, premature hypertension, metabolic syndrome, they're very common. Believe me, in my practice, so many female patients are them. There is a characteristic symptom that I'm having shortness of breath and chest pain. When I'm getting TMT, somehow TMT is mildly positive, but when I'm getting for the angio, the epicardial angio is normal. So what to do? Patient are telling, नहीं मुझे तो chest pain हो रहा है, मेरी सांस फूल रही. But I'm telling no, your angio is normal. So the problem is stated that when you go for the echo patient, you go for the stress, diastolic stress test, they are definitely having high feeling pressure and they are having microvascular disease. And so that's why especially type 1 disease is the, around the 50 is the more common in the female as compared to the male. Coming to clinical presentation, friends, presentation of symptom is almost nearly same for male and the female. This need to discriminate. Usually, the female symptom is very non-specific because functional component the female is more. But believe me, never you mention anyone patient that you are a functional unless your diagnosis should be excluded. So, started from chronic stable anemia. What is the characteristic is either male or female? Typically, I am normal on the level, but now we are going to work and for stressful activity, I am having shortness of breath and chest pain, and that is quite subsided when I am going to rest. Same is true with the female, but there is some atypical symptom is there, and chest pain, gastric pain, burning pain, feeling of like gaseous tendency, and this is true that in the OPD sometimes we are really fighting with the patient. They are telling, "Nahi, hame to gas chada," and now we are telling, "No, that you are not absolutely true." When going for the interrogate the patient, they are having cardiac issue. Other symptoms include like chest pain, unusual fatigue, shortness of breath, lower jaw pain, shoulder. Sometimes, there are other causes of chest pain that should be excluded, and that is very common until you are going to expose the patient like herpes zoster like this and this. There are characteristic presents with chest pain of the angina like this. Sometimes syncope and near syncope dizziness is the concern that should be seen in the female patient. Coming to classification angina with this female specific aspect, we know that there is some typical and atypical symptom. But while doing the clinical practice, we can't go like 1, 2, 3, 4, 5, 6. We know that they are coming to angina, just syndrotic angina, radiation of pain to the left arm, joint, here and there. So dyspnea and exertion, mental stress is extreme tiredness is important because some atypical pain is there. Both typical and atypical should be kept in the consideration for diagnosis, and be aware that whenever you're diagnosing is chest pain angina, this anxiety is a very important component in the female. We know very simple female coming the anxiety, they're finding sinus tachycardia, and we know that sometimes embolism is always having a sinus tachycardia. So anxiety component should be always excluded while dealing with the female patient. This is a very important one, PPT, that shows what is some distinctive pattern of ischemic heart disease in female. If you see the anatomy and caliber of the coronary tree in the both male and female, let us you see there are 2, 3 things are important. That smaller diameter of coronary arteries in the female pattern of disease, less stenosis epicardial arteries, and usually this minoca and this type of things is more common in the female. Diffuse pattern of atherosclerosis, less calcification. Usually when you are getting this CT angio for this patient, usually calcium score is not going very high as compared to male subset of patient. More vascular dysfunction, that's why, and also after PCI and CABG and clinical prognosis is not better. Reason behind this is artery of caliber is the poor and diffuse lesion. I'm meant focusing on the vascular dysfunction, and that is usually omitted in the clinical practice. Meaning you go, your ECG is normal, echo is looking normal, angio is normal. Whatever you have, you go out, you don't have cardiac problem. No, never you say like think always while dealing with a female patient that you might microvascular angina, and microvascular angina need to be treated. Because when you need to diagnose this microvascular dysfunction, this need battery of investigation and expensive material, and ultimately story is the same. So in my practice, I never go for such battery of investigation for the undue expense to patient. This is a clinical diagnosis. Pay your clinical attention and diagnose microvascular dysfunction is the important one. So coming to same thing, microvascular angina, what I was discussing. So these are what happened when you normal coronary filling is there in the diastole, and when there is increase in left ventricular diastolic pressure because of obesity, metabolic syndrome, diabetes, hypertension, so and so. So ultimately that is reflected in the microvascular vasculature also. So woman is sign and symptom of ischemia, no obstructive coronary artery disease, impaired microvascular circulation, and impaired coronary epicardial coronary constriction. This ultimately lead to symptoms related to angina, unstable angina, angina, and excess and shortness of breath, squeezing, like this, and frying occurrence of cardiovascular events. And there's a trial, even the patient is having non-obstructive CAD, we can't make it like that. Their mortality and morbidity is less as compared to. I will be in the subsequent slide and by these trials. So coming to prognosis, the woman with this microvascular disease, and there is a very important wide study, woman ischemia syndrome evaluation, and that make a real difference that why we ignoring this microvascular dysfunction in the female. So treatment of chronic microvascular dysfunction, that Inoka, whatever you say, myocardial infarction in non-obstructive coronary artery disease, patient coming with this symptom, you go for this diagnostic testing. Basic is the EC. Usually, juvenile pattern, female pattern of T15 in the female. So need to be excluded, and that should be done by some history, either ECG or echo. Usually, echo when patient is the transfer CT, echo is normal. Even a normal in the sense systolic function is normal, but when you closely evaluate the patient diastolic function, the filling parameter definitely high. What we call E by E prime by transmitral tissue Doppler velocity. This is the high. And after that, if needed, patient subjected for this some intervention. This is subject to depend on this risk factor and requirement of patient who need for CT angio and we need for cath lab angiography. Coming to whatever the diagnosis is there and patient is in front of your treatment part is the important one. So while treating the angina, we started from some antiplatelets or statins or some vasculoprotective medicine is needed, and after that we know 3-4 group of medicine is there when the beta blocker that have definitely advantage for this reduction in this mortality benefit with this all kind of patient with either angina, unstable angina, or heart failure. Then ranolazine, imipridine is there, enhanced vasoconstriction is there. Then you go for CCB and nitrate. If need both impaired vasodilation and enhanced vasoconstriction, combined therapy is there. If there is no abnormal assurance. But in my clinical practice, what I am doing, if my diagnosis is microvascular angina, I am very honest, and this is work in my clinical practice. I will share very honestly on this forum. Metabolic modulator has a very special role in female patient that having improvement definitely symptom of this stressful angina and exertion, microvascular dysfunction, shortness of breath. So I am using here and there this metabolic modulator. Of course, I am using this beta blocker, calcium channel blocker, ranolazine subset of percentage having diabetes, especially because we know that by using ranolazine, by Carissa and Meister trial, this has improved the angina on exertion and reduced the dose of nitrates. Ultimately, sometimes if you are not able to control well with this medical treatment, this need to PCI patient, we are subjecting patient to angioplasty. And if you compare the data from the main post PCI, This is some, as we discussed, why not with that female coronary artery having this some tortuous, and diffuse atherosclerotic pattern. And we know normal coronary artery diameter is 3 to 4, and sometimes in the bigger in the LED, and some it is around 5. So, but if you see the female pattern of disease, this is usually some narrowing is there in the female subset of patients. So, what is the result of PCI? So, even post PCI and using the drug-eluting stent in the female, and patient going for the early revascularization and complex percutaneous coronary artery revascularization and angioplasty. So I will share. They have not given me the PPT, but I will share my experience. Even after post angioplasty in the female patient, issue symptom related to angina is more typically persisting. Even after the post angioplasty, if your TEMI flow is well established post angioplasty, even then because of this microvascular dysfunction is persisting, and usually is in turn converted into symptom of frank ischemia and angina. And so even a post PCI with the drug-eluting stent, complication is not going to reduce, in fact, through and through. So new generation drug-eluting stent in the women undergoing complex percutaneous coronary artery revascularization need to address, not only depend on this angioplasty is finished, everything is finished, need to address their symptom and how to relieve the symptom. So I think I finished my talk with due time, whatever time was allotted for me. You are welcome for any comments and questions. So my last word, management of angina in the female is not ultimately you are dealing with the obstruction in coronary artery disease. We need to treat the symptom of angina. So that's better to say ischemic heart disease, because of microvascular problem, increase filling pressure, increase epicardial pad effect, so many risk factors there with the female. Thank you. This all from my side. Welcome from the comment and question. Thank you.
Thank you, Dr. Sajid, for enlightening us for a rather new upcoming subject, that there is a gender difference in shown, that it is difference between male and female.
Thank you, sir. Next, we have the recorded lecture of Dr. Bimal K. Agarwal, Principal and Professor Medicine, Institute of Medical Sciences and Research, Maharishi Markandeshwar, Deemed University, Mulana, Ambala, with the topic Frailty in Older People.
Respected chairpersons, my senior colleagues, and dear friends, I am Dr. B.K. Agrawal from University, Mulana. I will be speaking on the topic frailty in the older people. Before I begin my topic, I want to thank Dr. Vitul Gupta, the chairman of APA Malwa branch and the organizing secretary of this conference. He has been organizing this conference for last several years, and it is a boon for the PG students and general practitioners of the region. I am thankful to him for providing me this opportunity. Medical science has advanced so much that people are living up to old age, but taking care of their health is a big challenge. All the people in old age are not equal. Some are quite fit, but some are not so. Chronological age is not sufficient for risk profiling. Sometimes it does not match with the biological age. Frailty is such a vulnerable group of people in old age. We'll have to focus and we'll have to redefine the goal of healthcare in them. This was a study published in journal Chest in 2021. It showed that those who were frail before getting admitted to ICU and who required ventilation, about 25% of them were only surviving after 1 year. So such is the poor outcome in people, those who are frail and old. So frailty outcome, any stress or surgery or illness, there is fast deterioration of health, prognosis is poor. Diagnosing and detecting earlier will help rehabilitation, improving physiological reserve, and reversing or improving the level of quality. So this was a study which showed that those who were old and frail and required surgery, the post-op complications were higher and mortality was high. And with rehabilitation like nutrition, exercise, reducing anxiety, will improve the outcome of surgery in such patients. So what is frailty? Frailty is a syndrome with declining function of various bodily systems or organs and reduced physiological reserve, making the person vulnerable, and a stress or small insult can result in dramatic decline in health status. The person who was mobile before can become immobile, become dependent on others, and who was stable may develop falls, and who is mentally lucid may become delirious. The pathophysiology of this frailty is not well understood, but the hypothesis says probably the inflammatory cytokines like C-reactive proteins, interleukin-6, TNF-alpha are increased, and there is impaired regulation of neuroendocrine hormones. There is increased cortisol, decrease in the growth hormone, testosterone, IGF-1, and dehydroepiandrosterone sulfate. Moreover, the vitamin D level has been found to be low in frail people. What it does is there occurs sarcopenia, osteopenia, anorexia, decreased immunity, decreased cognition, and is prone to thrombus formation, and there is impaired glucose metabolism. The same thing I have given in graphical form. What it will result in is there will be slowness, weakness, weight loss, low activity, fatigue. Sarcopenia is one of the important parameters in such individuals. There is loss of muscle mass and strength with corresponding loss of physical function. It occurs with age, but it is not inevitable. Sarcopenia may not be seen in old people, but diseases like heart failure, COPD, cirrhosis, cancer, and end-stage renal disease, sarcopenia is quite common, and it is cytokine mediated. So how to diagnose who have frailty? There are various tools available, phenotype model, frailty index, clinical frailty scale, FAIL scale. I'll be discussing about them a little more. So this is another commonly used tool, this Fried frailty tool or physical frailty. In this, there are 5 parameters. Unintentional weight loss, if it is more than 5% last 1 year. Self-reported exhaustion, like person who was doing an activity earlier has stopped doing so. The person is so exhausted, feels so exhausted. Weakness, grip strength is weak. It is reduced to 29 to 32 kg in males and 70 to 21 kg in females. This range is depending on the BMI of the individual. Slow walking speeds, taking more than 7 seconds or 8 seconds to walk 15 feet, and decreased energy expenditure in leisure time activity. So low as per week, the kilocalorie spent is less than 383 in males and less than 217 in females. So based on these parameters, we can divide the individual into robust or pre-frail or frail. Robust, they're quite fit, the score is 0. Those with 1 or 2 score are pre-frail. If the 3 or more than 3 out of 5 domains are present, then we call it frail. And some studies now have added 2 or more elements. It is modified into cognitive frailty and depression have been added. Cognitive frailty is subjective cognitive decline. We have seen the patient, they come to us with a complaint of decreased memory, but they are normal while cognitive testing. But they may progress to mild cognitive impairment. And depression are the common association with frailty and depression. This study, relationship between depression and frailty in older adults, it showed that 38% of frail people are depressed and about 40% of depressed people have frailty. So they're so much closely associated. But one thing to realize here is depression is a modifiable factor. If we can manage depression in those individuals, we can seek their participation in intervention, like we can improve the dietary intake, we can improve the exercise and physical activity, and the frailty can be improved. Accumulation deficit of frailty index. All people in the old age are not frail. Some people will have health deficit, and as the age progresses, they may acquire more organ dysfunction, And depending on the counts of disease condition and comorbidity present or social situation, like some people may not have so much facility at home to take care of old people. So depending on that, what are the factors, it is tabulated and calculated a ratio of present deficit to pool of clinically relevant domain. Initially, there were 92 domains analyzed, but now it is reduced to 30, and further studies are being done with lesser number of domains being analyzed. FAIL scale is one of the rapid screening tool. It will take only few minutes to analyze. Fatigue, resistance, ambulation, illnesses, loss of weight. Fatigue, have you felt fatigued all the time or most of the time in last 1 month? If it is yes, score is 1. Resistance, difficulty climbing a flight of stairs. Ambulation, difficulty walking 1 block or walking several hundred yards. Illnesses, do you have any of these illnesses? There are 11 illnesses present, and if more than 5 illness present, score is 1. If less than 5 illness, score is 0. The illnesses are hypertension, diabetes, chronic lung disease, heart attack, congestive cardiac failure, angina, asthma, arthritis, stroke, CKD, cancer. Loss of weight, more than 5% last 1 year. Then the score is 1. So out of these 5 score, as earlier in the FRAD phenotype tool, if the score is 0, the person is quite fit. Score 1 to 2 is pre-frail, and score 3 or more, it is frail. And now this is clinical frailty scale. There are 1 to 9 from the physical functioning, or from a look you can identify the level of frailty. Scale 1, the person is quite fit. I'll not go into details of this, but let us take this 3. The patient is managing well. People whose medical problems are well controlled, even if occasionally symptomatic, but who often are not regularly active beyond routine walking. And 9 is patient is terminally ill. 7 is living with severe frailty. They're completely dependent on others even for personal care. So epidemiology, frailty is more common in female. Age is no bar, it can occur in any age, but in age group more than 65, it is more common. Prevalence. A Canadian study done in community dwellers showed that it was done based on the phenotype scaling. In the age group 50 to 64, the prevalence was 7%. More than 65 years, the prevalence was 7.8%. An adult study done in hospitalized patients in age group more than 60, it showed the prevalence can be as high as 18%. So what are the risk factors of frailty? Increasing age, polypharmacy. Polypharmacy may also mean the patient may have multiple illnesses. Loss of regular exercise, poor nutrition status or weight loss, cognitive decline, medical comorbidities, and psychological comorbidities. These people are more likely to develop frailty. What are the warning signs? If these signs are present, then maybe we can have a closer look of the patient and find out if the frailty is present. One is unintentional weight loss, like the patient is not over-exercising or not dieting to reduce body weight. Patient has incontinence, history of delirium or dementia, declining functional status. Any patient who had a recent falls is a risk factor. We should look for where patient is frailty so that further falls can be prevented. Patient developing medicine side effects, loss of appetite, sarcopenia, social isolation, irrational fears, or irregular sleep. Assessment and diagnosis of frailty. Some of the tools I told you, without further assessment, you can make a diagnosis the patient is frailty, but patient can be assessed with these factors like walking speed, if less than 0.8 meters per second, time get up and go test requiring more than 10 seconds. I will come to this in the next slide. Weakness measured by grip strength. So this is time get up and go test as per the British Columbia guidelines. If it takes more than 10 seconds, then probably frailty is present. In this test, the patient is sitting on a chair, asked to get up and walk at his or her normal pace, walk for 3 meters, turn around and come back and sit down. And if this whole process takes more than 10 seconds, then probably frailty is present. And this is handheld dynamometer. The patient holds it with the dominant hand, elbow flexed at 90 degree, and the person is asked to squeeze it as tightly as possible without giving jerks. Hold it for a few seconds and release. 3 such readings are taken and take the average of them. So once we have diagnosed the patient as frailty, can we do something about it? Yes, there is management. We should not give up on such individuals. One important thing is it can be reversed or improved with treatment. Adequate nutrition with adequate protein intake, exercise, all types, aerobics like walking, jogging, resistance like pushing against the wall, stretching. Vitamin D, if there is deficiency of vitamin D, it should be supplemented. Reduction of polypharmacy, management of diseases that may accelerate frailty like heart failure, hemodialysis, etc. And resetting the goal of considering the frailty status. I'll come to this in a couple of minutes. This study adherence to Mediterranean diet reduces incident frailty risk. This diet is minimally processed fruits, vegetables, cereals, beans, seeds. So taking such a diet, the frailty incidence can be reduced. Some basics of nutrition. If the patient is not eating well, look for any difficulty in chewing or swallowing. If it is so, take care of them. Depressed people do not eat well. So take care of depression. If it is present, some from the person, and because the nutritional status may not be maintained, and if the we have been patient is taking low salt or low fat or low sweet because of some disease condition, but if the patient not eating well, then it's better to relax these restrictions so that patient can eat at least some food. Meta-analysis showed that there is reduction in false vitamin D supplementation, and it should be supplemented only if the vitamin D level is less than 20 nanogram per ml. So how to reduce the number of pills the patient is taking? Medications to be reviewed and reconciled if the patient has more than one chronic disease, had significant adverse drug events, taking antipsychotics or opioids. Antipsychotics should be given the lowest effective dose for the minimum possible period. If the patient is been recently discharged from the hospital, then take a look of the drug he is taking, because sometimes the drug is started in the hospital and the patient continues to take it for a long time. Recent change in health status has multiple prescribers. If there are 2-3 doctors involved in taking care of the patient, sometimes the same medicine is prescribed by all the doctors. Take for example the PPIs or some vitamin B complex. So you can reduce the number of pills the patient is taking by collating all the drugs. If the patient is taking some medications which require lab monitoring, like PTI is done when the patient takes warfarin, or we look for potassium level if the patient is taking ARBs or ACE inhibitors. So these drugs should be reviewed very frequently. And wherever possible, implement non-pharmacological methods like quadriceps exercise for osteoarthritis. The patient may be old, may have APD, may have CKD. So instead of prescribing non-steroidal anti-inflammatory drugs, prescribe paracetamol and advise quadriceps exercise. So this is about the exercise I was talking, like even the patient is not able to walk around or patient is only lying down in bed, even in then some amount of exercise can be done whatever is possible, like simply moving the hands or legs, lifting hands, or putting the legs in the air and doing cyclings. This is strength exercise or toe stand. The person is standing behind a sturdy chair. Patient is asked to stand on toes, wait for a few seconds and come down. Such things are repeated 10 to 15 times. And if the patient is doing comfortably, then maybe it can be modified. You can ask the patient to stand on one leg and then the other. This will strengthen the calf muscles and ankle so that risk of fall can be reduced. So some basics of exercise in old and frail. The dictum is start low and go slow. If the person is not doing any exercise, you should slowly build up. Walking for as little as 5 minutes twice daily may be useful as a beginning point. Functional exercises like getting up from a chair, walking few yards, coming back and sitting down. Such exercises may be useful. Muscle strengthening. Start with a weight that can be lifted 8 times before muscle fatigue occurs. Lift while exhalation. Take 2-3 seconds to lift. Hold for a second and come down in 3 to 4 seconds. Breathing should be normal during all these activity. Practice till able to do 10 to 15 times easily. Then you can increase the weight. So this will build up the muscle, but protein intake should be adequate. So study has shown that multi-dimensional interventions like nutrition, physical activity, cognitive exercises, and combination of these. With these, we can improve the frailty score and we can reverse it as well. So resetting the goals of certain diseases, like suppose the patient diabetes or hypertension, how strict we should be in controlling blood sugar and controlling blood pressure if they're old and frail. Of course, there is trade-off between the risk of vascular events and the risk of fall. So this was an editorial published in the journal Hypertension in January 22. How low should we go in the presence of frailty? We remember JNC 8. It said that in the age group below 60, the BP target should be 140 by 90. In the age group more than 60, it should be 150 by 90. And it generated a lot of discussion and a lot of controversy around it. And it was rightly so. Simply based on the age, we cannot set the BP target. This editorial comment was based on a study published in the same issue of the journal. It was a study done in Germany in community setting in old people. They found that those who were old but not frail, the mortality was lowest in the systolic blood pressure 130. But who were old and frail, the mortality reduced as the systolic blood pressure increased, and it was the lowest in the blood pressure more than 160. So there is no such guidelines what is your target, but you can have now fair idea how you can individualize the treatment of your patients. So diabetes and frailty. Now we know there is glycemic targets are different for different groups of people. So those who are old, HbA1c of 7.5 to 8 may be good enough. And those who are old and frail and have dementia, life expectancy reduced, then maybe the A1C target of 7.8 to 9% may be appropriate. So to summarize, people in old age are not equal. Some are quite fit, some are not so fit. Older people with frailty have poor physiological reserve and acutely deteriorate with minor stress or injury or surgery infection. It carries poor prognosis. Identification of frailty can help better manage this population with setting goals. Rehabilitation before surgery can be offered and the post-op outcome can be improved. Interventions like nutrition, exercise will help in improving the frailty score. And what is most important is frailty is dynamic. It can improve, it can be worse. and it can be improved with intervention. Thank you.
Thank you, Dr. B.K. Agarwal, for this enlightening talk, because again, this topic gains importance as life and increasing incidence of frailty also.
Senior Consultant, Medical and Hematology Oncology, AGI Gastro City, Orison Hospital, Ludhiana, who will be presenting on the topic Clinical Interpretation of CBC.
This topic is very, very important. We consider CBC in each and every investigation on the top. And I think more
to be on such an august platform of MAPICON, the Malwa Belt. My first love was medicine, actually was not medical oncology. But during the course of my journey, I developed my second love with chemotherapies and hematology. So that is the reason I became a hematologist, a hemato-oncologist. Doctors as such are the best brains in this world, on this globe. And I feel in generation, we can help more people, we can help more patients to come out of their problems, of their sorrows. We all know that Punjab is burning in the grip of cancer, and there has been a lot of progress which has been made in chemotherapy and cancer as such, that patients of cancer, as of now, they live long, they live happily, and they enjoy a good quality of life. The reason for a dramatic change, the reason for a dramatic improvement in the results of cancer are a team effort. No single doctor, no single person can achieve results without a whole sum of a bouquet of flowers. We can achieve, which we thought was impossible, we can achieve that thing also as possible. But you need to have faith on each other. The biggest issue is you need to have faith on one another. You need to have faith on the team members. And not only the team members, but we should learn from our mistakes. I have learned a lot of things from my mistakes. I do make mistakes, even now I make mistakes, but I try to improve, I try to learn from my mistakes. And the mistakes which I made me this presentation as how to read CBC, how to interpret, how to read CBC in a very practical way. This is the cohort of patients which we as physicians usually see. If we have Dr. Gupta doing his OPD daily, I think this is the cohort of find out in a rushy OPD, in a heavy OPD, that in that heavy OPD, can we spot that which were those patients which might have cancer, That's very important, because you people as physicians are more trained. You people as physicians are more polished to treat diabetes, to treat hypertension, to treat asthma, to treat stroke. I'm not that polished. I'm polished to treat cancer patients. But that bigger cohort, that bigger funnel, which are coming in your routine day-to-day OPDs. Like watchdogs, we need to be very, very cautious. And because if you detect early cancer at an early stage, you can cure that cancer and rest and relax for your whole lifetime. Because cancer means you can survive. But we hardly make any mistakes which is grossly visible. If any patient coming to us with an ulcerative lesion of breast, it is visible that that patient is having a breast cancer. If a patient is coming with a big lump in the breast, we don't make any mistake. Yes, obviously the patient might be suffering from a breast abscess or a breast carcinoma. What really matters, what actually matters is very small common misses in our daily OPDs. Very, very small misses. And that took me to make my onco tip as physicians
deal almost daily. A chronic low backache since 4 months, 5 months, 6 months, and the patient is walking in, and we are again and again, again and again thinking a disc prolapse, or a sciatica, or a trauma, or osteoporosis, or osteopenia. In such kind of patients, I say the first investigation of choice is CBC. I call CBC as FIR, the first information report of any patient. FIR of any patient is the first CBC which the patient lands up with you in either your clinic or in your hospital. So the CBC of this patient was done, and HB turned out to be 4. This patient, a chronic low backache, elderly patient, CBC of 4. When I did a peripheral blood film, I thought it is normal. This is my honest acknowledgement, my honest saying, I thought this peripheral blood film is normal. But I took it normal. Every person is sitting separately. Similarly, in a normal PBF, in a normal peripheral blood, each red blood cell should be seen singly, lying singly. But the PBF which I was seeing, the red blood cells were lying one upon the another, just as the books are lying one upon another, and this is called rouleau formation. So if any pathologist writes in a PBF report that rouleau formation is seen, please take it seriously. Please take it very, very seriously, because rouleau is not normal. Okay, this was the first mistake which I did and I learned. This is the mechanism of rouleau formation. The red blood cells, they stack one upon each other. ESR of this patient was 120. So backache, high ESR with anemia, with rouleau formation, the next investigation of choice is obviously a bone marrow. If anemia is present, elderly patient, please think of multiple myeloma. If rouleau is present in an elderly patient, please think of myeloma in chronic low backaches. Please think of multiple myeloma if you have lytic lesions, if you have punched out lesions on an X-ray skull. And please think of myeloma if ESR is more than 100. And the function of myeloma cells is to generate antibodies. The function of myeloma cells is to generate antibodies. There are 5 kinds of antibodies which we have: IgG, IgM, IgA, IgD, IgE. So we need to get serum electrophoresis, that which Ig is being secreted by those neoplastic cells. This is called an M spike. If you see the normal electrophoresis, there is no M spike, meaning by there is no production of cancer, a cancer spike or an M band is present in electrophoresis. So if I recollect all this, there's a very interesting acronym called CRAB. For C stands is hypercalcemia, R is renal failure, A is anemia, and B is bony lytic lesions. This whole fits into a patient of multiple myeloma. So any patient having anemia, rouleau formation, skeletal lesions, ESR raised, a monoclonal antibodies, please think of multiple myeloma. Because the treatment of multiple myeloma has changed a lot. If any gynecologist is sitting here, she can appreciate that these babies don't have any limbs. So there was a drug called thalidomide which caused phocomelia, and this was, let's be a little fast to, next patient was, so we started with an HB, we did a CBC, we found out rouleau formation, and the story started with just a simple CBC, and we moved to multiple myeloma. Similar patient, a chronic low backache, male, came to us and X-ray hip was done, which showed osteoblastic metastasis. Simple X-ray which is available even in the remotest area of Punjab. We don't need a PET scan, we don't need an MRI, we don't need anything, we don't need CT scans, we just need a simple X-ray scan. And a simple X-ray, if the patient is having osteoblastic lesions, please think of prostatic rush for MRIs, PET scan, CT scan. These are simple. Another patient came to us with 35 years old female with pallor, with no lymphadenopathy. HB was 4, MCV was 42, mean corpuscular volume was 42, it's very low. Normal volume of the one blood cell is around 80 femtoliters. MCV, MCH, MCHC, it just gives how many hemoglobin you have in your red blood cell. All was lost that patient, but we were wrong. The patient was bleeding from a stomach cancer, a small drip by drip, drop by drop, drop by drop. Blood was oozing from her ulceroproliferative growth in the stomach, causing chronic anemia. So again, the onco tips and tricks which I made from this point is that please think of carcinoma stomach in unexplained microcytic hypochromic anemias. Please think of colonic cancers. Any cancer, any growth can be present in the cecum, ascending colon, hepatic flexure, or a transverse colon, or a descending colon. That growth can bleed, small bleed can occur and giving rise to chronic unexplained anemias. So any patient coming to you, elderly patient with chronic unexplained anemia, everything is better in the modern era, giving rise to more hopeful results. And if we see in the modern times, this is the before chemotherapy, this after chemotherapy, the tumor has almost vanished away. So we started with CBC, an old patient with a low HB, and we reached to CA colon. This was an elderly patient with a huge spleen. When CBC was done, HB was 8, TLC was 100. 100 is nothing. TLC was 100, platelet was again low. So HB low, TLC low, platelet low. So it's a case of pancytopenia, elderly patient, pancytopenia with a big spleen, And this is a classical case of hairy cell leukemia. This picture, this is a classical scenario of hairy cell leukemia because hairy cell leukemia has 90% cure rates. 90% cure rates. So any patient having pancytopenia, elderly with a big spleen, please think of hairy cell leukemia. This another patient came to us with gangrene of the fingertips. When we did the CBC, I'm very fond of doing CBCs. I'm very fond of interpreting CBCs. HB was 8, TLC was 13,000, platelets were 17 lakhs. 17 lakhs. We repeated the next day, the platelets came out to be 22 lakhs. And this was actually a case of, and yeah, important point was the peripheral smear showed 4 nucleated cells per 100 WBCs. This was a classical case of essential thrombocytosis in which the platelets were very high, which can cause a gangrene. This was another patient came to us, a female pure vegetarian with anemia, platelet of 88,000, HB of 7, but MCV was 114. Normal MCV is the volume of one single red blood cell is about 80 femtoliters. In this case, the MCV was 114, meaning by you have big red blood cells. You have big red blood cells. Anything big in medicine is called macro. So you have macrocytosis. So it's a very simple case. The PBF was done, and this was a neutrophil, which I again took it normal. My pathologist taught me. She said this neutrophil has 7 to 8 lobes. Normal neutrophil will never have lobes more than 3. So this is called hypersegmented neutrophils. Any pathologist writing hypersegmented neutrophil, take it seriously, right? It means the patient is having megaloblastic anemia. So this was a simple case of megaloblastic anemia in which there are big red blood cells, hypersegmentation of neutrophils, but the underlying cause in this case, the patient had an MDS, myelodysplastic syndrome. So please think of MDS in unexplained megaloblastic anemias. So again, we start with CBC and we reach to MDS. This is a very interesting case. I learned a lot from this patient, a young female with fever, generalized lymphadenopathy, with gum hyperplasia. HV was 8, TLC was 6.8, platelet was 159. Apparently, there's no reason to suspect anything except for anemia. So when I started my practice or when I started my clinics even, I never used to see below the CBCs. I never used to see the graphs. The first graph, the second graph, the third graph, I never used to see. I'm committing my faults, but I think it's a common house. I can do it. I never used to see this. So I made mistakes. I learned. I polished myself. I repolished myself. So after that, I'm standing in front of your good self today. The lesson learned from this CBC was that please see the graphs. Please see the graphs below the CBCs. It was the biggest mistake of my life. These are called WBC flag. The flag on the right side is a normal flag. On the x-axis is the diameter of the white blood cells. Normally we have if you see the white blood cell, it has again differential leukocyte count. You have neutrophils, you have monocytes, you have eosinophils, you have basophils. The first spike is of lymphocytes. The first spike is of lymphocytes. The second spike is of eosinophil, basophils, monocytes. But in the patient in question, the patient has only first spike. The patient doesn't have a second spike. The patient has just a single spike, meaning by the patient has only lymphocytes, no neutrophils, no monocytes, no eosinophils, only lymphocytes. So the patient was investigated in detail further and found to have acute lymphoblastic leukemia, in which the peripheral blood was full of lymphoblasts, and lymphoblasts. There was not a single neutrophil, not a single eosinophil, not a single basophil. So I learned from this mistake that yes, in every case of CBC, please look at the graphs, the WBC flags. So again, leukemia has a lot of improvement in the treatment part, and we started with CBC and we diagnosed acute lymphoblastic leukemia. We suspected leukemia on that simple CBC. So I'm not going to the treatment part. It has gone away, change, again improvements are there. So success story in deadly leukemias are again there, that there's a lot of improvement in leukemias. We have good results. Yeah, this is a very interesting case for physicians. Very, 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 very interesting case. 30 years female, 35 years female, male, female, young adult, 40 years. Usually come to your OPDs with a big spleen and a high TLC. High TLC of 1 lakh, 59,000, 60,000, 70,000, 78,000, 2 lakhs, 2.5 lakhs. At very first instance, we as physicians think the TLC is so much, 1 lakh TLC. हम एकदम पेशेंट की तरफ देखते हैं, यार तू ठीक तो है ना, फीवर वीवर तो नहीं है तेरे को, शॉक में तो नहीं है, because it's a reaction of us as doctors. A TLC of 2 lakhs and patient is coming walking to us. This is not possible. Man, this is not possible. What's happening? So the first reaction of us is to repeat a CBC, to repeat the counts. So we ask our lab technician, yaar iske count repeat kar do. So we get a phone after 1 hour, sir, again the TLC is 2.5 lakhs. Come on, yeah, this is not fair. Okay. Then we ask our pathologist, okay, you do the PBF. So the pathologist comes with a PBF and says, sir, in the peripheral blood film, you have neutrophils, myelocytes, metamyelocytes, basophil. These are the words which are very, very common to a pathologist and a physician. What are metamyelocytes? What are myelocytes? These are the babies of neutrophils. These are immature neutrophils. These are immature neutrophils, myelocytes, metamyelocytes. These are not normal neutrophils. So, as a, जैसे हम लोग हम कभी भी अपने बच्चों को we will never send our kids to fight on road. Similarly, the bone marrow will never send the babies of neutrophils to fight infections. कभी भी नहीं भेजेगी. Bone marrow will never send myelocytes, metamyelocytes in the peripheral blood to fight infections. It means there's something serious. The marrow is under stress. The bone marrow is under stress. In such cases, please remember any patient with a very high count, normal platelets, normal HB or a very low HB, very high TLC, and if you see the precursors of neutrophils and with a big spleen, the first diagnosis which come in our mind is chronic myeloid leukemia, CML. It's very, very common entity, very, very common entity, chronic myeloid leukemia. So the oncotip was that we started with CBC, we got shocked to see the TLC of 1 lakh, 1.5 lakh, 2 lakhs, but we concluded just on a simple peripheral blood film that the patient is having CML. CML in very shortly was a deadly disease when I was doing my MD medicine. I did my MD medicine in 93. It was a deadly disease. We have interferons at that point of time, but now it is curable. It's unbelievable survival. Patients of chronic myeloid leukemia have an unbelievable survival, meaning by they have a normal lifespan. So how was this possible? It is possible because of, if you understand the genetics of CML, this is a beautiful DNA of which we all are made up of. If we dissect this DNA further, there's a chromosome called 9 and there's a chromosome called 22. मैं इसको ऐसे बताता हूँ कि there are two boys in a class. There's a class of UKG in a school. Roll number 9 and roll number 22 दोनों की दोस्ती हो जाती है. तो दोनों रिसेस में अपना खाना शेयर करते हैं. They share their tiffin. Roll number 9 and roll number 22 वो अपना खाना उसको देता है, वो उसको देता है, and they enjoy. This usually happens in almost all schools. इसी तरह ही chromosome 9 exchanges a material with chromosome 22 and chromosome 22 shares a material with chromosome 9. स्कूल में तो उनकी दोस्ती हो गई, लेकिन इधर जब मटेरियल शेयर करते हैं, when they exchange materials, ultimately it creates a havoc. After sharing the material, BCR comes in close with ABL. BCR is a gene, ABL is a gene. So BCR-ABL becomes a fusion gene. If there's a gene, it will cause a protein. So the protein which is caused by BCR-ABL is called a BCR-ABL protein, which is a tyrosine kinase. It's an enzyme. Normally what happens is, the ATP fits into the BCR-ABL tyrosine kinase, starts a signal and gives a signal to the marrow to produce WBCs unendingly. Don't stop. Go on producing WBCs, 50,000, 60,000, 1 lakh, 1.5 lakh, 2 lakhs, 2.5 lakhs, 3.5 lakh, 4 lakh. Marrow बंद नहीं होगी. Bone marrow का वो message बंद नहीं होगा because BCR-ABL signaling is continuous. So now just think that I am saying the patients are treated lifelong, they are cured. So how is this possible? It is possible because of a drug called imatinib. Just see what happens. Instead of ATP fitting into BCR-ABL, imatinib fits. Imatinib fits and ATP cannot fit. So the signaling is stopped. It's so simple, it's magic. It's so simple, it's simple magic. And you are cured of CML. And this whole magic was developed by this person. This called, he is Dr. Brian Drucker, who developed this whole, who invented imatinib and created a success story for CML patients. And today is 16 September. 22nd September, about a week ago, about a week forward, it's a World CML Day. Because 22nd 9, there's a chromosomal translocation between 9 and 22. So in the whole world, 22nd September is celebrated as World CML Day. So that's why I just put a little more slides on it. So this was Philadelphia, the place where Philadelphia chromosome was diagnosed. So he's the brain behind imatinib. So the whole success, the mantra is it's a teamwork. We have to be together. We have to trust. I have to trust my pathologist. I have to learn from a pathologist. I have to learn from a laboratory technician. I have to learn from my patients. I have to learn from everything. So we started with CBC, ultimately found out acute lymphoblastic leukemia. We found out CML. We found out anemias. We found out GA malignancies. We found out myelofibrosis. We found out hairy cell leukemia. Thank you so much for the patient hearing. Thank you, sir.
Thank you very much. I must compliment you for your lecture, for your speech, as well as for your presentation. Excellent presentation.
Thank you, sir.
And very informative. Again, teamwork is the sense of all the activities.
Yes, sir.
So what you have stressed. Thank you very much, sir.
Thank you,
Thank
sir.
you.
And I again say my first love is medicine. Thank you, physicians.
Thank you. So with this, we are coming to close the second day's